have the different MDS subtypes, which are mainly morphologic, and I just want to emphasize that there's only one genetically defined subtype in the 2017 classification, which is the isolated deletion 5q MDS. The others are all defined by ring sideroblasts, how many dysplastic lineages, or the percentage of blasts. So in 2023, this shows the current classifications, the ICC and WHO side by side with the 2017 WHO equivalents. And as you can see, we have some all shown in red. The WHO has introduced some morphologic entities, but in general there's concordance between, and there's some new names of them, low blast versus NOS in WHO and ICC, and excess versus increased blasts. But overall there is a lot of consistency in how they've introduced new genetic entities. So let's talk about these new entities. So one is the traditional entity of MDS with ring sideroblasts, which we know is associated with SF3B1 mutation, as shown in this Venn diagram. But there are some cases that have ring sideroblasts that don't have SF3B1. And recent studies by the group in Pavia, led by Luca Malcavati, have shown that, in fact, it's not the ring sideroblasts, but the SF3B1 mutation that drives this favorable prognosis MDS. And this is also shown on the right in terms of looking at how cases cluster. It seems like the cases that have SF3B1 have a different cluster in terms of dysplastic lineages, in terms of gene expression profile and other studies, dysmyelopoiesis, from the ones that have wild-type SF3B1. This suggests that we really should define the disease not by the ring sideroblasts, but instead by the SF3B1 mutation, which does exclude about 25% of cases that have ring sideroblasts but don't have SF3B1. And that defines a more homogeneous entity. So in fact, both WHO and ICC created a new genetic MDS group of MDS with mutated SF3B1, which about 70% overlaps with MDS with ring sideroblasts, but is a more restricted group defined by the mutation. And I've highlighted in yellow some of the changes. The ICC includes a VAF cutoff of SF3B1, whereas the WHO does not. And there are some other minor exclusions in the ICC that are not very common. And in the WHO, in recognition that not all labs may have access to NGS, allows there to ring sideroblasts as substitute if SF3B1 mutation status is unknown. However, the ICC does not allow this because the idea is that to complete the workup of MDS, NGS should really be done, and we should look for SF3B1 mutation. And the cases that don't have SF3B1 definitely have a poor prognosis. But otherwise, they're very similar definitions. Now, the other genetic entity that's new is TP53 mutated MDS, and this is really a primary aggressive disease. We think of MDS as the blasts increase, it progresses from lower grade to higher grade and then eventually to AML, whereas P53, when it's present in MDS, the patients do very poorly even if they have no increase in blasts. And this represents about 10% of MDS cases. It's frequently associated with therapy relatedness, and it's almost always associated with a complex karyotype and genetic instability. As shown here, the lower part of this heat map shows the cytogenetic abnormalities, which are numerous and often complex, whereas often, interestingly, TP53 is almost often the only mutation. In the upper half, you can see only a minority of cases actually have additional cooperating mutations. It also seems in studies done by Ellie Papanuil's group, led by Elsa Bernard, that you have to have multiple mutations or multiple hits to P53 locus or biallelic inactivation to realize the aggressive disease phenotype. In the second, you have usually one P53 mutation that inactivates one allele, and the second allele is deleted by loss of chromosome 17p or a mutation in the second allele. So based on this accumulated data, it appears this is a real entity, and again, both have created a new MDS genetic group with slightly different names, but basically the same definition, both encompassing the wide spectrum of blasts, and with some differences highlighted again in yellow. The ICC again includes a VAF cutoff because the idea is to exclude very small P53 clones that may not actually be related to the underlying MDS. And the ICC also allows a complex karyotype to substitute for a biallelic P53, which is almost always concordant anyway. I just want to emphasize for nomenclature, when we say biallelic P53, which is the WHO term, it's equivalent to multi-hit, which is the term that the ICC prefers because it's a little bit more accurate, but otherwise they're synonymous. So then the other difference is that now defining AML with some genetic features, even if the blasts are less than 20%. Again, this is something introduced by both classifications. And we already are familiar with 3 instances when this was allowed previously. If you have PML-RARA or an inversion 16 or 821, these are considered AML defining, and you could make the diagnosis of AML even if you had 8% blasts or 5% blasts or whatever, because these genetic entities were considered to define AML, and these patients could get induction chemotherapy even if they had less than 20% blasts. This rule has now been extended to several other gene rearrangements shown here that are now considered AML defining. KMT2A or MLL rearrangements, some other less common ones, MECOM, which is the inversion 3, are now considered AML defining, as well as NPM1 mutation. Now, there's, again, a slight difference here. The ICC applies a minimum 10% blast threshold, the idea being that cases that have no increase in blasts, there are rare cases of, for example, NPM1 mutated myeloid neoplasm that has 2% blasts, and some of those patients may be stable, so I think the idea is we'd be uncomfortable treating them with induction chemotherapy if there's no increase in blasts until we accumulate more data. So the ICC was more conservative by saying you have to have at least 10% blasts to call this AML and qualify for induction intensive therapy, otherwise wait until the blasts begin to increase before treating intensively, whereas the WHO does not include that threshold. Again, I want to emphasize that cases that have any of these abnormalities with less than 10% blasts are very rare. Now, a change that the ICC made, now moving away from the genetic entities I've talked about, there's also a change the ICC made in the blast percentage defining AML based on some accumulating data that there are cases that can be treated intensively or resemble AML that have less than 20% blasts. And this is based on some studies in collaboration with Eli Esty that show that when you have an AML type mutation that develops as an MDS progresses, often it develops before the blasts reach 20%. And also cases that have the higher range blasts in MDS share some genetic features from AML that have 20 to 29% or oligoblastic AML. We know that the blast percentage correlates poorly with mutations. I think one idea is there's this concept that MDS versus AML is like a colonic adenoma versus carcinoma, and you get this outgrowth of blasts in a mutated entity. And that's not, I think, really conceptually what happens. As MDS progresses to AML, I think a better way of thinking it is it becomes more maturation impaired, and the blasts increase because the clone is maturing less and less, not because you have some separate new tumor that's arising within the MDS. And also, as shown in Seattle and some places that have actually done this for years, patients with 10 to 19% blasts can be treated successfully with AML-type chemotherapy. And in this study, Eli Esty's group found that that there was no difference in the outcome in multivariable analysis in patients who were treated intensively if they had 10 to 19% versus more than 20% blasts. Other things define the outcome, like ELN subtype, the performance status, and the age, and whether the patients went on to a transplant. So based on this evidence, the ICC created a new category of MDS/AML overlap group. And I know this has been a little bit controversial. Some people say, oh, the ICC has dropped the blast threshold for AML to 20 to 10%. That's not true. I think the idea of this is to acknowledge a continuum and to show we have this intermediate group of patients that are sort of in transition to AML or on the border. And also, if we count 18 or 17% blasts, this is within a confidence interval of 20%. This only applies to adult patients. That's important. Pediatric cases continue to be called MDS with excess blasts up to 19%. And the idea of this was to open up patients to eligibility for AML trials and to study them further and to determine which patients in this group should be treated potentially as AML versus MDS, which patients should be eligible for more aggressive therapy. It's probably not all patients, but maybe patients who have, for example, RAS pathway mutations or patients with more than 15% blasts. Until we study this group, we won't know which patients within this group will benefit from being treated intensively versus being treated more less intensively with MDS-type therapies. Just a word about morphology in MDS. So the ICC retains single versus multilineage distinction. The WHO has made this optional. Conversely, the WHO has introduced 2 new morphologic subgroups of MDS, hypoplastic, defined as an MDS with a low cellularity, This prognostically may not be different, it's controversial, but there may be some relationship to aplastic anemia and an immune basis, and the idea is these patients may respond to immunosuppressive agents better than other MDS subtypes. And then MDS with fibrosis, which is only applied to increased blast cases that have grade 2 or 3 reticulum, as illustrated here, and this appears to represent an independent adverse prognosis. So these are 2 morphologic subtypes added by the WHO. So to summarize, we have both genetic and morphologic determinants of subtype, and this shows how the hierarchy of classification would work in MDS, which is, by the way, the same for WHO and ICC, and I've highlighted these and color-coded in green is the concordant classifications that are the same for both. So first we question whether there's a P53. If there is, biallelic, we call it MDS with mutated P53. If the blasts are increased, we call it MDS with excess blasts, or in the ICC, MDS/AML if there's 10 to 19%. And then MDS with fibrosis, this is a WHO entity, which is separate. And then deletion 5q, this identical definition for both, is a genetic factor. And then we look for SF3B1, again, the same definition for both. And then we move to morphology, where it gets a little more complicated. If you don't have any genetic features, if you don't have excess blasts, we call it low blasts or NOS, which are basically synonymous, but the ICC goes further to separate these based on how many dysplastic lineages, whereas the WHO ignores the dysplastic lineage and instead looks for hypocellularity and ring sideroblasts. And so those are additional features if the SF3B1 is wild type that are considered in the WHO. So overall, I think by including both, we can actually give a sort of more full diagnosis. And so I think we can apply these by putting both diagnoses and following this hierarchy and benefit patients by giving, again, more information in their diagnosis. So in the last few minutes, I'll just sort of try to whirl through other classification entities in that myeloid. So MPNs, there are fortunately essentially no significant changes except the WHO no longer recognizes accelerated phase CML, and the WHO also moved JMML to the MPN group, but otherwise kept the definition very similar. The eosinophilic disorders are the same in both. They both added new rearranged entities, ABL, FLT3, and JAK2, and that's important to recognize because some of these do respond to tyrosine kinase inhibitors. And then the MDS-MPNs, there are some minor changes, mainly in CML. Both reduce the absolute monocyte count, defining CML to 0.5. So some cases that would have previously been called MDS now will be called CMML. And both now include abnormal monocyte immunophenotype and clonality and CML diagnostic features. So both have made changes. There's a slight name change in the WHO. Atypical CML is now called MDS-MPN with neutrophilia. And the reason for expanding CMML is some recent studies which have shown the so-called oligomonocytic CMML that had that 0.5 to 1,000 blast count has very similar genetic features to overt CML with higher than 1,000. So these are now combined together. And then finally, I just want to end with a few words about the AML classification. This shows the ICC classification, which was adopted by the ELN in 2022. And I'll show you the differences, but I'm going to use the ICC to illustrate. So this is a hierarchy, again, like the MDS. Remember, one thing supersedes the other. So first, the AML defining genetic abnormalities that I showed you on an earlier slide are the first sort of classifier, if you will. And then we look for mutated P53 like in MDS. This is an important feature. Then we look for MDS-related mutations and karyotype. And then if it doesn't have any of those genetic features, then we sort of call it AML-NOS. Again, the same kind of process analogous to MDS. This shows how the ICC does recognize 10 to 19% blasts as the MDS/AML overgroup. And importantly, the ICC sort of divorced or separated qualifiers to the diagnosis. So therapy relatedness, progression for MDS or MDS-MPN, or germline predisposition can be applied to any of the above genetic AML subtypes. So the classification of AML is now almost entirely genetic. Now, how does the WHO differ from this? Well, the WHO sort of lumps together P53 mutated neoplasms, AMLs, the MDS-related mutations, and the MDS cytogenetics, and all AMLs progress from MDS together in a single group of AML myelodysplasia related, kind of inherited from the old AML-MRC. And also the WHO asked to give a sort of phenotype of the AML and NOS, whereas the ICC makes that optional. So otherwise, it's a very similar classification, and both have really identical genetic abnormalities in that first group. Another change is the recognition that a single CBPA in-frame mutation in the BZIP region, which is the terminal C-terminus, is now considered to define AMO with the CBPA, which supersedes the prior biallelic, although the WHO still allows biallelic mutations as well. And this is based on indications that the BZIP is what confers the characteristic favorable prognosis. AML with MDS-related gene mutations, which is called AML myelodysplasia in WHO, is based on recent data showing that some mutations are strongly associated with secondary AML. As shown in this top area, that several of these mutations are considered to be sort of indications of an underlying MDS and also associated with inferior prognosis. RUNX1 mutation is also similar and segregates with these in molecular clustering, so the ICC includes that in the group as well. And the ICC, but not the WHO, includes a separate TP53 mutated AML entity. And this is because, like in MDS, TP53 confers a dismal prognosis in AML. So although P53 is considered adverse in ELN, the patients do even worse than other adverse cases. So it's sort of almost like a fourth group of extremely poor prognosis. So to summarize the mutation testing in AML that are required, again, they're the same in the ICC and the WHO. The only difference is the WHO technically doesn't recognize a P53, it recognizes P53 mutated MDS, but not AML, whereas the ICC does recognize a P53 mutated AML. And RUNX1, again, is not included in the WHO list of MDS defining mutations. And the ELN additionally recommends testing for DDX41, which is a new germline type of gene, which appears to identify a unique group of myeloid neoplasms. But neither of these was included, and this was not included in either ICC or WHO. So to summarize the differences between ICC and WHO 5th edition in AML, the case of the 10 to 19% blasts are considered MDS/AML, this new group in ICC, but are still considered fully within MDS in WHO, called MDS-IB2. AML defining genetic abnormalities like CAMT2A rearrangement, inversion 3 require 10% blasts in ICC to call it AML, but there's no blast submitted in the 5th edition WHO. The WHO considers a single AML myelodysplasia-related entity, whereas the ICC has a little more refinement and recognizes subgroups within that. And the WHO applies different differentiation categories to AML and OS. Now, that being said, a recent study done by the Haferlach group in Munich found that there's an 86% agreement between ICC and WHO AML entities. So that's good news that there is overall concordance. So this is my last slide. I just want to conclude. I know we've had a bit of a whirlwind tour through these myeloid neoplasms. I tried to focus on areas of differences, but is there a silver lining to the current situation of the two different classifications? Maybe you're all depressed now, thinking we're in such a complicated situation. Well, there will be extensive discussions and comparisons between the two, like at this meeting and at other meetings we've had, as well as in several publications, which I've summarized below, comparing the two and the differences, and translations will be emphasized to achieve fluency. We're now working on an app or a website with an international MDS group that you'll be able to plug in values and it will give you the classification in both the ICC and the WHO. And the idea is that differences will spawn research to refine the next classification. Where there are differences, it indicates something we need to study, like an MDS case with 15% blast. Which of those patients will benefit from AML therapy and which should get MDS? That will require a randomized trial to really assess. And the societies for hemopath and Europeans are now in active discussion with WHO leadership because we hopefully will be able to align that the next classification we hopefully will all be together and we'll learn from sort of this rift, if you will, and we'll be able to come together. And I think everybody really wants there to be one classification in the future, but learn from this division to try to improve and make even stronger the next classification of myeloid neoplasms. So with that, I'll thank you for your attention and take any questions. Or I guess we do questions at the end probably, or?
I think the questions will be deferred for the question and answer session later on. Yeah, that was really a very good, outstanding talk, and I know it's a little hard for you to digest so much information. It's whirlwind, 20 minutes, assessment and review of both the classifications, but that's the time Dr. Sergian was given. So I'll go ahead and for the second talk, I will introduce the speaker for our second talk today, and it is Dr. Talha Badr, and he's currently Senior Associate Consultant and Assistant Professor of Oncology and Division of Hematology and Oncology in Mayo Clinic, Jacksonville, Florida. And he's board certified both in internal medicine, American Boards of Internal Medicine and American Board of Hematology Oncology. And today he will be talking to us on the topic of challenges of adverse risk AML and how to approach it. Welcome Dr. Badr on the stage. Thank you.
Assalamu alaikum. Good morning, everyone. I first of all would like to thank everyone, the organizing committee, for the invitation and for the great hospitality. It's wonderful to be here in Riyadh, and I feel nostalgic. I have some fond memories of Riyadh. Have been worked in initial days of my career as a resident at King Fahd Medical City, where I used to be young and with nice hairs. So I would go over the overview of today's presentation. First of all, brief introduction about adverse risk AML, then update on risk stratification, how the risk stratification evolved over time till now. Then we'll talk about venetoclax-based therapy for adverse risk AML, and then briefly highlight the immune signature and the significance of immune signature in AML diagnosis and management. We'll go over AML with MRC, then focus some studies which we've done for evaluation of p53-mediated AML, and then lastly but not the least, the menin inhibitors, which have been the new novel agent which has been implied for the management of AML and some adverse risk AML. So adverse risk AML, it's a disease which inherent resistance to conventional chemotherapy, and these patients, although some of them achieve remission, but these remissions are short-lasting, and when these patients relapse, they tend to have a poorer outcome. Commonly, this disease is seen in elderly patient population, patients who had prior chemotherapy, and these patients are most commonly not eligible for intensive chemotherapy approaches, including bone marrow transplant. So, brief slides how the risk stratification and the classification of AML evolve over time, going through the back days where it used to be like more morphologically oriented classification of AML and less emphasis on molecular and genetic features. With the passage of time, we have learned how the heterogeneity of the AML can be dissected and how we divide these patients who have a favorable outcome versus those who have an unfavorable outcome, with making more attention towards the molecular classification. And as you can see, the adverse risk population or adverse risk group of AML has evolved and expanded over time until recently, where we can see that ELN22 classification, the risk category, the adverse risk evolved with more splicing mutations and more mutations by who can define as anticipated AML. And as well as one important thing to note in this recent classification, the FLT3-ITD mutated AML, which tends to be a poor prognostic AML, now more and more considered a poor prognostic AML and fall into intermediate category with the advent of novel TKI, potent TKI-based therapies which have improved outcome of this group of patients. One thing to note, that this classification system is based on intensively treated patient population. It may not imply the current phenomena where we use more and more venetoclax in our treatment regimen, not only with combination with Vidasa, but also with intensive chemotherapy in younger eligible patients. So venetoclax-based therapy, this has been the paradigm shift in the management of AML, not only elderly AML, but also in younger AML who have adverse risk phenotype. This is a study by Courtney Renardo from MD Anderson, who tried to explain the molecular profile and molecular signature, which can predict how these patients will respond to venetoclax-based therapy. As you can see here, patients who have SRS2 mutation, IDH1, IDH2 tends to have a better response to venetoclax-based therapy with better MRD clearance. On the other hand, the adverse risk group, including those with monosomal complex karyotype, 17p deletion, or p53, they may respond to venetoclax-based therapy. These responses were short-lasting because the persistence of highly potent p53 clone and other high-risk adverse phenotype. At last year ASH, Hartman donor have developed this immune signature that can help in appreciating how the AML patient respond to venetoclax-based therapy, dividing into three main groups. Those with p53 tends to have adverse outcome, and those who doesn't have p53, FLT3 ITD or RAS mutation tends to have a better response to venetoclax-based therapy. So we know that the splicing mutation, spliceosome mutation, including UTF1, SRF2, has fall into the adverse risk category, and these patients tend to have adverse phenotype, and those who are eligible for intensive chemotherapy should be proceeded to bone marrow transplant to improve their long-term outcome. The group from MD Anderson did a retrospective analysis and tried to find the significance of venetoclax-based therapy either in combination with low-intensity chemotherapy or intensive chemotherapy. They found that these can abrogate, they nullify the poor prognostic impact of spliceosome mutation, including SRF2, U2F1, and ZRSS2. At Mayo Clinic, we did our Mayo series of patients who have U2F mutation that's shown to be one of the adverse risk spliceosome mutation in myeloid neoplasm, and they found that there's a heterogeneity among this group of patients. Among the two most common amino acid sequence of U2F variant which we see, one is Q157P and other is S34F. These have heterogeneity, and more Q157P is clustered with P53, AXL1 and high risk mutation, and those with SRF34F are clustered with more low risk mutation, and these mutation tends to dictate the survival. Those with S34F tends to have a better outcome compared to those with 157P. And the bone marrow transplant tends to improve the outcome overall, irrespective of the amino acid sequence. So one thing more to learn apart from the adverse risk mutations, some variants and variant rate frequency does predict outcome among these adverse risk AML patients. So it's always challenging when you have a patient who has borderline 65 to 70 years of age, who may qualify for intensive chemotherapy, but may have some overlapping features or adverse risk phenotype. What agent do we choose? Either we go for venetoclax-based therapy that may tend to do work better in adverse risk AML, or do intensive chemotherapy and take these patients to bone marrow transplant. The researchers from UPenn did their EMR-based study in which they divide these patients who receive intensive chemotherapy versus those who receive venetoclax-based therapy and did some analysis. However, the venetoclax-based group had a more high-risk patients, elderly, who may have prior therapy-related AML, but the intensive chemotherapy-treated patients have a better outcome. However, doing multiple imputations and mitigating the adverse risk phenotype, the outcome remained comparable between intensive chemotherapy as well as venetoclax-based regimen. So prospectively trial are warranted to delineate these two modalities of treatment and to identify which patients tend to do better with intensive chemotherapy versus those who can do better with venetoclax-based therapy. So as we all know, with the passage of time, especially for elderly adverse risk AML, venetoclax-based therapy has evolved, and more clinicians are inclined towards treating those agents. So we did our real-world data from AML consortium across 10 academic centers, and though we found out that venetoclax has been more and more implied in the treatment of AML with p53 mutation, as you can see on the right side of the curve, the big green bars. However, the outcome remains dismal, with median survival in the range of 6 to 9 months. That suggests for this subgroup of patients, as Dr. Hazarjin mentioned, these are poorer risk group, and there's a separate entity to be recognized. These patients continue to do poorly with available novel agent therapies, including venetoclax. So we know that AML, development of AML, does happen with some immune suppression and immune exhaustion that leads to the AML diagnosis. And we also know that BCL2 inhibitors like venetoclax in combination with hypomethylation agent tends to overcome that immune suppression of the AML and activate the cytotoxic T cells. And we also know these high-risk group of patients with p53 tends to have a more immune-rich, immune-infiltrated phenotype. So we did an IIT and tried to understand the immune profile of AML patients who receive venetoclax plus HMA-based therapy. And we able to identified 35 clusters among this group of patients using CyTOF, single-cell mass cytometry, analysis which expands the immune profile, immunophenotype of the AML patients. And interestingly, we found that the p53 mutated patients cluster with immune-rich phenotype. Among the 35 clusters we identified, we found that the B-cell activated phenotype, effector memory CD8 T-cell phenotype are more rich in these group of patients, suggesting that immune-rich phenotype of this p53 mutated AML and immune-based chemotherapy approaches may have a role to improve outcome of this group of patients. On conversely, the patients who have an immune-depleted phenotype and immune-exhausted phenotype, they tend to have a better response to HMA-based therapy, supporting the evidence that venetoclax-based combination can upregulate the cytotoxic T cells to have a better cytotoxic treatment in response to these therapy in the patients with AML. Though the venetoclax has been a paradigm shift and improved outcome of certain group of patients, but there are still significant proportion of patients that tends to do in suboptimal or poorly with this combination approaches. There are various mechanisms that are studied and been known why these venetoclax-based therapy doesn't work well in all the AML patients. Among that, most importantly, as you know that the venetoclax require intact B-cell to apoptosis mechanism to induce cytotoxicity, which is impaired in p53 mutated AML. Similarly, sometimes the alternating apoptotic pathway get activated, like MCL1, BCL-XL, and BCL-W, which can inhibit the effectivity of the venetoclax approaches, and this group also includes the patient with FLT3 ITD mutated AML. So we need to work along those lines, have a better triplet combination of better individualized therapy, how to overcome this resistant mechanism, improve outcome of our patient with adverse risk AML. We'll talk briefly about AML with MDS-related changes. This is more commonly seen in elderly AML population, and those patients have significantly overlapped with high-risk cytogenetics. According to recent ICC classification, apart from the chromosomal changes that define AML with MDS-related changes, there are certain molecular markers that can define AML with MRC, including XL1, the splicing mutation, and some others. And substantial proportion of these patients had prior progression to HMA. Historically, patients who progressed on HMA-based therapy and transformed to AML, their outcome is less than 6 months. With venetoclax-based therapy, they may improve to 6 to 9 months, but still very poor. As you know, the CPX351, it's a liposomal combination with a cyclin cytarabine, which gives more leukemic activity of the 3+7 combination in patients with AML. It is approved for patients who had a prior MDS or had AML with MRC changes, or those who have therapeutic AML, and has shown to improve outcome in this group of patients, especially those who can bridge to bone marrow transplant. Recently, a randomized study conducted by UK group evaluating the benefit and efficacy of FLAG-IDA, another intensive chemotherapy regimen, compared to CPX351. They found, interestingly, those with MDS-related changes tends to have a better outcome with CPX, which may be better tolerated than FLAG-IDA chemotherapy. However, patients with p53 mutated AML tends to have a worse outcome with no benefit of either of the two combination. So moving towards the p53 mutated AML, which is my area of interest. As you know, the p53 is not only involved in cell regulation, genomic stability, apoptosis, but also has a role in innate and adaptive immunity. It's a mutation which commonly occur across all cancers and have the inferior outcome. And is AML, although it's seen in a small subset of patients, but those who are elderly, who had a prior chemotherapy or therapeutic AML, tends to have a higher likelihood of this poor prognostic disease. And these AML patients doesn't respond well to conventional chemotherapy approaches. Over the years, several chemotherapy combinations have been tried with moderate responses, as you can see in the red, with the response in the range of 40%, apart from one small prospective study from WashU, where they find the 10 days decitabine tends to improve the outcome of this patient with clearance of p53 clone. However, it doesn't pan out in combination with venetoclax-based therapy in further prospective studies. One agent that shows to be promising is maculimab combination, which is anti-CD47, which is an immunotherapy-based approach in combination with HMA or HMA plus venetoclax, that's shown to improve outcome and their 2 randomized studies are ongoing to see the efficacy of this combination versus standard of care therapy. With more to be learned about this combination, but so far the data seems to be exciting. The role of transplant. Historically, it is thought that this high group of AML patients may not respond well to bone marrow transplant, and it's not worth taking the risk with high morbidity and mortality which can be seen in bone marrow transplant, and the lack of benefit has been shown to persistent of p53 clone. In our real-world analysis, most recently in the venetoclax-based era, we did found that the only factor which improves the outcome of these high group of patients is bone marrow transplant. We did this analysis to find the predictors. What are the predictors that suggest that p53 mutated AML may tend to have a better outcome with bone marrow transplant? Although, as you can see on the right-hand side, very small proportion of patients were able to undergo transplant, around 10 to 13% after first line or second line therapy. However, among those patients who are bridged to transplant, they tend to have a better event-free survival, more than a year, and better overall survival after first line therapy, close to 3 years. Not only that, in multivariate analysis, we found that patients who develop chronic GVHD or who are in CR at day 100 post bone marrow transplant, that tends to have a best outcome. As you can see here, the 4-year survival around close to 40 to 50%, which is never heard of with whatever therapies we have available to treat this poor prognostic disease. Some of the evidence may suggest that graft leukemia effect may have a role to play in terms of sustaining an improved outcome for this group of patients. Having said that, these are small subset of patients, most likely because when we are treating these patient population, these are elderly, they are ineligible for intensive chemotherapy, have a lot of comorbidities, and have a relatively high treatment mortality. That's why it doesn't pan out in larger group of patients, but it's still in eligible patients, properly selected patients, that is still a modality to improve their long-term outcome. There's also debate about allelic state and outcome for this group of patients. Initial studies by Bernard et al. Showed that patients with MDS, low-risk MDS especially, if they have a monoallelic p53, tends to have a similar outcome to wild-type p53 compared to biallelic p53. However, later on, when this monoallelic versus biallelic was tested in high-risk MDS and AML patients, doesn't show to have any significant impact in terms of allelic state. We did this our real-world analysis in trying to find out if the monoallelic versus biallelic p53 have any role in high-risk MDS and AML patients in predicting long-term outcome. One observation we did found that the single hit p53 tends to have a high cluster of somatic mutations compared to biallelic p53, as has been shown earlier. However, we didn't see that it impact event-free survival or overall survival in high-risk MDS and AML patients. Most likely these patients are high-risk group, acquire more mutation with time when they progress from MDS to AML. Most of these patients may have a prior therapy at AML. Most of these patients may have a prior HMA-based therapy that tends to have negate any significance of allelic state in terms of affecting their outcome. So another adverse risk AML that we need to work on that continues to have a very poor outcome is inversion 3 or translocation 3-3. This group of patients, they have a two-fold oncogenic event. One is the overexpression of MECOM, and the other is the hypnosufficiency of a GATA2 mutation, which is a transcription factor. Recently conducted retrospective analysis from MD Anderson, they find to figure out how these patients do in venetoclax era of venetoclax therapy. As you can see here, the composite CR is around 40%, and it hasn't changed with intensive versus low intensive chemotherapy. With the venetoclax-based therapy, the complete remission rate is around 33%, and the overall survival at 3 years is really dismal, less than 10%. So these group of patients, adverse risk group of patients, we need to find better strategies how to improve their outcome. Lastly, but not the least, few slides on menin inhibitors. As you know, the menin with the lysine methyl 2 transferase 2A, which is the cofactor in leukogenesis of not only for KMT2 DA deranged AML, also NPM1. And we'll talk about basically on KMT2A, which is an adverse risk phenotype in acute leukemia, overall AML or ALL. Although it's seen in very small subset of patients, but these patients tend to do poor with conventional chemotherapy, and bone marrow transplant can salvage few eligible patients. Among several menin inhibitors, one of them which is most mature and the data has been presented as a phase 1, phase B study is revumenib with Syndex, a potent oral selective menin inhibitor. In a recently published phase 1 clinical trial, it has shown activity in relapsed refractory patient population, not only those with NPM1 mutation, but also those with KMT2D range. Mind you, there are several other menin inhibitors in clinical practice which haven't shown much signals, especially in KMT2A deranged AML. Most of those menin inhibitors have shown activity in NPM1 relapsed refractory AML. So this is a newer compound and a lot to be learned about this menin inhibitors, and there are several trials ongoing in combination with intensive chemotherapy as a frontline for NPM1 and KMT2 deranged AML. So in summary, I would say for adverse KML, one size does not fit all. You need to have a better, more individualized approach. Intensive chemotherapy may not be the answer for this group of patients. Low intensive chemotherapy may have a comparable outcome with less cytotoxicity and better quality of life. And as you need to be focused on more individualized therapy, more incorporating more genomic data, and novel treatment combinations and clinical trial participation for this group of patients is always preferred. Appropriate patient selection, bone marrow transplant can be used effectively to improve the long-term outcome of these patients. And recognizing resistant mutation early and using combination to overcome those resistant mutation is the way forward to improve outcome of this group of patients. With this, I thank you all for listening today.
Thank you, Dr. Badr. That was an excellent presentation. And actually, I think you did a nice job of downtelling whatever Dr. Hassajian mentioned about, especially regards to P53 mutated AMLs. So again, the question and the comments will be taken at the end. So we will move now to ALL, and I think this is going to be an online presentation. I'll go ahead and introduce the next speaker. Our next speaker online is going to be Dr. Ibrahim Aldos. He's an associate professor in the Department of Hematology and Hematopoietic Stem Cell Transplantation at the City of Hope, Duarte, California, United States. And he's also co-director of the Hematology Tissue Bank and the co-director of Leukemia Registry at the City of Hope. And he has interest in, and focus of interest is in optimizing treatment outcomes in younger patients with acute lymphoblastic leukemia, especially improving the immunotherapies and treatments beyond anti-CD19 antibodies. So today, Dr. Aldos is going to speak to us about immunotherapy in frontline treatment for adult B-cell acute lymphoblastic leukemias. Dr. Aldos, are you there? Can you?
Okay, good morning. This is Ibrahim Aldos from City of Hope in Duarte, California. I would like to thank the organizer for inviting me to present on immune therapy in frontline treatment for adult B-cell ALL. These are my disclosures. So age at the time of ALL diagnosis is prognostic, and we can see that survivals decrease as patient age increase. And if we look at the SEERS database, which is a registry database in the United States, outcomes of ALL in older patients were extremely poor and hasn't changed significantly over the recent years. This is the same database where we can see that older patients can be defined as 55 and above, only represent 22% of all newly diagnosed cases of ALL, but they contribute to more than half of all deaths related to ALL. And looking at older patients enrolled in clinical trials, which usually these are more fit patients to meet the eligibility criteria, their outcomes remain poor, and overall survival is in the range of 20% or less. So why older patients with ALL, they do poorly? There are different reasons. Part of it, they tolerate chemotherapy poorly. They have high rate of induction mortality and death in remission when they treated with chemotherapy induction, consolidation. And it's difficult to maintain the treatment schedule in older patients with ALL as they get the condition between cycles, and they tend to develop prolonged cytopenia that usually delay subsequent treatments. And importantly, important drugs like asparaginase, full dose vincristine, high dose steroid, high dose methotrexate cannot be administered safely in older patients with ALL. So the treatment usually inadequate. On top of that, they tend to have high risk disease biology. Older patients more frequently have pH positive ALL, complex karyotype, low hypodiploidy, KMT2A rearrangement, IKZF deletion, and TP53 mutations. And all of these predict usually low response to chemotherapy and high risk of relapse. Even the entity of pH-like ALL, which is a chemo-resistant subtype of B-cell ALL, is not uncommon in older patients. This is a large multicenter study, included older patients with B-cell ALL. You can see that pH-like ALL represent up to a quarter of all cases of B-cell ALL. Adding to that, usually older patients, they tend to have more comorbidities. There are more medications that can interfere with chemotherapy administration, as well as the psychosocial support limitation will become difficult to bring them frequently for treatment, either with chemotherapy, even post-transplant care as well. So older studies, they try to intensify the chemotherapy backbone for older patients to achieve better outcomes in terms of cure have failed in older patients. And this is one example. This is the BITHEMA ALL96 study, where investigators induce older patients with ALL with 5-drug regimen. And the study was actually amended early because in the first 10 patients, 7 actually died during induction as a result of toxicity. So asparaginase and Cytoxan were actually removed from induction, and this led to lower induction mortality and higher CR rate. But with kind of less intense chemotherapy, the risk of relapse remains high. And even with low intensity chemotherapy, older patients continue to experience death in remission afterward. And this led to kind of low overall survival in these patients. So immune therapy like blinatumomab and intuzumab have shown promise in relapse refractory B-cell ALL, including older patients with B-cell ALL. And typical factors that predict chemoresistance, it doesn't appear to impact the response to these agents, such as poor cytogenetic, increasing the patient age. And also, the toxicity of these drugs are unique and different than chemotherapy and appear to be more tolerable and not age-dependent. So both drugs, blinatumomab and intuzumab, led to superior response rate as well as overall survival compared to physician choice of salvage therapy in relapse refractory B-cell ALL. Focusing on blinatumomab, so you can see here age is not a predictor for response. Older and younger patients, they respond the same. Now, what predicts response to blinatumomab is the disease burden before treatment. And there is more interest to treat patients with blinatumomab when they have lower disease burden because you can see the response is significantly different. And in pooled analysis from prospective studies comparing outcomes of blinatumomab in relapse refractory patients, if they are younger or older than, they're younger or older, you can see that the response, the MRD response, the relapse-free survival, and overall survival were comparable for younger and older adults with relapse refractory B-cell ALL. And you can see here also that the toxicity overall is comparable with the exception of grade 3 neurotoxicity, which is more common in older patients compared to younger patients. So blinatumomab is safe and active drug in older patients with relapse refractory ALL. Age itself does not influence response or survival, and blinatumomab has a favorable safety profile. And the promising activity has been seen in both relapsed refractory patients as well as MRD positive disease. And there is actually more motivation to give it in low disease burden, including MRD, because we see higher response as well as the durability of remission is longer. This is from the BLAST study where patients treated with relapsed refractory MRD positive disease with blinatumomab, and the orange curve is patient didn't receive consolidation with allogeneic stem cell transplant. And you can see at 5 years, you still have maybe a third of the patients remain in remission. So it's potentially curative treatment when you give it in low disease burden. Plus, when you give it in low disease burden, you tend to see lower toxicity. Intuzumab also has shown activity in younger and older patients, and age itself did not influence response or progression-free survival. Now, in contrast to blinatumomab, intuzumab is active in both high disease burden and low disease burden, so it can serve better as a cytoreduction treatment before you give blinatumomab. So, moving to immune therapy in frontline treatment for older adults with Ph-negative B-cell ALL. So with the data I present, there is an interest to integrating blinatumomab and intuzumab early in the treatment paradigm for older adults with ALL, part of it to improve the safety as they have lower toxicity than chemotherapy and potentially can reduce the induction mortality, the death and remission. And with the activity we see with these agents in relapsed refractory setting, they can overcome the suboptimal response with chemotherapy. We can produce higher CR rate, MRD response, and possibly durability of remission. And because they have a better safety profile, it can maintain the physical fitness of older patients for subsequent, more curative consolidative therapy like transplant or CAR T-cell therapy. So there are different studies looking at the question of frontline blinatumomab and intuzumab in older patients. So this is the SWOG 1318, one of the earlier studies. And in the study, older patients defined 65 and above receive induction treatment with blinatumomab for 1 or 2 cycles, followed by consolidation with blinatumomab for 3 cycles, and followed by pump maintenance. You can notice here that because these are untreated patients, no cytoreduction was given. The median bone marrow blast was high, 87%. So these patients, they have high disease burden. Sorry for that. Even with that, the CR rate was 66%, and including MRD negativity in the majority of responders. There were no early death, and overall survival and disease-free survival were kind of looking more favorable compared to historical control. They were 37% at 3 years. Another study which is actively enrolling is the Golden Gate study. And in this study, this is a phase 3 study comparing blinatumomab with low-dose chemotherapy versus standard of care that can be either hyper-CVAD or GML regimen in older patients with newly diagnosed ALL. Now, this is the experimental arm of the study, where patients actually receive low-dose intensity chemotherapy a week before starting blinatumomab induction. And this is followed by blinatumomab if the patient responds, then consolidations with 4 cycles, including 2 methotrexate and 2 blinatumomab, then maintenance pump and blinatumomab. There was a safety run-in phase done in the first 10 patients. And you can see here that these 10 patients, the median age was 69. And the majority, they have high disease burden. And even with that, with the introduction of low-dose cytoreduction chemotherapy, this led to response in all these 10 patients, including MRD response in 9 out of 10 patients. And now the phase 3 study is actively enrolling patients. There's also studies including intuzumab as a frontline therapy in older patients with ALL. So this is the EWAL-ENO study, where 2 cycles of induction intuzumab given with low-dose chemotherapy, followed by consolidations and pump maintenance. The study enrolled 131 patients, and it shows high CR rate, 90% after induction 2, and the majority achieve MRD negative. Now, encouragingly, the treatment-related mortality was low, only 3%. And these outcomes, considering that the median age was 68 and the majority, they have high-risk genetics. And these are the survival curves on short follow-up. A similar study is the GMAIL Initial 1 trial that also enrolled older patients with Ph-negative B-cell ALL, where they received 3 cycles of induction with intuzumab, the first one with dexamethasone, the second and third one only with IT chemo, followed by consolidation, reinduction, and maintenance. In the study, all patients achieved CR, and the MRD response was high, 74%, and there was no early death within the first 6 months, and these are the survival curves for these patients. Now, another approach was taken by MD Anderson group, where they actually combined both intuzumab and blinatumab in older patients with B-cell ALL. Patients received the mini CVD with intuzumab as initial cycles, followed by consolidation with plina, then maintenance with pump and blinatumomab. This is one of the earlier reports and showing that in patients treated with this regimen, the overall response was 98% and overall MRD response was 96%. However, it became clear that not all older patients are the same. Those in their 60s, they tend to do better than in their 70s. And this is mainly related because you're having more death in remission in patients in their 70s, including this novel regimen. This led the investigator to amend the protocol to eliminate chemotherapy in older patients to reduce the rate of death in remission. This is another presentation, another update from the mini CVD plus intuzumab plus minus blinatumab presented in the EHA 2022. And in addition to older age, patient didn't do well. Patient with actually poorer cytogenetic, they didn't seem to do well as well. However, the outcomes for patients in their 60s and without poor cytogenetic was very encouraging, 69% at 5 years. Another exciting study that was just presented this year is the Alliance 041703. This is a chemo-free regimen for older patients with Ph-negative B-cell ALL, where patients receive intuzumab induction followed by blinatumab consolidation, no maintenance, no chemotherapy. And the median age was 71, and you can see the CR rate was as high as 96%, and at least early survival data appear encouraging. At City of Hope, we actually took a different approach. We asked the question, will CD19 CAR T-cell therapy has a role as a frontline therapy in older patients with ALL? Since these patients, they don't do well with CAR T-cells in the relapse refractory setting when there is an active disease, we're trying to introduce it as a definitive consolidation therapy in CR1. So patient achieves CR1 with any initial frontline therapy, they will be eligible if they're 55 and above, and there's no immediate plan for transplant. The idea is if you give it in patient in remission, the toxicity is low, so that will be ideal for these patients, more likely to experience severe toxicity with CAR. At the same time, there's data indicate when you give CAR T cells in patient in remission, the durability of remission is longer, and potentially it can be a curative treatment. Now, moving to younger adults with Ph-negative B-cell ALL. Similar to older adults, there are different studies. They're looking at the same question: can we introduce blinatumab, intuzumab during induction consolidation in these patients? And the idea that younger patients treated with pediatric-inspired regimen, they still have more toxicity compared to children, and the rate of relapse is higher. Can we improve on this? And you can see different groups, they ask the same questions, and the CR rate is high, MRD negativity was very encouraging, and at least in short follow-up, the survival rates appear very encouraging. One of the important study that was presented recently is the ECOG 1910 study. And in this study, patients between 30 and 70 years old with newly diagnosed Ph-negative B-cell ALL receive induction, intensification, and if they achieve MRD negativity, they get randomized to the backbone consolidation plus maintenance, or the same backbone chemotherapy consolidation with 4 cycles of blinatumomab. So the study shows survival benefits with adding blinatumab during consolidation MRD negative CR1 patients, as well as improvement in relapse-free survival. and it will likely change our standard of care, how we treat these patients. So, as expected, you have lower risk of dying from leukemia, but what's surprising was that also death and remission was lower in patients randomized to blinatumomab. And potentially this is by giving blinatumomab between chemo cycles, it will reduce the risk of having complication from continuous chemotherapy treatment and reduce the risk of sepsis. Now, surprisingly, most of the benefit was seen in younger patients, but not in older patients randomized to blinatumomab, which is, we still don't know why. I think we need to see the paper to kind of understand why this is the case. Another randomized study using intuzumab as a frontline therapy in younger patients with B-cell ALL is the Alliance 041501, where the patient received the backbone CLGB 10403 regimen, but randomized to either the standard consolidation versus 2 cycles of consolidation with intuzumab after induction, in addition to the same backbone chemotherapy. Unfortunately, the study was suspended a couple of years ago due to unacceptable toxicity in the investigational arm, and appeared it was more related to sepsis later in the course of consolidation. But we're still waiting for more results to see if the introduction of intuzumab was superior in terms of MRD response, and potentially on longer follow-up, we may see improved outcomes. What about Philadelphia chromosome positive ALL? Is there any role for immune therapy? So this is data from MD Anderson looking at their Ph positive ALL patients, where they show the improvement over the years in Ph positive ALL by the introduction of tyrosine kinase inhibitors compared to lower intensity chemotherapy. But overall outcomes in terms of molecular response, overall survival were comparable between both arms. Now, since chemotherapy doesn't work, as blinatumomab showing really encouraging outcomes in relapse refractory B-cell ALL as well as Ph negative B-cell ALL, the DELBA study enrolled patients with Ph positive ALL, adults with Ph positive ALL, to be treated with induction with the dasatinib and steroid for 3 months. And after 3 months, they continued the dasatinib and they received 2 to 5 cycles of blinatumomab concurrently. So the study shows that the combination was safe. And after the first cycle of blinatumomab, the rate of molecular response was almost double. And this can be prognostic in Ph positive ALL. And we can see for this chemotherapy-free regimen, the overall survival, disease-free survival outcomes were encouraging. Similar study was also conducted by the SWOG. This is the 1318 study where dasatinib and prednisone given for 3 months, then blinatumomab was introduced with dasatinib. But this study enrolled older patients, 65 and above, and outcomes were encouraging as well. Now, as ponatinib, third-generation tyrosine kinase inhibitor that has actually activity in many of the resistant mutations we see with dasatinib, investigators at MD Anderson combined ponatinib with blinatumomab as a frontline therapy in Ph positive ALL. And this study, blinatumomab was used during induction as well, not like the DELBA and the SWOG, where it was used after induction. And this study, you can see the overall response was very encouraging, 96%, and the majority achieved complete molecular response. And these are the survival curves, very flat early on. So it's very encouraging outcomes. And what's encouraging about this study that the majority of patients didn't go through allogeneic stem cell transplant. So it's potentially a curative treatment, but we need a longer follow-up. With that, I conclude that the integration of immune therapy in frontline treatment for adults with B-cell ALL has shown early encouraging results, both younger and older patient positive. And it's likely that our
by virtue of their simplicity. That's not to say that we should have stopped there. Obviously, advances have taken place. But now, with WHO versus ICC, having different classifications, and they do differ in a number of ways. You're right, they're similar as well. We can go into their differences again, but is there any prospect? You suggested that in your slide that there may be coming together of these classifications. Because the other thing is that these classifications are followed globally. So what we are doing is by giving a classification that is based on molecular typing, that we're telling the world, WHO is telling the world, ICC is telling the world, that molecular characterization of every leukemia and MDS patient should take place, which costs quite a lot of money in many of the developing countries. So I just wondered what your general comments are about the way we have evolved to the point where we are now.
Yeah, that's a complicated question. I mean, regarding the molecular testing, I think you're absolutely right about that. That's one reason why the WHO did have the idea of still using ring sideroblast to kind of substitute for SF3B1, because an iron stain is very cheap, it's widely available, and it does predict reasonably accurately SF3B1. The other thing is for P53, I do think that molecular testing is important to help us better understand MDS if it's available. Does that answer the question about the molecular?
Yes, but I think you can see it from the clinician or patient's point of view, because people would do the molecular testing if it made a difference to the treatment choice or if it made a difference to the overall prognosis. The problem with some of the diseases like MDS is we are so limited by the number of drugs that are available to effectively control this disease, let alone cure this disease.
I think that is an issue. I mean, one thing for the IPSSM is identifying higher risk disease patients that may benefit from more intensive therapies, and the IPSSM does, by adding mutations, you can upstage patients that would have been called low risk to higher risk, so that could be a benefit in directing them to more therapies for higher risk disease. I guess that's one thing. Regarding the overall classification that has become more complex, as I mentioned, there is talk about trying to come together. There's a now multiple group, including both WHO and ICC people, trying to achieve some consensus on how to use the MDS classification best. I think that would include using aspects of both, mentioning, for example, hypoplastic MDS, mentioning fibrosis, but also mentioning multilineage versus single lineage dysplasia, so kind of taking the best of both classifications as we go forward.
There are a number of questions online as well about morphology and morphological classification, but most of them address this issue, what I've just said. Comments from the audience?
No, it's a question rather than comment. We know that TP53 is one of the common or the commonest mutation in all type of malignancies, not only the hematological. What we see in AML, is it different mutation or is it the same mutation which we see it in all malignancy? This is the first question. The second question, is it become part of the routine testing which we do for all acute leukemia as part of the panel by molecular or cytogenetic?
Thank you for the question. I think it's a common p53 suppression or p53 mutation which we see in all cancers, and commonly as we learn more about p53, there are several gene panel in US which we can use. The payer issue, insurance issue, we won't be able to do a whole genomic sequencing of 52 or 72 gene panel. We have a modified 11 gene panel that is economical and that is preferred to be used while we are doing bone marrow biopsies for newly diagnosed AML inpatient. Not only for the predictability, but also for therapeutic indications. Now we have some agents which are more in a clinical trial for like meglumab and some other agents for p53 treatment naive AML patients. We do that commonly. So for various reasons, not only for prognostic, but also therapeutic reasons. And the modified gene panel, which is economical, can be used. And as the Dr. Herzardman mentioned, you can do a AML MDS FISH panel to look for 17p13 deletion, or you immunostain to find this, which is economical compared to genomic sequencing if there's a cost-related issues.
Can I just ask both of you, a question about P53. I mean, one of the changes that has taken place since Eliza published her paper on P53 is multi-hit versus monoallelic. That monoallelic is not bad or is not that bad, whereas multi-hit is. Do you agree with that?
For a low-risk MDS patient, yes. But patient with high-risk MDS or AML, monoallelic versus biallelic doesn't pan out, or monoallelic doesn't pan out to be better than biallelic because of secondary mutation acquire new clones, resistant clone, that doesn't have the same prognostic impact compared to low-risk MDS, let's say less than 5% blast, that may have a significant impact and these patients may do similar to wild-type P53, but not for high-risk MDS or AML.
Is that your feeling?
Yeah, I completely agree with that. That's one reason why in the ICC, when you reach the MDS AML 10% blast threshold, you only need one mutation to put it in that group. And I've talked also to Elsa Bernard and Ellie Papanuil about that. They, of course, published a paper that said that in MDS, it should be biallelic. In the IPSSM, a monoallelic P53 mutation is actually ignored. It doesn't contribute at all to the prognosis. But I think even they said that as the blasts increase, it does appear that monoallelic does assume a significance. I don't think we fully understand why, but I completely agree with what you said, that for AML, certainly there seems to be no difference between a single or multiple hit P53.
Yeah, just one minute. And is it also true of complex karyotype as well, or it's only true about high blast cell percentage that monoallelic matters? Because there's suggestions that from Tempa and other places that it may be in those cases as well.
I think that's probably true. I also wonder if you have a complex karyotype and what looks like a monoallelic, if it actually might have loss of heterozygosity that's not being picked up, that could be missed. So I think that's an unanswered question.
Okay. You, sir.
Okay.
Okay. I'll come to everyone. Yeah.
Okay. First of all, thank you, Prof. Robert Sarjan, for this informative presentation. And actually, when it comes to the splitted classification between ICC and WHO5, as a and hematopathologist working in tertiary center, I can see that it has some negative impact on the practice. So, because a hematopathologist who's working in a busy setup and who's including 3 classification schemes in one report because he is the different hematologist from different schools. So I know that a lot of scientific issues and some or few politics behind that. So now my question, or consider it my hope, can we have a unified WHO 6 in the near future, or we will continue with ICC 2, ICC 3, and so on?
I think that's a good question. I think certainly we all are going to, plan to unify, we hope to unify behind the WHO 6. I think that is the idea. As I said, we are having discussions now with the WHO, and the idea is that we can have a collaboration where maybe the ICC would have a meeting and present a sort of suggestion and that would be adopted by the WHO or used partly. So I think we can develop a model where we can work together. I think the timing, the reasons why this split happened, I didn't want to get into that, but I think it was timing. I think COVID contributed. I think if we had been able to meet face to face, I think the differences could have been resolved. I think the timing of when the ICC met was too close. So I think a lot of issues happened, but I think certainly we've learned hopefully from these mistakes, and that for the new classification, the 6th edition, I think we want to unify behind that. Unfortunately, that will take several years, as you know. It will be probably 4 years or even before the 6th becomes prepared or comes out. However, in the interim, again, there are some publications, I think, in the works to try to give suggestions on how to work with the two and perhaps put both information. In the meantime, we are giving the 3 classifications, and I've seen other reports, and we just list them 1, 2, 3. I'm old enough to also remember when we had for lymphomas, the Luke's Rappaport and the Luke's Collins and the Rappaport, and I used to give, when I was a resident, I would give poorly differentiated lymphoma, nodular, whatever the I mean, I would give both. So I think it's sad that we're back there, but it's one way to handle the two classifications.
All right, thank you. If I'm allowed, I've got two questions actually, one to Dr. Surjan and one to Dr. Talha. The first one is, especially with dysplasia being so important in the algorithm you mentioned, are we behind as the medical field generally, and perhaps in the field in incorporating AI to make everyone's lives a bit easier? That's the first question. So I'll come to the second question.
I think that, well, I think that's an evolving field. I think there's been a lot of research now in using AI to try to identify dysplasia and certainly cell types. I think AI, I don't think it will replace humans. I think that it can be used by humans. I think sometimes even simple algorithms that identify cells like CellaVision or similar software that can make mistakes that I think a human can see, like calling lymphocyte a neutrophil. So I think we still will need a human to kind of, but I think it can in the future be assistance at trying to identify dysplasia more objectively, or using things like flow cytometry. I think morphologic dysplasia has a lot of issues, and I think we need to get to the point where we can improve the ability to diagnose it, which is subjective. But that's true. We have to decide what dysplasia is. And I think even a computer will not be able to tell dysplasia due to, say, recovery from chemotherapy or an infection or an inflammatory state that can produce reactive dysplasia from true MDS dysplasia. I think even a computer won't be able to tell those because they look indistinguishable. So I think AI may have a role, but I think much more work needs to be done before we can get there.
And if I had a question to Dr. Talha, and thank you very much for both presentations. So it's about the TP53 and venetoclax, because we're programmed to say, well, oh, TP53 chemotherapy resistance, oh, we have to use venetoclax. But yourself, and even Nicholas Short's paper from a couple of years ago, where it actually showed that with a low VAF, cytarabine was better, that old cytarabine, which is not very fashionable anymore. So is there a bit of an over-expectation and an overuse of venetoclax, and should we be a bit more realistic? It's a good drug, but it's not a super drug, and do we need to address that a bit?
No, thank you for the question. Very good question. In fact, yeah, in our real-world data set of close to 400 patients, we were not able to replicate that VAF 40 or less than 40 had an impact on response to intensive chemotherapy or low-intensive chemotherapy or VAN-based therapy. And especially when we did analysis of multi-hit versus mono-hit, multi-hit includes VAF more than 50 or over if it happens in isolation. So we didn't see one kind of therapy impacted outcome. So we couldn't replicate those findings which they have presented. So there is a controversy and conflicting results on that. Secondly, I agree, in the scheme of things, P3-mediated AML continues to do poorly, and there is no one therapy that can improve outcome. However, if you can bridge these patients to transplant with minimal toxicity, with better quality of life, that's the only factor that can improve outcome. In our analysis, we do see the odds ratio favoring VAN-based therapy in terms of achieving remission, but not improving survival. So as you can see, the signature paper from Courtney Donato, they did show that VAN-based therapy do achieve remission, but remission durations are short. If you use that time window and time period to consolidate these patients to better therapy, there's a hope that you can salvage very small subset of patients, may not be many.
Thank you. Dr. Tala.
All right. Thank you all. That was a very nice talks. Dr. Sarjan, you showed that I'm more into the technical questions rather than the grand scheme of things. The SF3B1, you did show that the ICC and WHO are similar, but I think the ICC has the 10% cutoff. So, for example, if a patient, 60 years old, female, deployed, came in with 30% ring sideroblast and 7% S3B1. In one classification that's in the WHO, that's an S3B1 mutated, but in the ICC, that's not going to be the case. So there is a little bit of differences in terms under the thing. And my point here is both classification did not really look into the prognosis. So if you threw in RAS or IDH or something, then you get really the prognosis from a low risk to a high risk if you do the IPSSM. However, neither classification actually replicate that. It's just, they are just dependent on a signature rather than a prognostic or therapeutic driven. That's what I was saying. The second question on the same lines is, I always wonder in the ICC, why the myelodysplasia related changes come before the cytogenetic related changes in the diagnostic hierarchy. It seems that cytogenetics like a monosomy 7 and this is carry more weight in terms of prognosis and therapeutic than myelodysplasia related genetic mutations. Thank you.
Thank you.
Yeah, no, I think you're right about the second point. I think it's not clear why the mutations necessarily have over this. I think more studies need to be needed. I think it's possible that the cytogenetics is more relevant. In other words, if you have a monosubmutation, that may be worse than having just an ASXL1. That being said, I would say it's still better to have both of those than the WHO just throws them all in together as AML-MR. I think that there are probably nuanced differences between a cytogenetic lead, like say an AML with a very complex karyotype, even if it has wild type P53 versus an AML with a RUNX1. I think those are probably different, and I'm not sure which should supersede the other, but I think more work needs to be done on that. But I think it's better to at least have those two groups than, again, to call them all AML-MR, which is such a heterogeneous group, including AML with mutated P53, which I think really has to be separated. I think I really have a problem with the WHO not recognizing an AML P53 and just putting that in with some AML with a normal karyotype that progressed from an MDS and a patient who was treated with HMA. I think those are very, very different animals. So, but I think you're right that there's no, I think, clear reason why the mutation-defined MR should supersede the cytogenetically defined. And regarding your first question, I agree that the VAF cutoffs that the ICC put are arbitrary. I think the idea was that if you have a very small SF3B1, it may not really be driving the disease phenotype. So, but, you know, I take your point. It doesn't have a cutoff for the IPSSM. So I think that, again, warrants probably further study.
Thank you very much. There is just one question online. I'll come there. One question online, which is to do with both the morphological features, morphological characterization, as well as molecular characterization and ethnicity. So the questioner is asking, are there any differences that we know about between various ethnic subgroups in MDS or even in acute myeloid leukemia? So is there any data that you think is going to be, answer that question that's been asked online?
Get the second part, the molecular features?
Yeah, are there any differences in molecular or morphological features of AML and MDS in different ethnic groups? Is MDS in Middle East the same as MDS in Chicago?
No, that's very interesting. I haven't looked at it and I haven't come across any paper suggesting or delineating ethnicities or clustering of different molecular mutations by them.
I think in Japan there have been some studies showing some differences in Japanese MDS versus European, but I'm not aware of other ethnic groups that have been studied.
Thank you. Can I just ask a question about CyTOF? I didn't quite follow the data because there was a lot of data. What did the CyTOF data show specifically in terms of understanding the venetoclax plus HMA combination and whether it's a it's a kind of signature that goes with a better or a not so good response or duration of response.
Yeah, the site of analysis, as you know, is a single cell mass cytometry, which is
I know that,
and
but-
then what we found is that that P53 mirrored AML tends to have a more immune-rich clustering.
What does that mean?
That means they have high phenotype, which suggests like more CD8 or more memory T cell infiltrated tumor microenvironment.
So they are more immunoinflammatory.
Exactly.
At
At diagnostics.
a site-off level, but not at a single-cell transcriptional level.
That we haven't looked at it, single cell transcription level, but we have seen like at the site off level that they have more immune infiltrated phenotype.
I see. Okay, thank you. Any? There are still a lot of questions. It's been a wonderful. I just wanted to ask one question from our ALL expert. And this will be the last question. And how do you treat a 55-year-old ALL at the present moment? What is your combination therapy and maintenance? Hello?
Sorry,
Can you?
I'm having problem with the connection.
How do you treat, today at City of Hope, how do you treat a Philadelphia negative
Can you repeat the question? I
equivalent for
couldn't
blastic
hear it.
leukemia
Only the
adult?
beginning. Have I treat what?
Say that again. Did you hear the question?
Dr. Dos, can you hear us? Can you hear us? No, I think it's good. Disconnected. Okay, so we close this session and thank you everyone for participation and thank you to speakers
Sir, I
for
still
their
hear
excellent
the
presentation.
question.
So it was really interesting, exciting interchange. So hopefully, inshallah, we'll continue talking to our speakers and there will be a break for 10 minutes for coffee break, inshallah. We'll be back after 10 minutes for the rest of the session. Thank you very much. Assalamu alaikum.
وبركاته. بسم الله الرحمن الرحيم. Ladies and gentlemen, good morning everyone. I am Muhammad Ahmed, hematology at King Fahd Medical City. Joining me, Dr. Marwan Shaheen, hematologist at King Faisal Specialized Hospital and Research Center. We will be moderating the second session for today. We have 3 presentations, each will be for 20 minutes. Followed later, we'll have the panel discussion, hopefully for 15 minutes. Our first speaker, with a great pleasure for me to introduce the first presentation for the second session, will be presented by Dr. Uthman Al-Sawaf. He's a hematologist and medical oncologist at the University Hospital of Cologne, Germany, and study physician at the Germany CLL study group. He studied medicine and medical school of Roth, RWTH, Aachen University in Aachen, Germany. He joined the Department of Internal Medicine as of Professor Michael Halleck at the University Hospital of Cologne in 2016. In 2020, he has also joined the laboratory of Professor Charles Saunton at the Francis Crick Institute in London as visiting scientist. He worked as coordinator physician and principal investigator for national and international phase 1 to 3 trials, in addition to the clinical trial work. He will gonna talk about optimizing therapy for CLL, a common and almost daily practice in our clinics. Dr. Uthman Al-Sawaf.
Thank you for the generous introduction. Thanks everyone for having me. It's a pleasure to talk today about optimizing frontline treatment of CLL. And I'm sure you all have, as you said, you see CLL on a regular basis. It's a quite common condition, but probably not the most commonly treated condition, as I will show later on. So in CLL, we've seen really over the past few years a lot of new randomized data come in, a lot of new randomized prospective studies being conducted and trying to shape our treatment landscape. And I think this really illustrates, on the one hand, how common the clinical challenge of CLL can be, and also how engaged the community is in really establishing new treatments for our patients. Probably the biggest group of patients with CLL is the group that has no symptoms. So patients that are absolutely asymptomatic, where the diagnosis of CLL was made by accident during an elective surgery, for instance, or in preparation for an elective surgery, and where an increased lymphocyte is noted, and then we as hematologists pick these patients up, and then we do the diagnostics, see in the immune flow cytometry that the patient does have CLL. And then the patient asks what to do. And here we have already the first randomized data from the 90s, where a study was for the first time conducted in CLL in a randomized way, where patients with asymptomatic CLL either received chlorambucil or received watch and wait. And both groups, as you can see in this paper, had the same overall survival. So they didn't really benefit from early treatment initiation. And in our group, then we, over a decade later, started a study, CLL7, which tried to address the same question, but use FCR in these patients. And the most important finding of that study was, as you can see on the right, that patients receiving FCR in the red curve did not live significantly longer than patients who were managed with watch and wait. So again, we see that watch and wait seems to be a fairly reasonable strategy for patients with asymptomatic CLL. And our last attempt was from CLL12. In this study, again, patients with asymptomatic early stage CLL were enrolled, and they were randomized to either receive ibrutinib or to receive a placebo. And again, as shown in the summer congresses just a few months ago, you can see on the right that the patients, the red curves, those who received ibrutinib, did not live longer compared to patients who were managed with watch and wait. Meaning that, again, there doesn't seem to be any signal that patients do benefit from early treatment initiation, and that we really should and have to wait until the disease progresses and becomes symptomatic, because only then do the patients benefit in the long run. So therefore, the treatment paradigm of watch and wait is still valid, and probably will be still valid for the next 10 years or so, I would imagine. And so we recently updated our German Oncopedia guideline, which is the guideline that we mostly use in the German-speaking parts of Europe. And I think it does have some general considerations that probably also apply here to the Middle East. So you can see, as first of all, on the upper left, asymptomatic disease, watch and wait. And then, based on two key stratifying factors, the TP53 status and the IGHV status, we distinguish between different patient groups. In the past, our algorithm looked much more complicated, where we also included things like fitness as a stratifying factor and also included chemomonotherapy as an option. So you'll notice that in this guideline, for the first time, we removed chemomonotherapy and we also removed the distinction between fit and unfit patients. And so the only difference that we have now in terms of the treatment options available is whether the regimen is given as a fixed duration treatment or as a continuous treatment. And for the fixed duration treatments, of course, we have the chemomonotherapy in theory, because this has always been a fixed duration option. We have venetoclax-based fixed duration treatments with CD20 antibodies and BTK inhibitors. And we have continuous approaches with BTK inhibitors. And here we have 3 approved options. If you look back at the different pivotal clinical studies that were conducted in CLL in the frontline setting, you'll notice that you can distinguish between studies that focus on the younger and fitter patients on the left and studies that focused on the elderly unfit patients. And the reason why this distinction was made and why this was relevant at that time is that the patients who were young and fit tend to, or are the only ones that are eligible to receive intensive chemomonotherapy with FCR, whereas the elderly unfit patients, these are the ones that used to get chlorambucil-obinutuzumab, which is better tolerated but less effective than FCR. So the reason why we had this distinction between fit and unfit was particularly driven by the chemomonotherapy component and the fact that we knew that some chemos are more toxic than others. With targeted treatments, though, it's very different. You can see that the targeted agents are being used on the left as well as on the right, and therefore the distinction is not that relevant anymore. So if you look, for instance, at the latest studies that we have, like CLL17 or MAGIC and other studies, we don't have a chemo component there anymore in any of the arms, and therefore we also don't distinguish between fit and unfit anymore. So these are basically all-comer frontline studies. In terms of the BTK inhibition, the continuous BTK inhibition, we have really thousands of patients who have been put into prospective studies. And therefore, this is just one example from the ECOG 1912 study of a study that tested continuous ibrutinib and randomized this against FCR in young and fit patients. The study did show that if you give continuous ibrutinib, you have better efficacy compared to patients receiving FCR. And the interesting aspect about the comparison between continuous BTK inhibition and FCR is that if you look at certain subgroups, particularly the patients with IGHV mutated CLL, you'll notice that they have a similar outcome. And this is very relevant because it means that a patient that has received 6 months of FCR in the blue curve on the right has the same outcome after 5 or 6 years as a patient who has been taking ibrutinib each day for 5 or 6 years and still has the same outcome, even though the FCR-treated patient had a treatment-free remission for 5 years or more. And so this really highlights that if we have a sensible way to give a combination treatment for a limited number of treatment cycles, produce a deep remission, that we can then provide our patients with considerable treatment-free remissions. And this was very recently, just 2 or 3 weeks ago, again demonstrated in this long-term FCR 300 cohort from MD Anderson, where they have now a median observation time of 19 years. And you can still see that in the red curves on the right, the patients who have mutated IGHV status, most of them who remain in remission after 10 years do not develop any relapses anymore. So this really highlights, again, consider that these patients received just 6 months of treatment. They have been in a treatment-free remission for over a decade now. So this, I think, highlights the possibilities that we can get from an active fixed duration treatment. On the other hand, we do have also issues with chemomonotherapy. So we know that particularly after 5 to 6 years, the risk for developing secondary neoplasia is quite considerable. And for FCR-treated patients, which in most cases are young and fit patients, this is of course very relevant, because even if you have an active regimen, a patient who starts FCR at an age of 55 has statistically a very high risk of developing a secondary AML when they become 65 or 70 years. And this is of course much more threatening than a relapse of CLL. So the high efficacy of FCR, and particularly in the mutated IGHV setting, does come at a very high cost. We don't have the same issue with BTK inhibitors, but we have other issues with BTK inhibitors. So we know that they have a distinct toxicity profile. We know that, for instance, with ibrutinib, there's a considerable cardiovascular toxicity in terms of atrial fibrillation, ventricular arrhythmia. We know there are sudden cardiac deaths that have been reported in many studies. We have congestive heart failure, issues with bleeding disorders, issues with hypertension. So these are all toxicities that are quite particular and distinct with BTK inhibitors. So even though they are quite active, ultimately we know from observational studies that this ultimately leads to high discontinuation rates. And so one way to address this issue is to use next-generation BTK inhibitors. This was the primary rationale for the introduction of agents like acalabrutinib and zanubrutinib, that they have similar efficacy but but a more favorable toxicity profile. So this is from the ELEVATE-RR study, a straightforward head-to-head randomization between acalabrutinib and ibrutinib in relapsed CLL. And they showed that they have exactly the same median PFS, as you can see, 38.4 months in both studies, so non-inferiority, but less toxicity with acalabrutinib. So you can see over the time, for instance, on the left with atrial fibrillation, hypertension, and below on bleeding events in the purple curves, they are significantly less common than with ibrutinib. So in that sense, an agent that is better than ibrutinib in that regard, even though we need to appreciate that over the time, as you notice in these reversed Kaplan-Meier plots, the risk does also increase with acalabrutinib. So up to 40% of patients, for instance, develop bleeding events with acalabrutinib, which is still more than you would expect with chemotherapy, for instance. So therefore, as clinicians, we need to be aware when we have patients that are at an increased risk of bleeding due to their comorbidities or due to their co-medication, that we need to be aware of this issue also with acalabrutinib, even though it is more favorable than with ibrutinib. With zanubrutinib, we have another covalent BTK inhibitor that is also supposed to have less off-target effects and therefore reduce the risk of these side effects. And this is from the ALPINE study, which also had a randomization between zanubrutinib and ibrutinib in the relapsed setting, and where there were significantly fewer atrial fibrillation events than with ibrutinib. Other toxicities like bleeding events, for instance, or hypertension were equally common with between zanubrutinib and ibrutinib. So the only difference here is really the atrial fibrillation. So overall, again, it is more favorable than ibrutinib, but the advantages are a little bit more limited than with acalabrutinib. The difference, though, is that with zanubrutinib in the ALPINE study, there was also they also detected an efficacy superiority in terms of the response rate as well as the progression-free survival. Now, we need to be a little bit careful, in my view, because there are some statistical caveats in the study design that, in my view, I'm not 100% convinced that this is really more effective than ibrutinib. I think there are too many statistical caveats in the data set. So my conclusion from the ALPINE study is that zanubrutinib is at least as effective as ibrutinib, but certainly less toxic. So therefore, I think acalabrutinib and zanubrutinib are more or less, when it comes to clinical decision-making, equal agents. In terms of the combination treatments that we have, there the data are still more limited than what we have collected over the last decades in terms of continuous BTK inhibitors. So the key established combination regimens are venetoclax with obinutuzumab or with ibrutinib in the frontline setting. And you will notice that with all agents that are currently under development and in the pipelines of drug manufacturers, you'll notice that all, or virtually all, are being explored in one way or another as a fixed duration or limited duration regimen. And the reason for this is that the rationale is quite clear and the advantages that fixed duration treatment has are quite evident. So you expect to have less toxicity because the patient has to stay on treatment for a shorter time. You have less drug exposure. You have less, a more limited health economic impact by having a limited drug intake. We have less resistance development, which potentially could allow us to retreat patients eventually at some point when they relapse. So a lot of advantages in that regard. So one study that looked at fixed duration targeted treatment in the frontline setting for the first time with fixed duration treatments was CLL14, focusing on elderly unfit patients and comparing this to chlorambucil obinutuzumab and demonstrating, as you can see on the right, a longer progression-free survival. This is from the very recent data cutoff that we made and showed in the summer congresses, where we see that at 6 years, still over 50% of the patients are still alive and in remission, even though they have been without any treatment for more than 5 years now. We do notice that there are some subgroups like the TP53 aberrated disease where the efficacy is still more limited. So TP53 is prognostic also when using venetoclax obinutuzumab, and it is also prognostic, of course, in chemoimmunotherapy. But still, if you look here in the median PFS and for the dashed line, the patients who have TP53 aberrations, you'll notice that the median PFS is 52 months. So still over 4 years of disease control in half of the patients. So I think, therefore, it's still an active regimen for this group of patients. With the unmutated IGHV status, there seems to be, again, a prognostic impact, even though the disease, again, is quite well controlled with venetoclax obinutuzumab. Median PFS here is 65 months. And what's also particularly valuable is the time to next treatment. So not just the time until a progress develops, which in most cases can be managed with watch and wait, but the time until the disease actually becomes symptomatic. And here you can see again on the right that at 6 years, over 60% of the patients are still alive and did not require a next line of treatment. And bear in mind that these patients in this study have a median age of 77 years now. So this means that most of the patients in the venetoclax arm in CLL14 will only require 1 year of treatment in their whole lifetime because they are already now at such an advanced age. And in terms of overall survival, even though the difference is not yet statistically significant, we do see that the curves do separate and that there seems to be an advantage, particularly when it comes to the actual CLL-related mortality when using BCL2 inhibitors in the frontline setting. In terms of MRD, this is still, I think, rather exploratory and something that's not necessarily widely used in clinic. The important aspect here being that we can discriminate by the MRD status at the end of treatment between early and late relapses. So in the red curve here you can see patients who remained MRD positive after venetoclax obinutuzumab, which was roughly 15% of the patients. So not a huge group, but still a relevant one, because these have a median relapse time after treatment of roughly 2 years. So these are the ones that will eventually also develop an early relapse, and this information can be useful for some patients in the clinical management. And in terms of toxicity, this is also one thing that, as I showed in the beginning, is one of the key rationales of having a fixed duration treatment, the fact that when you stop treatment, you virtually don't have any toxicity anymore. This is true on the right for chlorambucil, but also for venetoclax. As you can see, after treatment, we don't pick up basically any toxicity anymore. And so this is a clear advantage to the continuous strategies where over time, the cumulative incidence of certain toxicities does increase. And then we also ran CLL13, which is the counterpart of CLL14, because this study focused on the younger and fit patients. So in this study, the comparator was FCR and BR, as you can see above, and there are a couple of combination partners with venetoclax, including rituximab, obinutuzumab, and also the triple regimen of obinutuzumab and ibrutinib. So a lot of different hypotheses that are addressed in this study. The main finding being, though, that venetoclax and obinutuzumab, with or without ibrutinib, in the right two columns, provides substantially deeper remissions. 87% of the patients became MRD negative compared to just 52% with FCR. So clearly deeper remissions, and this very clearly translates also into longer progression-free survival. So as you can see in the red and in the black curves above, those are the ones that received venetoclax obinutuzumab with or without ibrutinib, and these had the longest progression-free survival, even more so than chemoimmunotherapy, our most effective chemoimmunotherapy basically. In terms of toxicity, we picked up already one interesting signal, which is that even though the observation period is just 39 months or so, we already now have numerically more secondary malignancies in the chemo arm than with venetoclax obinutuzumab. So including 4 heme malignancies, including secondary AML that already occurred in the FCR arm, whereas we didn't see any of this with venetoclax obinutuzumab. So this again is a signal that the risk-benefit ratio of targeted treatments might be more favorable. And then very recently, we also have now the combination of venetoclax with BTK inhibitor, with ibrutinib. And this is, of course, the key difference here to venetoclax obinutuzumab being that this is an all-oral regimen without any infusions that is given over a fixed duration. And this is in fact the only way at the moment by which we can limit the exposure to ibrutinib, or any BTK inhibitor for that matter. All BTK inhibitors are given continuously until treatment progression, and by combining with venetoclax we are able to stop the therapy. And you can see this first in the Captivate study, which is a phase 2 study, which showed very nicely that for patients who received venetoclax and ibrutinib and who became MRD negative, if you give them a placebo, their disease-free survival and progression-free survival is non-inferior to patients who continued on ibrutinib. So this is really a very clear prospective proof that a patient who achieves MRD negativity does not need continuous treatment because their outcome will be the same. And even when you look at MRD rates, for instance, as illustrated here, you can see over the different periods of time until 36 months after randomization, the MRD rates are similar between patients with placebo and with ibrutinib. So this means that continuing ibrutinib doesn't even deepen the remissions compared to just taking a placebo. So I think a very powerful illustration that MRD negativity really allows you to stop treatment in this particular context. And then we have the phase 3 GLOW study, which also used ibrutinib with venetoclax as a fixed duration for roughly a year and compared this to chlorambucil obinutuzumab. Again in elderly unfit patients, and you again see a clear efficacy superiority, 75% of the patients being alive and in remission at month 42. So clearly better than chlorambucil obinutuzumab. We again see that the MRD status tends to discriminate between early and late relapses. We again see that things like unmutated IDHV tend to be prognostic in the context of fixed duration treatment. And also in another data set from the Captivate study, we see that things like TP53 are also associated with shorter progression-free survival. So it seems that these high-risk features in the context of fixed duration treatments tend to be more prognostic than they are with continuous treatments. In terms of toxicity, again, we do see in the GLOW study that after end of treatment, there is virtually no toxicity anymore. So again, the proof that if you have a fixed duration strategy, you have less toxicity or basically no toxicity once you stop treatment. The issue being, though, that with ibrutinib and venetoclax, there is still some of the ibrutinib-related toxicity observed, even though it is just given for roughly a year. So you can see that higher grade atrial fibrillation occurred in 6.6% of the patients, and I think 12% or so overall atrial fibrillation rates. Also things like diarrhea occurred in up to 60% of the patients. So the toxicity profile is still relevant, even though the administration is just given for roughly a year. It is still a regimen that is particularly in elderly unfit patients, can be a challenge. So in our treatment algorithm, we tend to, when we use it more in the younger and fit patients, even though the GLOW study is conducted in elderly unfit patients. And therefore, in our guideline, we basically distinguish more or less between the hierarchy of using more continuous treatments or more fixed duration treatments, depending on whether the disease is more low or high risk. But I think we might still have to revise this a little bit more because we expect to show more data at ASH regarding the fixed duration treatments. But ultimately, I think this shows that most of the patients can be managed very well with these targeted therapies, but we still have a lot of different questions that we need to address. Things like the question of which group of patients really benefits more from fixed or continuous treatments, implementing MRD and these kind of parameters. So there are a lot of different clinical studies looking into these aspects. The MAGIC study, which is a global study run from the US, where they are comparing acalabrutinib plus venetoclax to venetoclax obinutuzumab, both arms in an MRD-guided way. So this is more exploratory, but still, I think, will be a valuable data set. We are currently setting up CLL18, which will start end of next year, so late 2024, where we randomize venetoclax obinutuzumab to pirtobrutinib venetoclax with and without MRD guidance. So this is again a little bit more exploratory. We have CLL17, which is already fully enrolled with over 900 patients, where patients either receive continuous treatments or fixed duration treatments. So this will ultimately be really the ultimate data set to answer questions related to fixed versus continuous treatments. And then I know that the ECOG and the Alliance cooperative groups are currently setting up also studies comparing MRD-guided strategies to fixed duration or continuous treatment. So we will see more activity in that area as well. So with that, let me just quickly conclude. Based on the data that I showed, I think we can see that targeted therapies have really, across all groups of patients with CLL, have shown superiority over chemomonotherapy. Most of the patients that you diagnose with CLL in 2023 here will have a good disease control, a long-term disease control with the agents that we have, but there are still relevant subgroups like the ones that remain MRD positive, the ones that have very high risk features like TP53 aberration plus unmutated IDHV and so on. These are the ones that are probably more tricky to manage and to offer a long-term disease control. So I think this is the area where we are more and more focused now to improve the treatment outcomes. So with that, I would conclude. Thank you very much for listening, and I look forward to the panel discussion later on. Thank you.
Thank you, Dr. Othman. We'll have the question at the end. Dr. Othman started his talk with 2,000 on the online attendee, and I'm glad to see all our colleagues here from Al Faisal student to fellows and the pharmacists, and this is what really the Saudi Society of Blood Disorders is happy. This society is meant to have to be for all the Saudi hematologists, not attached to any university or any certain hospital. And the meeting is really great, and I want to thank them for inviting me to moderate. It's my pleasure now to invite the next speaker, Professor Marina Konopleva. Professor Marina is a professor in leukemia program in MD Anderson, Houston, and as well in the Montfire Medicine and the Montfire Einstein Center in New York. Professor Marina received several awards, and she's appointed many current positions in research. She's starting research more than 20 years ago in several parts, and today Prof. Konopleva will present her insight into the BCL2 resistant in acute myeloid leukemia, a big and challenging problem facing our patient on a daily basis. Prof. Marina will join us virtually. Please, Prof, proceed.
Hello, this is a real pleasure to be invited to this annual Saudi Hematology Congress meeting. And I would like to present for you today some of our research into mechanisms of resistance to BCL2 inhibition. These are my disclosures. And I would like to start with the mechanistic schema, how BCL2 inhibitors work. Let me get a laser pointer. So it's based on the dimerization between and interactions between anti-apoptotic BCL2 family members, such as BCL2, that control mitochondrial integrity, and pro-apoptotic family members, most commonly as BEM or BAX. So in the tumor cells, there's a high expression of BCL2, and the tumor cells are thought to be primed, which means that they are pre-bound with these pro-apoptotic family members. And if you have a drug such as BCL2 inhibitor known as venetoclax, it binds BCL2 and results in the release of these pro-apoptotic family members that induce cell death. However, if there's a clone that overexpresses a BCL-XL, MCL1, or other anti-apoptotic family member, or if there's some epigenetic upregulation of this proteins, then despite the fact that the drug is still bound to the BCL2, there's relocalization of BAX and BIM to these other family members, and as a result, there's no cell death, there's a resistance. So, of course, these are the results of the randomized azacitidine venetoclax trial that were presented at ASH last year, long-term follow-up. And unfortunately, what we realized that this therapy, despite being really powerful and revolutionary in older unfit for chemotherapy AML, it's not really curative because, as you can see, there's still a significant difference between azacitidine and the combination. However, patients continue to relapse long-term, and the cure appears to be less than 20%, which indicates rapid development of resistance. So we put together this slide that I will go through in a few minutes that displays most commonly recognized mechanisms of how that happens, and it's occurring on multiple levels. So as I mentioned, the most common mechanism of resistance is because of the overexpression of other family members. Now, how that happens, this could be driven by what we call signaling mutations, and I will give you examples of both FLIX3-ITD and RAS mutations. There's also data that monocytic state can be associated with upregulation of specifically MCL1 and BCL2A1. And then there are other mechanisms of resistance. BAX is required for the induction of cell death, and the team at Australia found the mutations in the BAX. I will show you that slide in a moment. Then there's a deficiency of the BAX, whether it's on the protein level or RNA level. And this is most commonly caused by the mutations in the gene called TP53 that results in the deficiency of both BAX and BAG. And this is actually one of the most common mechanisms of resistance to cell death. In addition, there are data that mitochondrial structure plays a role, and I will present it to you in a second. So these are the mechanisms of resistance that I will show you in the next few slides of my talk. So again, starting with the BAX resistance, this was presented and reported in Blood 2020 by the team of Andrew Way and his colleagues from Australia. I haven't seen the follow-up reports. However, what they showed is that the mutations in the BAX, most commonly in this P168A mutation, results in the inactivation of BAX, inability to go to the mitochondria and cause permeabilization of the membrane. They identified these BAX mutations in about 17% of patients who progressed on venetoclax-based therapies. And the location could be different, but most commonly in this BH3 binding domain. So at least this is something that we are not routinely looking for, but perhaps we should be looking and doing the sequencing to identify this BAX mutation and how they're associated with genetics, and all those questions remain unanswered. Going back to this mitochondrial structure, so this is a work from Yannis Saifantis' group from NYU that was published in 2 cancer discovery papers in 2019-2023. In the original paper, they generated the venetoclax resistant cells, and they showed that the mitochondrial structure becomes much more tighter, as you can see here. And by protein analysis, they identified upregulation of the protein called ClpB, which is important for this structure. So what happens is the crystals are more narrow, and that results in the delay of the cytochrome C release and resistance. If you silence this protein through a guide RNA CRISPR approach, you can see that you can partially reverse the sensitivity to venetoclax. And then in most recent subsequent talk, a paper that just came out recently, they did the CRISPR screen and identified a number of the proteins that are involved in the process of what we call mitophagy. So this is depicted here, and is essentially when BH3 mimetic work, there is a damage to the mitochondria. However, this damage can be repaired by removal of this damaged mitochondria and selection of the healthy mitochondria. And this process is called autophagy. So you end up with perhaps fewer mitochondria, but they have fitter structure and they can resist cell death. They identified several proteins that are involved in this process, and there's a research ongoing to knock out some of the, or silence, inhibit some of these proteins, such as MFN2. Going back to the previously identified more common mechanism of resistance, in the original study where we combined the data from low-dose venetoclax and Vidasa venetoclax study, we identified 2 mechanisms of resistance to venetoclax. So the first one were mutations in P53 associated with chromosomal aberrations, complex karyotype, deletion of 17p. And this is, as you can see, in patients who are relapsing or primary refractory. This is a majority of the patients presenting with these mutations or complex karyotype. The second is what we call signaling mutations that were identified in a smaller number of patients. And for example, FLT3-ITD, by single-cell DNA sequencing, this mutation can go down. However, it gets selected and presents resistance to the venetoclax treatment. So of course, we first pointed out to these mutations, and this was confirmed in the recent analysis of the ASHC study, again presented by Hartmut Donner at ASH 2022, where he looked at the utility of ELN22 classification and found that it was not quite useful for predicting resistance to HMA venetoclax. However, he identified novel sort of patterns of resistance, and they were similar to what was reported before. So the worst case is a patient who has P50 mutation. You can see here survival is about 5 months. And then there's an intermediate cohort with patients who have either FLT3-ITD or RAS mutation, and these patients are doing also not well. And then there's a group that is doing better, and these are patients who have wild-type P53 and no signaling mutations. So FLT3-ITD, just to start with that, is a signaling mutations, as you know, one of the most common mutation in AML. And the reason why the cells are resistant is because downstream of FLT3-ITD is a multitude of signaling pathway, which eventually led to the stabilization of MCL1 through both transcriptional upregulation through STAT5 and also the protein stabilization due to reduced degradation of the protein. Fortunately, we now have approved FLT3 inhibitors, and since this is upstream, if you block FLT3 with some of these inhibitors, this is I think the AC220 or quizartinib, you get some downregulation of MCL1, but you're also getting upregulation of this protein called BEM. And if you recall from my initial schema, this is a pro-apoptotic protein which can in fact bind to MCL1 and inhibit its function. So if you use the BHC profiling assay, you can see that in the resistant cells with the treatment of different FLT3 inhibitors, there's a switch towards BCL2 dependency as shown here and higher sensitivity to venetoclax or ABT199. This is depicted here in the cell growth assays when the combination of quizartinib and venetoclax results in near complete elimination of cell growth. And this was seen also in vivo in this model of cell line, but also subsequently in PDX models that were conducted where venetoclax plus quizartinib inhibits the tumor growth. So this led to the combination of FLT3 tyrosine kinase inhibitors and venetoclax with the different TKIs such as gilteritinib and quizartinib. And in fact, this was seen in the clinical data. So the analysis of the VIALE-A study showed that while in general, patients who have FLT3 mutation, they are responding better to the combination of venetoclax compared to azacitidine alone. This is essentially limited to patients who have tyrosine kinase domain mutations. However, patients who have FLT3-ITD, they essentially have no benefit from this combination treatment. So going back to the new treatments, again, the introduction of combined venetoclax and gilteritinib in the relapse refractory setting resulted in the high response rate of about 80%. This is now published in JCO of this past year. Remarkably, that patients with prior TKI exposure were similarly sensitive as compared to all cohorts. And if you can get these patients towards stem cell transplantation, in fact, patients can enjoy long-term survival. However, there are some resistance mechanisms that were also described last year, and some of them are related to RAS mutations. However, in the majority of the patients, this combination led to the reduction of the FLT3-ITD VF in all 14 patients looked at. So since then, there is now what we call triplet therapy for all the patients unfit for the induction chemotherapy, which combines azacitidine, venetoclax, and gilteritinib. And this is a report from MD Anderson group at ASCO of 2023, where they showed very high response rate of 100% with this combination, high rates of proceeding towards allogeneic stem cell transplantation, and estimated 2-year survival of 71%, really unparalleled data compared to the historical control. However, this combination is quite myelosuppressive, so there is a reduction of the doses of both gilteritinib and venetoclax required, especially if you go long-term, to be able to keep patients on study. So another example of signaling mutations is upregulation of RAS-MAP kinase pathway. And this is work from our lab where we generated venetoclax resistant cells and performed all kind of analysis, genomic analysis, proteomic analysis. And one of the strongest pathway that was upregulated is MAP kinase pathway. We confirmed that on the protein level as it's seen here. And as a consequence of this pathway, again, the MCL1 protein was upregulated in all the 3 resistant cells compared with the control cells. As you can imagine, if you treat cells with MCL1 inhibitor, the cells are actually sensitized to venetoclax and are being killed. The most common mechanism of upregulation MAP kinase pathway in AML is RAS mutations. And looking at the patients who progress on the study, we showed using the single cell DNA sequencing, again, selection of this RAS mutation, KRAS, NRAS, and PTPN11 mutations in several patients we looked at. We also confirmed that there is upregulation of MCL1 in some patients, reduction of BCL2, as shown here in this exemplary patient. We then engineered AML cells to express inducible RAS mutation and show that the cells become resistant to venetoclax compared to control. But again, they remain sensitive to the MCL1 inhibitor and the combination with venetoclax. And this was seen also in the in vivo models of this cell line derived with NRAS G12D mutation, when only the combination reduced tumor burden and reduced the AML development. However, as we know, the MCL1 inhibitors are not currently approved yet for therapy, and they're associated with on-target troponin release, so which prevented their further development. The studies are still ongoing. So finally, going back to the p50 mutation, as I mentioned, this is the most common mechanism of resistance to venetoclax. It's the same schema that I showed you previously. These are patients who have p50 mutations or complex karyotype, and they're selected by the treatment very quickly. So the Dr. Wei's group, using again single-cell DNA sequencing, show that these mutations here in red, also this KRAS mutation, are being upregulated or rather selected by the venetoclax therapy, and this is sort of universal in all patients. He also showed in his plenary paper in Blood 2021 that if you use the combination of BCL2 and MCL1 inhibitors, you actually get enough release of pro-apoptotic family members such as BAX and BAC, and that results in the cytochrome C release and cell kill. So you can in fact overcome this by combination of these 2 BH3 mimetics, and this was later confirmed by the work by Michael Andreev's group, which similarly showed that in cells they have knockout of p50 or p50 mutation, combination of MCL1 inhibitor and venetoclax here in black results in synergistic efficacy, cytochrome C release, and the marked extension of the survival both in the cell line model and also in PDX. But again, we don't have MCL1 inhibitors, so what else can we do? In our lab, we elected to look at the combination of venetoclax with immune therapy. In this case, this is inhibiting CD47 or don't eat me signal. So very quickly how this works, so the cancer cells express high levels of CD47, which prevents phagocytosis by the immune cells such as macrophages. So the antibody that was developed called magrolimab can inhibit the CD47 and results into the engulfment by the macrophages, which is shown here beautifully when the macrophages start to engulf green tumor cells. We decided to look at that because in the initial phase 1 study in p50 mutated AML, there was high response rate and very respectable 6-month survival that was presented previously. So we went back to the lab and looked whether the combination of venetoclax, azacitidine, and magrolimab can actually work together. And we showed that in this model, this is not p50 mutated model, but just a model of signaling mutations AML. Both veneza and magrolimab have some activity, but the combination was doubling survival. So this eventually translated into the clinical trial that was led, investigator-initiated trial by Dr. Naval Davar at MD Anderson, and they included both p50 mutated and wild-type patients, and they showed that even the p50 mutated patients had high CR/CRi rate, and perhaps improved overall survival, which is shown here. Of course, the data were still inferior compared to the wild type patients who are presented here in the top. So this is now ongoing as a phase 3 trial led by Gilead that randomizes the azavan and the magrolimab in the triple combination. But perhaps some of you are aware that at least in MDS, magrolimab recently failed to reach the endpoint, and the studies were placed on hold till further review. So finally, I wanted to talk to you in the last few minutes about the cell state and how that may impact the resistance to venetoclax. And I would like to show you the example of this acute erythroid leukemia. So acute erythroid leukemia in WHO, it's obviously triggered by the proliferation of these erythroid cells, and they have very high frequency of PVC mutation, very poor survival of about 5 months. These patients are refractory to the chemotherapy, and unfortunately also refractory to venetoclax. So the recent report from the group of University of Helsinki, where we collaborated with, has shown that these cells have, by the CRISPR screen, high dependency on BCL2L1, which is a gene encoding for the protein BCL-XL. Again, venetoclax does not target BCL-XL. This was confirmed here, and also by use of the BCL-XL inhibitors, which had a significant efficacy in this erythroid leukemia cell lines, also in megakaryocytic leukemia, AML. If you look at the gene expression data in different available gene sets, you can see that this former FIB category of M6, which is erythroid leukemia, or M7 megakaryocytic leukemia, they have very high levels of BCL-XL compared with any other AML. This is TCGA, this is HEMAP, the same with the M6 have high levels of expression, and this is St. Jude cohort, which show the same data. And they also show that using the tool inhibitors in this HEL cell lines, you can get single agent efficacy. However, the development of BCL-XL inhibitors has been also struggling because of thrombocytopenia, which is on-target toxicity of this type of drugs. So in our group, we have been looking at the efficacy of the PROTACs. So BCL-XL PROTACs, they're being degraded through, in this case, VHL-E3 ligase, and this is a structure of this complex molecule that binds BCL-XL. So the reason this PROTACs avoid thrombocytopenia is because VHL-E3 ligase is expressed in tumor cells, but is not expressed in platelets as shown here. And consequently, there is no thrombocytopenia if you use this product. So our recent data indicate that while this erythroid leukemia and megakaryocytic leukemia, they're totally refractory to venetoclax here, shown here in green, they're quite sensitive to this BCL-XL product called DT2216, which is in clinical trial, and also to the new generation BCL2 BCL-XL product 753B. And this is a tool molecule navitoclax, which is again still in clinical trials, but it's not yet approved for therapy in AML. So I would like to end my talk by postulating that survival in AML is generally BCL2 dependent. However, there is a codependency on BCL-XL and MCL1, and that affects the resistance that can develop with the treatment. The resistance can be multifactorial and is most commonly associated with PVC or signaling mutations and also the differentiation state. And this is downstream reflected through the deficit of activators such as BAX, which could be due to PVC mutation or actual BAX mutations, and or switch to other anti-apoptotics such as MCL1 and BCL-XL, which is seen with the signaling mutations and differentiation state. We think that using the products, at least for BCL-XL therapy, is quite effective and avoids thrombocytopenia and can be used in certain ven-resistant subsets. And of course, we are still hoping that MCL1 inhibitors will be coming through in the clinical practice. We also look at the combination with immune therapies that I've shown you here, and the novel treatments that are being thought of are direct BAX activators or inhibitors of mitophagy that are being studied in preclinical space. So I'd like to thank you for listening and acknowledge my collaborators at the MD Anderson, both in the lab and in the Department of Leukemia. I recently moved to the Montefiore Einstein Cancer Center in Bronx, and I would like to thank my collaborators here and multiple collaborators across the country and the globe, particularly Tony Letai, who has led the seminal discovery in BCL2 field, and co-developed another clocks with our team. Andrew Way in Melbourne, Australia, showed you a lot of data. We have collaboration with the St. Jude, with Charles Mulligan and Larry Yakubuchev on the AEL, with Dr. Zhou, who developed the PROTAC. He's now at the University of San Antonio, with a team of Yanis Aifantes, and of course, industry partners and funding. So thank you for your attention. I'm happy to answer questions.
Thank you, Professor Konoplova. We'll have the answer at the end of our session. And thank you for this excellent presentation, or summarized venetoclax resistant, which actually I think increasingly we're facing as we increase using the venetoclax in our management. For our next presentation, I would like to welcome Professor Animesh Bardanani. He's an instructor in oncology and consultant hematology in Mayo Clinic, professor of medicine in Mayo Clinic University. He's finished his PhD program in molecular medicine. He will talk about mastocytosis. I think it's a rare and I think it's underdiagnosed, especially in our region. Thank you, Professor Bardanani.
Thank you for the invitation. I really appreciate the warm welcome I've received in Riyadh, and so thank you. So the topic I've been given is systemic mastocytosis. It's a rare disease, but I think in the next 15-20 minutes I want to convince you it's an interesting disease. So I have no disclosures. So the learning objectives are discuss recent updates to diagnosis and classification. Number 2, describe a practical approach to prognostication. And number 3, select a rational approach to treatment of mostly advanced mastocytosis. That's what I see in the clinic in hematology. So first, some background, because I imagine people may or may not be very familiar with the disease. So mast cells are derived from bone marrow progenitor cells. These cells are born in the bone marrow. They circulate for a short amount of time in the blood, and then they live in the tissues where the body comes into contact with the environment. So it's the skin, it's the mucosa of the gut, the respiratory tract. And we should be clear that mastocytosis is technically a malignancy. So it's a clonal proliferation of neoplastic mast cells. So what do mast cells do? Well, they have a role in innate immunity, but on the dark side, they also mediate allergic reactions, which can be very severe. So mast cells, we'll pretend the cell on the top left is a mast cell. It's a round cell, and it has these multiple granules, very basophilic granules. And these granules contain lots of mediators: histamine, tryptase, heparin, chemokines. So when these mast cells are triggered, they degranulate and they release these chemicals into the circulation, as you can see on the bottom right, and that produces the symptoms of mast cell disease. So when should one suspect that your patient has mastocytosis? Well, a fairly high proportion of patients will have a very characteristic skin rash, which is shown on the left. This is called urticaria pigmentosa. And these lesions are rich in histamine. So on the top right, as you can see, if you rub these lesions, many a times the histamine will be released and there will be a hive or an urticarial reaction, which is called Darier's sign. Mastocytosis patients also have other symptoms like peptic ulcer disease because of all the histamine release. They may have flushing because of prostaglandins. But the most severe complication is anaphylaxis. This can be life-threatening. Patients can have sudden circulatory collapse, syncope. This can be life-threatening. And it can be triggered by various things, some new drug that they started, an anesthetic that they received, or a insect bite, a bee sting or a wasp sting, something like that. So it's very important to educate every mastocytosis patient about this risk and make sure they know how to deal with it, how to avoid the triggers. And if the symptoms start, every mastocytosis patient should be prescribed two epinephrine auto-injector pens so that they can use it immediately to stop the anaphylaxis reaction. These patients can have also a lot of bone morbidity. So, accelerated osteoporosis, they have lytic lesions. These can lead to pathologic fractures. So let's quickly talk about the diagnostic criteria. This slide shows you the criteria. You have one major diagnostic criterion, and then you have 4 minor criteria. So to diagnose somebody with mastocytosis, you need to satisfy either one major plus one minor criteria or 3 minor criteria. So this slide shows you the major criterion. So these are sections of bone marrow biopsy, and on the top left you can see an H&E stain. Now it's hard to see, but what you should be able to make out is a cluster of mast cells, and it's actually a whorl of cells. At the periphery, you can see that these mast cells are not normal round-looking mast cells. They're more spindle-shaped. They're elongated with flat nuclei. And of course, the mast cells can be more easily delineated when you use sensitive stains like tryptase or CD117. And these stains should be used to assess the bone marrow biopsy sections in every patient that you are evaluating for mastocytosis. One of the minor criteria is demonstration of aberrant or abnormal expression on mast cells of certain markers. These include CD25, CD2, and most recently CD30. And this can be demonstrated either by flow cytometry or immunohistochemistry. A very important minor criterion is demonstrating the presence of activating mutations in the c-KIT receptor in mastocytosis patients. So the c-KIT receptor is the main growth factor receptor that promotes survival and proliferation of mast cells. And virtually all adult patients will carry that mutation highlighted at the bottom in yellow. This is the D816V mutation. It is present in over 90% of patients with mastocytosis, and it's considered the driver mutation for the disease. There are some other mutations also in other domains, but this is the main one. And the final minor criterion is demonstrating an increased serum tryptase level. So for the purpose of the diagnosis, the cutoff is 20 nanograms per mil, and it is fairly specific as long as you're measuring this at baseline, so when the patient is not having symptoms, and if you can show that it is persistently elevated. Okay, so now we've diagnosed the patient with mastocytosis. How do we classify the patients? So this slide is more complicated than it needs to be. I'll try and simplify it. So basically, there are 2 forms of mastocytosis. First is cutaneous mastocytosis, where you see the disease is only in the skin. And you almost never see this in adults. This is purely a pediatric disease. What the adults mostly have is systemic mastocytosis. So there the mast cells involve the skin, but they also involve bone marrow and other internal organs. And systemic mastocytosis is of 2 broad types. There's the indolent mastocytosis, which is a low-grade disease. So mostly patients have nuisance symptoms, but no significant organ dysfunction. And then you have advanced mastocytosis. That itself is of 3 types. So one is aggressive mastocytosis, where you have organ dysfunction from mast cell infiltration. Number 2 is mastocytosis with an associated myeloid malignancy. So you might find mastocytosis with MDS or with CMML or with acute leukemia. And lastly, there is an entity called mast cell leukemia, which is extremely rare. So, one question when I started studying this disease is why so many disease subtypes? You have just one driver mutation, but then you have all these, disease manifestations. And the way I conceptually think about it is, think about patient 1, okay? Patient 1 has only one mutation, the KIT mutation, and there's only one blood lineage involved, that's the mast cell lineage. So this is the patient who will develop indolent mastocytosis. In contrast, if you consider patient 2, that patient still has just that one single KIT mutation, but now you have multiple hematopoietic lineages involved. And this is a patient more likely to develop smoldering mastocytosis or even aggressive mastocytosis. The extreme is the patient number 3, where you have multiple mutations, so KIT mutations and other mutations, and also multiple lineages involved. And this is the patient who will develop mastocytosis with an associated myeloid neoplasm. So again, these are hypotheses. These are one way to think about the disease. So in terms of how do you determine disease subtype, what subtype does your patient have? There are just 4 steps. It's quite straightforward. So the first step is to make sure your patient does not have mast cell leukemia. That is fairly straightforward to do because your pathologist will exclude presence of very immature metachromatic blasts, etc. Once you've excluded mast cell leukemia, then the next step is make sure that your patient does not satisfy diagnostic criteria for an associated hematologic neoplasm, such as CMML, etc. That I just talked about, you already have a good idea of the patient's prognosis. So these are survival curves. The curve in red are patients with indolent mastocytosis. These are actually the most common adult patients. So these will be about 45% of all mastocytosis patients, and they have a normal life expectancy or close to that of healthy controls. The middle 2 curves are patients with associated hematologic neoplasm or aggressive mastocytosis. Their median survival is about 2 to 4 years. And the 4th category, mast cell leukemia, you can barely see the curve. It's actually hugging the y-axis, and the median survival is only 2 months. So that's how aggressive this disease is. So, of course, the scientific community has worked to develop better prognostic models for mastocytosis. I can't go through all of them. I've listed some of the common prognostic models at the bottom of the slide with references. But the one we use at our institution is the one on the right. It's the Mayo model. And I like it because it's simple. All you need is the age of the patient and 4 simple parameters: the hemoglobin level, platelet count, alkaline phosphatase level, and serum albumin. And just based on that, you can risk stratify any mastocytosis patient into those 5 risk groups. And we tend to use this model in the clinic. So let's talk about treatment, and we'll focus mostly on advanced mastocytosis. So for this group of patients, you really need cytoreductive therapies. You need to kill the mast cells. Just symptomatic treatment is not enough. And in this slide, I've traced the timeline for development of mast cell cytoreductive therapies over a period of, 30, 35 years. So at the left, you start with the interferon era in the mid 1980s. Then the next era was when cladribine came on the scene, about 2001 was the first report. And then the right side of the screen, I show you the modern era, which is the last 10 to 15 years, with the development of very potent oral tyrosine kinase inhibitors that target that mutant c-KIT protein. There's also a role for stem cell transplant, and I'll discuss that briefly in one of the subsequent slides. So at the bottom right, you will see that in the United States, there are 3 approved treatments for mastocytosis. I won't talk about imatinib, we don't really use that, but the 2 other tyrosine kinase inhibitors are midostaurin and avapritinib. So when you compare avapritinib to midostaurin, I think avapritinib has some advantages in that it is 10 times more potent against the mutant c-KIT protein as compared to midostaurin, and it's also more specific. I wanted to share some of the data very briefly about the avapritinib trials because I think this has changed the treatment landscape. I think it has demonstrated a proof of principle that if you have a drug that can shut down that mutant c-KIT signaling, you can have a very potent anti-mast cell effect. I'm not saying this drug is perfect. It has lots of problems, but I think it has proved an important proof of principle. So the avapritinib approval came from 2 trials. This is the phase 2 trial. So advanced mastocytosis patients, 62 patients were treated at 200 milligrams per day, and the primary endpoint was overall response rate. So you can just look at that box at the bottom left. Overall response rate, 75%, but impressively, about 20% of the patients had a complete response. This is not something we've seen frequently with other therapies for mastocytosis. If you look at the middle panel, this was the secondary endpoint, which is change in the symptom score. So the symptoms significantly improved during treatment, and the patient's quality of life measures also significantly improved. Now this trial, of course, this was very short follow-up, only 10 months. So I want to show you some data from the phase 1 study, which also, data from this study was used for the licensing approval. And here, this was 69 patients, again with advanced mastocytosis. The follow-up was longer, 23 months. So this allowed for the responses to mature. And as you can see in the bottom left, the overall response rate, again, 75%, with a 36% complete response rate and 34% time to response. The on the advanced mastocytosis. The middle panel shows you the very potent anti-mast cell effect of this drug. So mast cell aggregates, remember that was the major criterion, that was eliminated in 77% of patients. The serum tryptase level normalized in 74% of patients. And then look at the effect on the mutation, a very potent effect. So 30% of the patients had a complete molecular response, even when interrogating with a very sensitive PCR assay. So I think, fairly convincing anti-mast cell effects with this drug. So again, quickly to show you, along with the deep clinical and molecular responses, there was also improvement in bone marrow histology. So if you look at the panel on the left, at baseline, you have dense mast cell infiltration in the bone marrow. You treat the patient after 3 to 6 months, the bone marrow becomes hypocellular. But those mast cells now are only in the interstitium. Okay, you no longer see that dense infiltrate. And then after 6 to 12 months, the bone marrow is starting to look normal cellular, and the mast cells that were previously spindle-shaped now start looking round and normal appearing. So, the take-home message is that with avapritinib or avapritinib-like drugs that are going to come in the future, we have the potential for disease-modifying treatment. With avapritinib, we've seen responses regardless of the mastocytosis subtype, whether or not they received prior therapy, and regardless of mutational status. So let's say you have both drugs available, midostaurin and avapritinib. Which one to choose? Well, there's no direct head-to-head comparison, so we can only compare across clinical trials. But if we do that, then avapritinib has a 75% response rate overall, midostaurin anywhere from 20 to 30%. The anti-mast cell effects are more potent for avapritinib, but these drugs also have very unique side effects. So midostaurin, GI side effects, very prominent, nausea, vomiting, diarrhea, frequently lead to dose reductions, holding the medicine, starting it again at a lower dose. Also have to follow for QTC prolongation. When you think about adverse effects of avapritinib, the common ones are peripheral edema and diarrhea, but the ones of more specific interest are noted at the bottom of the slide, highlighted in yellow. So in an older patient, you really have to look out for cognitive changes, memory impairment, dizziness, sleep pattern changes, to even more severe cognitive effects. The other thing that was noted was this signal for intracranial bleeding. So the FDA label says that avapritinib is not recommended to treat patients who have a platelet count less than 50,000. And if your patient has a platelet count less than 50,000, you have to medicate, stop the avapritinib, maybe transfuse the patient, etc. But this is a significant barrier to the large group of patients who have an associated myeloid neoplasm and are likely to be thrombocytopenic from their. But again, we use this agent because the responses are quick. If we need to debulk somebody quickly, we do that. Cladribine also has the added advantage of having effect against an associated hematologic neoplasm. And can be used as a bridge to transplant. So one quick word about the role of stem cell transplant in mastocytosis. Very, very little data. This is the best data we have. 57 patients from 33 centers, and this was published in 2014. This was even before we had these tyrosine kinase inhibitors available. The main message is the overall survival in the top left was 57% at 3 years. But if you look on the top right, the best outcome was for patients who had an associated myeloid neoplasm. So let's say you have a patient with mastocytosis with acute leukemia or a high-grade MDS or myeloid neoplasm. Those are the patients that did best. So the overall survival was 74% at 3 years. And in this study, they found that myeloablative conditioning was better than reduced intensity conditioning. But again, in the tyrosine kinase inhibitor era, the role of stem cell transplant is still sort of unsettled. And the last thing I'll mention is with the transplant data, there was a plateau in the survival curves. Now again, the numbers are small, but there is a hint of that. So I'll end with this slide. This is the summary for the treatment of mastocytosis. I can share these slides with whoever wants them. I can't go through all of this, but I'll just mention indolent mastocytosis because I haven't talked much about it. These patients are a real challenge. As I said, we educate these patients extensively on avoiding triggers for mast cell degranulation. These patients should carry an epinephrine self-injector at all time. With regards to management of symptoms, we do a stepwise escalated management, and we work with our colleagues in the allergy division. So, histamine blockers, leukotriene antagonists, sodium cromolyn, in some patients, short-term corticosteroids. And in severe refractory cases, we have used cladribine, we have used midostaurin. Avapritinib is now FDA approved for treatment of patients with indolent mastocytosis failing, standard treatments. Perioperative management is very important in these patients because, when they go through anesthesia, that can trigger a degranulation event. And it's important to address their bone health as well. So I know it's lunchtime. I'm sorry if I went too long, but it was a pleasure speaking with all of you. And this is my email if you need to contact.
Thank
you.
Thank you very much, Professor. Now we want to invite the speaker, please, if you can come here, Dr. Othman and Dr. Maria from the online. Any question from the audience? Yeah, please, can you provide mic for the questions here? شباب المايك. حد بسمع. It's coming, the mic is coming. So till then, maybe I can ask one question. So Dr. Othman, there is a question from the online about when to stop ibrutinib for patients who CLL was going for autologous stem cell transplant. You will taper or you will maintain, how to manage the ibrutinib prior to transplant?
Yeah, thank you. I'm not aware of any robust data that for this point. So I'm just thinking now about the last patient that we put into transplant. So I don't have a patient in that particular setting in the past before transplant on a BTK inhibitor. We tend to stop our targeted therapies before we start the conditioning by at least 1 week. It depends a little bit on how well controlled or poorly controlled the CLL is on the BTK inhibitor. So if the patient is already experiencing an increase in lymphocytosis, for instance, on the BTK inhibitor, and you are about to proceed into transplant, then I would try to keep the patient on the BTK inhibitor as much as possible, maybe just a few days before you start the conditioning, because we know that in these circumstances, when you stop the BTK inhibitor, usually the patients do get a flare. Whereas if the patient is quite in a stable remission on ibrutinib, then I think it can be safe to discontinue a little bit earlier as well. The only thing we are afraid of are a little bit the interactions between the conditioning and the BTK inhibitor. But again, this is a little bit a data-free zone there.
Yeah, also they ask about the mobilization. So again, for the drug-drug interaction, the clinical pharmacist will assess that. Thank you. Dr. Mansour?
Thank you, Doctor, for the good presentation and informative presentation about systemic mastocytosis. And actually, I want to share our experience in King Khalid University Hospital, because we have 2 patients with systemic mastocytosis, and both of them actually were initially presented with diarrhea predominant irritable bowel syndrome. And they have taken long time before we reached the diagnosis. They started from family physician to medicine to GI with diarrhea and abdominal pain. And after 2 years, they decided to do GI biopsy. When they do GI biopsy, they discovered that they have mast cells aggregate in the mucosa. And they referred it to us in hematology, and we diagnosed them with tryptase was 200 actually at that time when they presented. And we managed them with midostaurin, and they are doing fine now actually, and we are following them with also tryptase level. My question actually, you see this story, I have seen it twice, and I think it's common, and we need to increase the awareness about this disease, not among the hematologists only, but also among GI medicine. Because now we know that GI biopsy has been done frequently, but sometimes nobody are taking consideration of possibility of mastocytosis, and this is why I think it's underreported and underdiagnosed, and the patients suffer. So my question is, again, I need your comment on initial presentation as irritable bowel syndrome, diarrhea predominant, and how to evaluate the patients after treatment.
Yeah, excellent question, and I agree with you that the solution to this is education, education, education. Mastocytosis is a great mimic. It can come in through so many doors. It can come in as a skin rash. It can come in as an allergic reaction. It can come in as irritable bowel syndrome. It can come in as a cancer. So, I think, the clinician who's seeing the patient has to have a high index of suspicion. It has to be in the differential diagnosis. The thing that we use most commonly is the serum tryptase level, and then we have a very sensitive allele-specific PCR that we can send on the peripheral blood. So the sensitivity is 0.01%. So those are some of the main things we use to quickly screen whether or not these patients may have it. Now, the problem is even more complicated. It is not just systemic mastocytosis. Now there are other syndromes that are associated with mast cell activation. There's mast cell activation syndrome. There is hereditary alpha tryptasemia, where there is amplification of the alpha tryptase gene, and that can be also associated with mastocytosis. So I think this is a very complicated field. It is going to keep us busy for many, many years to come. And, I hope that answers your question.
Thank you. Thank you very much. Dr. Mansour.
Thank you very much. To start with Dr. Koropleva, I was wondering, is there any testing in a preclinical models or in vivo models of MAP kinase inhibitor combination with venetoclax and seeing if that's eliminating the resistance and at the same time probably potentiating the efficacy rather than targeting just a FLT3?
Yeah, so we have combination with the MEK inhibitor from Genentech, and that actually translated into clinical trials. The data we had was more in vitro, I have to say, but we did perform clinical trial, which unfortunately was negative, and the reason for that was high toxicity of MEK inhibition and inability to sustain patient on MEK inhibitors. It was mainly GI side effects, nausea, vomiting, diarrhea, and I think so this is a sort of common field and issue with the MEK inhibition. So we need to, we're still struggling with this field as far as MAP kinase mediated resistance, and we are hoping to get perhaps specific NRAS inhibitors or KRAS inhibitors similar to what is being developed in solid tumors. Of course, in AML, the mutations have been different spectrum, so we cannot use the same kinase inhibitors, but I know that there are some in development, or perhaps RAF inhibitors, or there's some literature that using downstream, for example, PLK inhibitors could be highly effective in the RAS mutated setting. So right now we don't have good clinical way to inhibit MAP kinase, but preclinically, yes, if you inhibit MAP kinase, you get synergy with BCL2 inhibition.
So if we are stuck with a FLT3 inhibitor, would you think maybe quizartinib would be a better option given that it kind of more specific work on the wild type and the mutated rather than gilteritinib?
Yeah, that's a great question. As you're familiar with the way data presented at EHA by Paul Montesinos, and he showed that quizartinib in combination with chemotherapy had significant efficacy in non-FLT3 mutated AML. And this is thought to be because of sort of multi-kinase inhibitor, and it has some KIT inhibition properties and so forth. I don't know if quizartinib will have efficacy in MAP kinase-driven leukemias such as RAS-mutated leukemias, but that's certainly something that one can look into.
We'll have one more question, Dr. Amal.
Thank you, Dr. Athman, for your presentation. My question is, what the differences in the KEYNOME mapping of the covalent BTK inhibitors?
I didn't completely get the question. The acoustics are a little bit difficult here.
What are the differences in the KEYNOME mapping of the covalent PTK inhibitors?
Sorry, the differences in what? In the
KEYNOME mapping.
The KEYNOME. Sorry, yeah, got it.
I know.
Sorry. So in terms of the covalent BTK inhibitors, there are often in the presentations you see the different illustrations of the KEYNOME maps and how big or small the inhibitory effect of the BTK inhibitors are on different kinases beyond BTK. And there I think we always need to be careful when we interpret these plots, because there is sometimes you see the illustration of the inhibitory effect on the KEYNOME based on the micromolar of each, on how many micromolars of each compound you use, whereas clinically we know that the doses we give of ibrutinib are different to the ones that we give for zanubrutinib and for acalabrutinib. So we need to normalize these maps in order to really interpret them accurately. So what we can say is that certainly acalabrutinib and zanubrutinib have less off-target effects. We see these quite clearly, especially there are kinases that are inhibited quite substantially by ibrutinib, things like ITK, for instance, ETK, and so on, that are inhibited by ibrutinib and lead to some of the unspecific effects related to things like diarrhea or skin rash. But also we know, for instance, particularly with ibrutinib, this has been also been validated in preclinical models that ibrutinib inhibits CSK in cardiomyocytes, which induces, on the one hand, cardiac insufficiency in murine models and also triggers atrial fibrillation. And so we know that acalabrutinib does barely or doesn't at all inhibit CSK, and therefore that's one of the reasons why we see less atrial fibrillation, for instance, with acalabrutinib. And the same also applies to zanubrutinib to a certain extent. So in that sense, the covalent BTK inhibitors certainly have less off-target effects, but importantly, they still have off-target effects. We know that, for instance, to a certain degree, they also inhibit EGFR to a certain degree, which also leads to things like skin rashes that we see with acalabrutinib and with zanubrutinib, albeit to a lesser extent than with ibrutinib. So in that sense, the effect on the kinome is certainly differential, but more favorable with the next generation ones.
Thank you.
Thank you, everyone. I think we'll end our session for today. For session number 2, sorry. Thank you again for joining us, and thank you for all the audience. We'll have the lunch break for now, and we'll come back at 1:30 after 1 hour. Thank you again.
Thank you.
Assalamu alaikum. Good afternoon, everybody. I think we'll start our sessions. It's going to be two lecture lymphoma followed by two lectures multiple myeloma. So our pleasure to have Dr. John Corvella. He's Associate Professor of Medicine at the University of Toronto and Clinical Investigator in the Division of Medical Oncology and Hematology at Princess Margaret Hospital. It's a pre-recorded presentation. The first presentation will be the role of PD-1 inhibitor in Hodgkin's lymphoma, followed by the role of allogenic stem cell transplant in Hodgkin's lymphoma.
Very much for this opportunity to be with you today. I'm John Curvilla. I'm a hematologist at the Princess Margaret Cancer Center in Toronto, and we'll be talking about the role of checkpoint inhibitors in classical Hodgkin lymphoma in the next 20 minutes or so. Here are my disclosures. So by way of introduction, I can now summarize two large phase 2 studies that studied anti-PD-1 antibodies in relapse refractory classical Hodgkin's lymphoma. These are the pivotal phase 2 data here for both nivolumab and pembrolizumab. And firstly, what I want you to see is that the data here are quite similar. So the overall response rates are about the same, around 70%. The CR rates numerically look a little different and may potentially favor pembrolizumab, as you can see. And you can see the progression-free survival as well looks quite similar at around 14 months, though the median follow-up from the two clinical trials differs a little. Now, looking at the details a little bit, the administration in terms of the frequency, whether that's Q2 or Q3 weekly, Q4 weekly, or even Q6 weekly, have been looked at in different schedules. And again, some have been better studied in solid tumors than hematologic malignancy. Nivolumab has a treat until progression schedule, more typical, but pembrolizumab has a fixed duration of 2 years. But we did need, again, phase 3 trials ideally to try to sort out the role of these drugs more clearly. Now, what else can we see here? When you look at the impact of response, it's important to really highlight that for the minority of patients that achieve a complete remission, you can see much more favorable complete remission leading to better progression-free survival, as you can see with the top curves from both studies here being shown in blue. Partial remission, there still appears to be a good benefit there, and you can see patients with stable disease might often experience disease stability for potentially up to a year, again suggesting the broad effect and benefit from this class of agent. Now I'm just going to summarize one of the randomized trials here, Keynote 204. This was the randomized comparison of pembrolizumab with brentuximab vedotin that was the confirmatory phase 3 trial. This included two patient populations, patients that were potentially stem cell transplant eligible, and thus this treatment, whether it was the PD-1 or brentuximab, was used as a bridge to transplant, and also potentially for ineligible patients where this was used more as a palliative maneuver. Now, I've shown you the progression-free survival here, which is the primary endpoint. You can see a statistically significant benefit for pembrolizumab. The hazard ratio is 0.65. The difference 13 versus 8 months, so clinically meaningful. Still, at this time of reporting, the overall survival data are immature, and we'll hope to be able to discuss that with you in the future. The toxicity profile is similar. I'll show you that now so you can get a flavor for that moving forward. Health-related quality of life was also prospectively studied and favored pembrolizumab. Now, to look at the toxicity here, I'm just going to highlight this very quickly to show you that the toxicity profile of pembrolizumab, and you can conclude nivolumab as well, is slightly different than an ADC like brentuximab vedotin, where the typical things that you see, thyroid dysfunction, fever, itch, fatigue, are all typically grade 1 or grade 2, and you don't tend to see peripheral sensory neuropathy or peripheral neuropathy as more common toxicities, which you do tend to see with the antibody drug conjugate. Looking at immune-mediated adverse events, that's when what you'll see, again, mechanistically, these are more common with pembrolizumab. Again, thyroid issues being the most common, But pneumonitis is the important one that we need to think about as clinicians. And you can see 10.8% in terms of the risk, with half of that being grade 1 or 2. And importantly, half of it also being grade 3 or 4 events, 5.4%. Now, these are patients that can be managed safely with corticosteroids. Again, with higher grade events, pembrolizumab is generally not recommended to be given again. But there were no related deaths from drug-related pneumonitis. So this can be done safely, but clinicians need to watch for this important toxicity. Here's the other randomized trial that we'd hoped to see, Checkmate 812. So this continues to be an unanswered question. And so the study here was in a similar population, relapsed refractory classical Hodgkin's lymphoma, that could have been ineligible for a transplant, randomized between a doublet this time of the checkpoint inhibitor nivolumab with brentuximab vedotin versus brentuximab alone. And treatment would continue with nivolumab until disease progression, or toxicity, or 2 years in CR, whereas with brentuximab vedotin, it would be given up to a maximum of 16 cycles as it was done in its pivotal trial. Now, unfortunately, the trial never accrued successfully. This was open largely in the United States, and the trial was ultimately closed. We know that there are phase 2 data looking at nivolumab and BV, and it looks to be a very active doublet, though it was studied more in the pre-transplant setting. And this would have gotten into the question of sequential treatment, where again, you could give a checkpoint inhibitor and follow it with BV if you wanted to after progression, versus the idea of combination therapy, and would there be perhaps a longer benefit for the patient in terms of disease control? And then the question of how to do this, should it be sequential or combination therapy, becomes would have been a key question to try to answer. But unfortunately, we won't learn that from this clinical trial. So what will I conclude just very quickly of that summary of the available data here? Now established as a gold standard from a monotherapy perspective, pembrolizumab is superior to brentuximab vedotin. The toxicity profile was favorable, and we have seen the evolution over time of brentuximab moving earlier in the treatment course. We know the Athera study validated its use as consolidation post-autologous stem cell transplant. We know Echelon 1 has moved it into the frontline setting, where we see an overall survival advantage. As well, for patients pre-transplant that have not responded well to salvage therapy, but could be transplant eligible, Keynote 204 included small numbers of patients there and is the only randomized data in that setting, but would validate the approach with a checkpoint inhibitor. We do need to prospectively study newer combinations in the pre-transplant setting. There is a subset analysis of Keynote 204 that looked at non-transplant eligible patients based on age and comorbidity. So there's some important data there. But the fundamental questions here, how do we build upon anti-PD-1s? How do we look at this if we think about the role of allogeneic stem cell transplant as well? And that will be the topic of another presentation. What else can we say, and what else have we maybe learned from these data? So from the monotherapy data, Keynote 87, so this was the pivotal study of pembrolizumab monotherapy, they did allow retreatment in that clinical trial. Again, pembrolizumab was given for up to 2 years in patients that were tolerating it and responding, and then would stop. In those patients, so 10 of the 20 patients went on to receive a second course of pembrolizumab and completed 17 additional cycles of treatment at the time of this report at ASH in 2021. 2 remained ongoing. And what I want to show you here is when you look at the second course, there does appear to be a reasonable response rate in a selected number of patients. Again, right around 70%. The CR rate seems to be reasonable, again, in about a third of patients, PRs in about a third of patients. And when you look at the progression-free survival, it also looks relatively reasonable when you can see the median is about 17 months. And so this speaks to the potential of retreating here in patients that were sensitive to the drug, but we don't know really how to interpret these data without some sort of comparison, and we'll hope that clinical trials in the future will address this. What else is now available when you think of the space of palliative patients that are being treated with relapsed refractory classical Hodgkin's lymphoma? This is where you may look at traditional chemotherapies. So again, the most recent data is with the drug bendamustine. though that is now 10 years ago, where you see a reasonable response rate of about 53%, but unfortunately the PFS was only about 5 months. I'll just highlight one of the other drugs here, camidanlimab tesirine, where again in a large phase 2 study, the overall response rate is 70%, maybe a little better at a higher dose. The CR is acceptable at 40%, but had this very challenging toxicity, a neurologic one of a Guillain-Barré-like syndrome in 6.5% of patients. There was also the possibility for skin and liver toxicity. So the registrational data, that trial has been accrued. Is there a pathway forward with this drug? I think the toxicity may limit our ability to be able to use this drug. And certainly, I think clinicians and patients both are quite hesitant in thinking a bit about this. And looking at other things, whether it's CD30 CARs or CD16, CD30 bispecific antibody, the Affimed drug, unfortunately, proof of concept here, but really no great signal that these are going to be good solutions for us moving forward, at least as they are currently being used from these available data. So where else are checkpoint inhibitors being studied? Well, salvage therapy would be a very good place to do this. We know transplant is a gold standard in the right patients. We know maintenance BV is a gold standard based on a randomized trial with Thera, but salvage therapy has not been well defined in Hodgkin's lymphoma, unlike in DLBCL, where again, multiple randomized studies have been done. The difficulty there in DLBCL, we didn't at the time maybe have very good drugs to do this, but as you can see, checkpoint inhibitors would be an excellent drug in this setting in Hodgkin's lymphoma, and we also have another novel targeted agent with brentuximab. And so we can see what sort of work has been done in this setting as well. The challenge here is that the difficulties can be, how do you look at trying to get these drugs approved? And it might be easy to do this in the US, where single-arm data can lead to NCCN guideline notice, and that then allows patients to receive these drugs. But in many countries, randomized trials are required. And so right now, if the access is third line based on data like Keynote 204, here is some data looking at those settings here. You can see the bullets on the right point. You can see about 33 patients or so ultimately underwent transplant in both arms without a progression event. So that would imply they were responding and we were able to go on to transplant. And you can also see a good number of patients ultimately underwent transplant as well, but we haven't been able to report those outcomes. So from this data set, hopefully there might be a way to get at telling a little bit of the story about what happened to those patients in the use of these therapies. What I'll show you here are some data that Reed Merriman put together that looked at retrospective data from a number of series that looked at the addition of anti-PD-1 salvage in the third line or beyond setting in patients going on to autologous stem cell transplant. So it's a very complicated analysis when you look at the number of different lines of therapy. And starting there in that table in the middle, the figure that shows that in PD-1 treated patients, the response is pretty good. It may get up to about 80% there in a decent number of patients. And when you look at patients that then go on to transplant, and if they didn't have intervening therapy, you can see excellent results. That's the bottom, the curve on the red, looking at progression-free survival, and the outcome looks very good. And if you just look at patients that were potentially PET positive or PET negative, again, a number of these patients achieve CR. They appear to do very well. And so this favorable response rate in PFS post-transplant is a good signal that PD-1 therapy pre-transplant doesn't appear to be a problem and may actually be a very good thing. Now, incorporating novel agents, here's another important thing. So I've summarized very quickly here a number of different studies. On the left are BV-containing regimens, on the right are nivolumab or pembrolizumab-containing regimens, again, showing you incredibly high response rates and very good progression-free survival post-transplant. Again, the challenge, all of these are single-arm phase 2 studies, and so the difficulty here is going to be really incorporating these data to lead to randomized studies that will hopefully change practice, and that would certainly be needed in a country like mine, Canada. But the data look very good, very promising. From a toxicity standpoint, the toxicity profile looks reasonable, but it's important to highlight you do see immune-related adverse events, and whether that's pneumonitis, colitis, transaminitis, so liver issues. You see encephalitis there. So a number of different things that we need to watch out for. And so it's smaller studies. So I think we may need bigger trials to really better understand the rare events that are happening in this patient population. So a bit of caution to say you should just be doing this randomly if you have the drugs available, because we may not fully understand this yet in terms of looking at toxicity and managing it effectively, but larger experiences are coming. Now, some retrospective data as well, and this came from a series in the US, multiple centers led by the Mayo Clinic. And again, when you compare checkpoint inhibitor-based regimens, and that includes particularly BV-Nivo, you can see, looking at the progression-free survival curves on the right, excellent results, really showcasing the benefit of using these drugs compared to conventional salvage therapy. So again, retrospective data, but still awaiting prospective studies to be able to move this forward. So what's the gold standard at the moment? I would say it really depends on access, depends on your belief in these phase 2 studies and what's available. Many regions are still forced to use traditional chemotherapy in the absence of randomized trials. I'll just highlight one Italian data set using BGEV, has great data with modern PET imaging to look at the CR rate. And so again, a good choice there. There's a lot of variation in practice and transplant around the role of CR, but to me, there's no doubt here that regimens that lead to a PET CR, that is the most important predictor of outcome. Third line therapy, I think based on the level of evidence, we have as much as we're going to have, and a checkpoint inhibitor now is the effective gold standard and should be considered in these patients as a bridge to transplant. And remember, sensitive disease is the more important thing here, no longer traditional chemosensitivity, because as you've seen from the data I've shown you, these patients can do very well after transplant. So it's very reasonable to incorporate novel therapy where you can, but the data from a randomized standpoint are still needed. Future directions, where can we go? Can we get this more into the curative setting? How do we do that? We have good response data now to look at this. This may be a good surrogate in terms of PET-CR. We do need randomized trials in the second line setting, in the curative setting, but can we also look at this in the frontline setting? And there may be bigger questions that we can get at. Do these patients really need transplants? Is there a way that we could take these highly active regimens and maybe avoid the toxicity of chemotherapy? Though again, financially, that may have its own challenges, as now a transplant is a fairly cost-effective therapy in comparison to longer courses of checkpoint inhibitor therapy, as an example. I'm going to now close with the frontline setting, and just to highlight a couple of quick points here, multiple different ways to cure advanced stage Hodgkin's lymphoma, as you can see here, whether it's an ABVD-based approach, BCOP-based approaches with de-escalation if interim PET are favorable, or even the incorporation of BV using echelon 1, where we now have seen a survival advantage with most recent data. Now I'm going to show you these data that were presented by Alex Herrera at the ASCO meeting earlier this year that randomized nivolumab instead of brentuximab vedotin onto the AVD backbone, so building on the data set put together with echelon 1. And this was a North American intergroup study that included the US groups, the Children's Oncology group, as well as our group, the Canadian Cancer Trials group. So here's the design very simply: stage 3 or 4 disease, age 12 or above. Stratification included age, IPS, and the use potentially of end of treatment radiation, randomized to the N or BV versus AVD for 6 cycles. 470 patients per arm. The primary endpoint was PFS. What I'll just highlight here are the baseline characteristics to get at age. So you can see above the age of 60 was quite uncommon in this trial at about 10%, so a little under 100 patients. There's the ethnic mix, as you can see. Looking at baseline characteristics, 2/3 were stage 4, IPS 4 or more in about 1/3 of patients, bulky disease in about 30% of patients. So fairly representative of the typical patient population in all accounts. Looking at adverse events here, so you can see broadly fairly well managed. Again, GCSF mandated in the control arm with brentuximab vedotin, used relatively frequently in the experimental arm as well. That's typically American practice. That doesn't need to be done in lots of countries. And you can see on the nivolumab side, a little less of the higher grade peripheral neuropathy toxicities as an example, and potentially that signal around transaminitis being one of the concerns to watch out for. Looking at treatment discontinuation, just to highlight here, looking at early discontinuation, the events are driven by progression, which were higher in the brentuximab arm, as well as deaths on treatment, higher in the brentuximab arm. And the discontinuations you can see are almost double with the BV versus nivolumab, as noted on this table. Here's the primary endpoint, progression-free survival. And again, the analysis was triggered because of events, and the 1-year PFS, which is now reported as the point estimate, 94% for nivolumab versus 86% for BV. And you can see the hazard ratio there of 0.48 being very statistically significant. The PFS benefit is consistent across all subgroups. And here's the overall survival, which is way too early in terms of looking at it from a time perspective. So the conclusions from the investigators is that this improved PFS, it was well tolerated, we need ongoing follow-up, but this is poised to be a new standard for advanced stage classical Hodgkin's lymphoma. What do I think about this? Yeah, it's early follow-up. We haven't seen a manuscript. How will the longer term follow-up be? And I don't really doubt that this is going to be a positive trial based on what we've already seen in the relapse refractory setting. But how does this influence practice? That's a much more difficult thing when you start to look at late effects, the ability to cure with other regimens that are not ABVD, the lack of use of interim PET in this trial versus the use of interim PET in other studies. And so there are interesting questions here, and I think there'll be a lot more for us to talk about over the following years. And so to conclude, checkpoint inhibitors have clearly changed the management of relapse refractory classical Hodgkin's lymphoma and probably will change frontline therapy as well. The data in the curative setting, whether that's around transplants or in the frontline setting, remain very early, but efficacy appears to clearly favor incorporating these agents into standard management. Toxicity is present, but not limiting as long as you watch out for things like pneumonitis. And we need to continue to do prospective and randomized trials with good follow-up, particularly in a disease like Hodgkin's lymphoma, to really understand all of this. So I thank you all for your attention.
I think we're going to move to the second presentation, role of allo in classical Hodgkin's lymphoma.
Hello, everyone. So in this presentation, we'll be discussing the role of allogeneic stem cell transplant in classical Hodgkin lymphoma. I'm John Curvilla from the Princess Margaret Cancer Center in Toronto. Here are my disclosures. So it's important, I think, by way of introduction, to look at our gold standard very quickly in the setting of relapse and refractory disease, which is autologous stem cell transplant. And this was defined by a randomized controlled trial. There are actually two, but this is the larger one, and that needs to be taken with a grain of salt because, as you can see, only about 120 patients were randomized in this small clinical trial. And so the primary endpoint here was freedom from treatment failure, something very similar to PFS, and clearly shows benefit for transplantation over standard dose salvage with Dexabeam. The numbers start to break down when you look at stratification by early or late relapse, but this was curative therapy that was maintained over several years, and thus autologous transplant became the gold standard. The only other randomized data we have in this setting that's been published is the Athera study, which looked at maintenance brentuximab post-autologous transplant in high-risk patients. And at the initial time of presentation, there was a median follow-up of 30 months, but now we have 5-year data that continues to show consistency of the primary endpoint of progression-free survival being maintained even at 5 years. At the 2-year time point, there was a 12% benefit. The toxicity was manageable. Again, it was peripheral neuropathy and neutropenia being the big issue, but no overall survival advantage in this study. Admittedly, patients went on to cross over in a good proportion, 84% of those patients in the control arm. So it becomes difficult to really understand overall survival. But the important thing here, maintained PFS at 5 years, which we've seen with the longer term follow-up, highlights the curative potential of this regimen. And I think there's little doubt that this does improve cure. So unfortunately, the overall survival being lacking doesn't really get at that point because there are other therapies, whether it's BV or checkpoint inhibitors, that people can use. Here's some historic data that I want to give you a sense of what people used to think about how we treat relapsed refractory classical Hodgkin's lymphoma once you get into the palliative setting. And this is with conventional therapies, radiation, etc. And unfortunately, it's old data now, but a very large series of over 750 patients that showed that the outcomes generally were not good. The median PFS about 1.3 years, median overall survival about 2.5 years. And this was a setting where for a lot of people, drug development might have been thought of, but this was also a place where you could think of allogeneic stem cell transplant. So when do we think about allogeneic stem cell transplant in the modern era? So do we think about it for patients with disease progression post-stem cell transplant? Yeah, that's a reasonable place to think about it. Do we think about it for patients with high-risk features in the second-line setting? And that might be patients that are primary refractory to an anthracycline-containing regimen, or patients with a poor response to salvage therapy. And I'd say, I don't think we need to think about those patients in quite the same way anymore because of what we know about novel agents such as BV and pembrolizumab and nivolumab. You're very likely to be able to get a primary refractory patient or a patient that doesn't respond to a conventional regimen second line. You'll be pretty likely to be able to get them into a good remission and take them to an autograft. And you can also take the high-risk patient and consolidate them with BV based on the Athera data. And as you can see from those data that I showed you earlier, they tend to do fairly well in that setting, even if they have high-risk disease. So I think the main place to think about allogeneic transplant, if you have access to these therapies, will be in patients that have experienced disease progression post-transplant. Now, I'm just going to give you a little bit of the history around why we do transplants in relapsed refractory classical Hodgkin's lymphoma, because before the advent of reduced intensity transplantation in the early 2000s, this was something that people did not believe too much in with myeloablative allografting, particularly because there was a lack of data that looked at graft versus tumor effect in this disease. And we know the biology of classical Hodgkin's lymphoma is very different than that of DLBCL or indolent lymphoma. So these are 4 series published by 4 different groups that highlight the potential for response to DLI, and this was associated with a lower rate of relapse as well as response and a lower rate of chronic graft versus host disease. The challenge of interpretation of some of these is that some of these patients might have received chemotherapy along with the DLI, and so that's the challenge. And looking to the right of this table, graft versus host disease and also non-relapse mortality can certainly be an issue in these patients, reminding us of the challenge of doing allogeneic transplant successfully. So Anna Sereda and the EBMT went on to run a prospective phase 2 study called the HDR Allo trial. And I think this is probably the most important conclusion from that trial. In the 50 patients that were chemosensitive, they tended to do much more favorably from an overall survival perspective as well as from a PFS perspective. But patients that were resistant did not really appear to benefit as much from a transplant. And this is probably the group of patients to avoid taking forward to an allogeneic transplant. So here's a more recent EBMT review that to me really gets at the feasibility of doing this in the modern era. And so whether it's from a haploidentical donor source, a sibling transplant, or a matched unrelated donor, what you can tell from these data are that the one-year non-relapse mortality are reasonable, but it is in that 15 to 20% range. 2-year progression rates of about 40%, 2-year overall survival of around 65 to 70%, but that 2-year PFS of about 40% seems to be what people were able to typically accomplish in this setting. And when you looked at a composite endpoint that might include extensive graft versus host disease and relapse-free survival, so the CGRFS, this might have favored haploidentical transplants. And so in this setting, multiple donor sources possible, non-myeloablative regimens showed these favorable outcomes. Again, sensitive disease preferred. I think these were the conclusions from this setting as we got into the checkpoint inhibitor era. What really changed was in 2014, the phase 1 data that were presented with nivolumab, and again, at the very soon thereafter, the data with pembrolizumab. Again, both studies changing the face of relapsed refractory classical Hodgkin's lymphoma. So the next question became, what happened to allogeneic transplanted patients after exposure to a checkpoint inhibitor? And with the effect that checkpoint inhibitors could affect the immune system, is there the potential for higher grade toxicity that you might see with these patients? And so again, Reed Merriman put together a series here, over 200 patients, appropriate age. The majority had a favorable comorbidity index, the higher proportion of patients having received nivolumab. The disease status at the transplant, I think, is the important thing to put out here. So about 60% in CR, about 30% in PR. The number of haplotransplants here more common, but again, matched unrelated donors still above matched siblings. So again, reflecting what generally happens in transplantation today, and 60% being reduced intensity, 34% being non-myeloablative fully. When you look at the toxicity first, acute graft versus host disease might be a little higher in general than what we're used to seeing at just over half the patients, 15% being grade 3 or 4, and 2-year graft versus host disease might be kind of what we tend to see in this setting. But when you look at the outcomes on the right, the non-relapse mortality and relapse rates look very favorable. So that relapse rate of 18% appears to be lower than historical data. And the GRFS, as you can see, 47%, PFS 69%, looking very favorable here and suggesting potential benefit. But how much of this is being just driven by the fact that patients are in complete remission? We also put together a series specifically looking at pembrolizumab for the patients that have been treated on clinical trials, and this includes some patients with primary mediastinal large B-cell lymphoma as well. And again, what you can see is that acute graft versus host disease, fairly similar at around 50%, that chronic graft versus host disease rate about a third as well, and favorable progression-free survival post-transplant, acceptable non-relapse mortality and relapse rates, and again, favorable overall survival. Again, in this setting, remission in about 44% of the patients. So driving this point home, certainly these appear safe, slightly higher rates of acute graft versus host disease, and potentially favorable outcomes post-transplant. So very interesting and perhaps reflecting a shift in how we may think of the use of transplantation in this setting. So these are data that Miguel Perales has presented on behalf of the ABMT. We're hoping to see a manuscript out shortly. I understand it's in review. And I thank Miguel for providing these slides to me. We'll just look at the outcome of allogeneic transplant based on a joint CIBMTR and EBMT analysis in the next few minutes. So the aims here were to look at adult patients with Hodgkin's undergoing allo with or without prior checkpoint inhibitor. And this was done over a period between 2008 and 2019, any donor, any graft versus host disease prophylaxis, I think typically employed, and myeloablative or reduced intensity conditioning. So here are the patient characteristics. Nothing stands out here, though there are some differences between the groups which would need to be balanced for an analysis in terms of what was being used. Now, firstly, looking at some of the key questions here, prior checkpoint inhibitor improves PFS, as you can see with the curve on the left, hazard ratio 0.75, but does not appear to show a difference in terms of overall survival. Prior checkpoint inhibitor is associated with a lower risk of relapse and similar non-relapse mortality. So at least in terms of the ultimate toxicity, death without relapse, we don't see a worrisome signal here, and the relapse rate does appear to be substantially better with the hazard ratio of 0.53. When you put this into multivariate analysis, the significant differences that really stand out here, the PFS is statistically different, the relapse incidence is statistically different, and when you look at acute graft versus host disease, though not statistically different, that p-value is 0.09, it looks like that is the other thing that appears to be the bigger issue here. For grade 3-4, but with grade 2-4, it does become statistically significant with that p-value of 0.02. Looking at additional factors in terms of overall survival in this multivariate model, what you can see here, age is an important predictor, female sex, PR versus refractory disease, higher risk of failure, the myeloablative conditioning, higher risk of failure, poor KPS, higher risk of failure. And when you look at haploidentical recipients, they had improved progression-free survival and a lower rate of relapse, but this ultimately did not affect overall survival. So that in part could be a numbers game in the analysis. When you look at cause of deaths in these pie charts here, you can see the big difference is the lower rate of relapse in the patients that receive checkpoint inhibitors on the left, versus on the right with that sort of teal blue there. So what can we conclude in terms of understanding the differences here? There are some conclusions that come with some caveats. So the outcomes do appear favorable in terms of overall survival, though not maybe statistically significant, progression-free survival, certainly lower rates of relapse, non-relapse mortality appears to be similar, higher rates of grade 2 to 4 graft versus host disease. That signal with grade 3 or 4 did not ultimately be statistically significant. Post-transplant cyclophosphamide may be associated with some of the best outcomes when looking at some of the other data. That may play in with the haploidentical question there. Typically, it's been recommended that there should be some delay from PD-1 exposure, usually around 3 months when thinking about that from a safety standpoint. But again, there are many unanswered questions here as to what is happening with the checkpoint inhibitor. Is this doing something to the biology of the disease or to the biology of the patient before those cells are being infused from a donor? Is it the fact that more of these patients may be in a better response and that's what ultimately drives the outcome? Or is it some of the technical factors of the transplant now that we're on non-myeloablative, that we're no longer doing myeloablative transplants? Is it the haploidentical donor? Is it post-transplant cyclophosphamide? These are some of the interesting things that we still need to think about when understanding this. So the challenges for clinicians, unfortunately, is that we don't have level 1 evidence to guide decision making. And I think the key clinical question is, should a patient go on to receive a checkpoint inhibitor or go on to allo if in remission? And I think looking at the data, if patients achieve a CR to a checkpoint inhibitor, certainly given longer follow-up of those patients, they appear to do very well and have a low risk of toxicity. And I think that's a very easy group to say, staying with the checkpoint inhibitor is the right answer. For the patients that are maybe in a PR, the PFS still is excellent. It's over a year and it's very low toxicity. And generally in my practice, that would be, I think, a preference to stay on drug as opposed to go directly to a transplant in that setting. But that's a more challenging conversation to have with a patient. Looking at it from the side of the transplant, the factors to think about, the patient, it's, what's their age, what's their comorbidity, what does the donor look like? What is the local experience in terms of doing transplant in this setting? In the lymphoma history, what was the response to a checkpoint inhibitor? What have other drugs been used? What other options may be available? Are there maybe good clinical trials available? The discussion with the patient clearly has to get into the discussion of risks and toxicity, whether they're both acute and the delayed toxicities you may experience with graft versus host disease, and what sort of treatments that may be available for relapse post-allo or at the time of progression if they're continuing on the checkpoint inhibitor and not going on to the allo. So ultimately, this does lead to very individualized decision-making and sometimes more complicated discussions with a patient as needed. So ASH 5 years ago put out these recommendations for patients receiving checkpoint inhibitors in blood. And so I will draw this to your attention. So this does make the idea that early referral to a transplant center should be considered to at least have the conversation so that people can understand, and that allo can be considered for patients in this setting in theory. When looking at the transplant strategy, they recommend at least six weeks of hold before the allo transplant. So again, a little less conservative than what had previously been thought from many experts of about 3 months, now that we understand the safety a bit better. The use of VOD prophylaxis, such as ursodiol, could be used. Again, this was consensus and not evidence-based. We don't tend to see that signal now with the increasing data that's been available now. You can think about the typical strategies we use to reduce the risk of graft versus host disease and have very close monitoring early given the potential for acute graft versus host disease. So think about very quickly initiating therapy with corticosteroids if they develop fever. So beware of other causes, not just graft versus host disease, but rapidly initiate treatment for GVHD if you see it, to try and get ahead of this quickly. And again, we know the rates of grade 3 or 4 may not be statistically significantly different, but this is the main risk we want to watch out for. Patient-specific risks, again, think about their history, think about the timing for relapse post-transplant. You have to think about how you're going to approach other strategies if they ultimately progress and need checkpoint inhibitors afterwards. So you may want to start at a lower dose. There isn't a lot of data about this in this setting. And the management of graft versus host disease, if someone's been given a PD-1 antibody post-allo, stop it, start treating with high-dose steroids again, and think about earlier intervention second line if needed. And so to summarize, the registry data demonstrate favorable results more recently. This is probably in part due to the selection of responsive patients. Whether the checkpoint inhibitor is doing something biologically different, we don't know, but this is a very important point when thinking about discussing the more favorable results these days, potentially with allo. There is no level 1 evidence still to define the role of this, probably will never be a randomized trial. We don't have other good alternatives, so there isn't CD30 directed CAR that's available, but again, drug development still remains very important. There are effective combination approaches being explored, newer drugs still being developed in this setting. So many groups such as ours try to have a number of these options available for patients that are not interested in the potential toxicities of an allogeneic transplant. This remains a very complicated discussion to have with a patient around these issues of toxicity and efficacy. And it remains very important to individualize that conversation with your patient. I think all of us as clinicians have our own biases in terms of how we think about allogeneic transplants and its potential toxicity, but there is no doubt that there may be some patients cured with allografting in this setting. And really the challenge here as a clinician is to try to find the right approach for the right patient. And that really is a challenge we always face in medicine, but particularly in Hodgkin's lymphoma, when we may have settings such as this one where there's more than one option potentially available. So with that, I'll conclude and thank you very much for your attention.
Thank you very much to Dr. Carvella. Now to probably a more interesting topic, to be honest, myeloma. So it's my true honor to present to you Dr. Victor Jimenez Zubeida, who's one of my favorite myeloma doctors and one of my mentors when I was a resident. So Victor is an associate professor at the University of Calgary in Alberta, Canada. He's also the team lead in the plasma service at the Tom Baker Cancer Center. So Dr. Jimenez, hopefully you're not too jet lagged to present today.
Thank you so much. Thank you for the kind invitation, and it's always a pleasure to be here. This is my first time in the Kingdom of Saudi Arabia. So I'm going to present, the first part of my presentations is about myeloma, and the second part is on myeloma, but thinking about bispecifics. So talking about myeloma these days is including a bunch of different drugs that are available, and we're happy for that. Our patients do have some options. This is my disclosures. Today is the Mexican Independence Day. That's when I come from. Myelomas, you know, is a plasma cell disorders where a group of cells, they look the same. Morphologically speaking, these cells look like abnormal plasma cells that proliferate in the bone marrow. The median number of plasma cells is around 30% in patients that develop myeloma. But they do have the ability to produce abnormal proteins that we can measure through serum protein electrophoresis or free light chain. Sometimes they make both the heavy chain and the light chain. But these lesions that they produce are lesions that can affect the bones. People can fracture, they can damage the kidneys, they can grow, and around 10% of patients might have extramedullary disease at the time of diagnosis. But they do have some genetic abnormalities that actually make them different between those group of cells. So this is a very key presentation from the Mayo Clinic group in Arizona, where a patient donated the bone marrow for research throughout the whole course of the disease. And you can see how in the beginning, there is a very small clone that is just pretty much not visible in the first circle when the patient was treated with, before the patient was treated with lenalidomide and dexamethasone, that is kind of the light green. And that's actually the clone that evolves at the end of the disease when the patient actually presents with plasma cell leukemia. So nowadays we think that there are between 4 to 6 different clones that are genetically different that expand and contract as they respond to treatment or become resistant, and that's what makes myeloma more difficult to treat. We always aim for cure because now we have drugs that could potentially give us good responses. But also, we do not sacrifice the best treatments available up front because there is no guarantee that the patients that we see at the time of diagnosis will be surviving and the treatments that will be reserved for the second time of treatment or for the next relapse. And there is an attrition rate that occurs between one line to another. And depending on whether the patient is transplant or not transplant eligible, the non-transplant eligible might be patients that are more frail, more commonly seen succumbing of toxicities related to the treatments that we use. And that's why we offer always the best treatment up front, because there is a big attrition rate between lines of therapy, and we always like to offer the best treatment up front. We have made a lot of improvements, and you can see in this slide all the drugs that we have now available for multiple myeloma. And there are new avenues, there are new treatments, there are new mechanisms of action drugs that actually are available now that were not even thought about 10, 20 years ago. And that's what is making this disease now more treatable, and in a small population of patients that we hope will expand in the next few years, we're hoping that patients will live long enough that they might die of something completely different, and that's what we call functional cure. But when we talk about individualized treatment for patients with myeloma, that's something that has not only to do with the biological aspects of the myeloma cells, but also where some aspects that have to do with psychosocial variables, that has to do with geographic areas and access to different cancer centers, but also sometimes disponibility of the drugs, access to different medications, access to the cancer center. There are patients that might prefer to get oral treatments because they're unable to attend cancer centers for injectable drugs, or there might be some people that might have some preference based on convenience of what they consider is the quality of life. So the individualizing decision about treatment is always something that we do, not necessarily based on the biological aspects of the disease, but also based on some other factors that include geographical difficulty, challenges, access, and most of the times is what we have available in our cancer centers. Everything that we do for our patients has to be based on keeping them alive for as long as possible, but also to preserve the quality of life. And that includes some social disruptions, the ability for patients to work, access to transportation, the caregivers that might change depending what are the treatments that we offer to those people. So there are many considerations when we offer the treatment. So giving the best treatment up front, thinking that the patient can stick to that treatment for the longest is what we normally do. And there is a high burden of all these treatments that we do and the effects of the myeloma itself that can potentially affect not only patients, but also can affect the people that care for them. And those are caregivers that can develop stress, anxiety, or even depression, as you can see in this slide. And the quality of life of patients can also be affected by different factors that sometimes are not necessarily just related to the biological aspect of the myeloma. We do have treatments that are novel, and we have now drug combinations that could potentially give us deeper responses compared to what we used to assess 10, 15 years ago. And now we can even think of assessing the response based on the presence of what we call minimal residual disease, whether it's by flow or by some genomic abnormalities, because these drugs are so efficacious that people actually can have very good responses even beyond what we used to call the hematological complete response 10 years ago. So minimal residual disease is something that we're hoping that will help us to first assess deeper responses, but also in some people perhaps help us guide the treatment. The unmet myeloma is not only treating people with the right drugs, but also in some people is not to treat with drugs that might have some toxicity when they are not needed. So patients that are transplant or not transplant eligible that actually get minimal residual disease negativity do have a 67 to 68% reduction of the risk of death or progression when this status is achieved, which suggests that patients actually can have very deep responses that will translate into a very overall survival. But obviously, we're not going to offer different treatments that are toxic just to get to MRD negativity. Perhaps that might be something that is important, particularly in the group that we call high risk based on the cytogenetics, and perhaps might not be so important in people that might have a low-risk myeloma. What really matters is to keep it on the treatment that works for as long as possible, even if there is a small residual clone. However, the treatment can vary between patients. There are factors that have to do with physical performance, and some people might be more frail. The first separation that we do is whether a patient is transplant eligible or not transplant eligible, and the attrition rates may change depending on this. So as I mentioned to you, we always offer the best treatment up front because there is no guarantee that the second treatment might be available. But the patients that are non-transplant eligible tend to be older, tend to be more frail, and for those patients, giving the treatment that is more efficacious and less toxic remains the key important factor. And when transplant is considered, for the most part, we use the 65 age as a cutoff for different clinical trials, and that's an arbitrary number. In many centers, even patients over the age of 70 with good performance status can be considered for transplant. But nowadays, there is a challenge with these new drugs that we have, of even technological approaches like CAR-Ts and bispecifics. The question is whether the transplant will continue to be something that remains a key cornerstone treatment part, or whether we can actually substitute this for the novel treatments. So it is important to consider not only the biological aspects of the disease, but also the clinical characteristics of patients and the different comorbidities. This is just a slide when we can suggest that patients that are transplant eligible, we can offer different regimens of inductions, and the ones that I present here are the ones that actually are available in Canada for induction: the cyclophosphamide, bortezomib, and dexamethasone, the RBD combination of lenalidomide with bortezomib, and the addition of daratumumab with bortezomib, thalidomide, and dexamethasone. So there is a hope that by adding new drugs, potentially triplets or quadruplets can increase the response that we see in our patients. And you can see in this slide one study from the European group where patients receive induction with Cybordim, and then there was an intensification with BMP or the transplant, and then patients were randomized to receive consolidation or nothing. You can see in the Kaplan-Meier curve how the progression-free survival seems to be better for the people that receive transplant, but when you see the response rates between the group that receive transplant or the intensification with BMP, you can see that the responses can be close to each other, but the deeper response is seen more with the transplant group. And it seems that particularly for the groups that might be high risk, doing transplant 1 or even 2, the tandem transplant might potentially be a good option to try to keep the disease not only controlled with good responses, but to keep it for longer. This is an interesting study called Determination, where patients receive RBD followed by transplant, and patients were then randomized to receive lenalidomide maintenance until progression. And what you can see right here is the same, that the patients that receive transplant do have a better progression-free survival. And the responses appear similar, but you can see that the MRD negativity is deeper for the people that receive the autologous stem cell transplant. There is some studies looking at what we call maintenance, and that can be given with lenalidomide, with studies based on bortezomib or ixazomib that have been less effective than lenalidomide have been suggested. But if you see the use of lenalidomide versus non-lenalidomide maintenance, patients actually do have a better time to next therapy, progression-free survival, and even overall survival. So there is another study that is interesting where there was an idea of trying to prove whether the addition of daratumumab, this is something that can be in the phase of the induction, in the phase of consolidation, and even maintenance. And the idea was to see whether by using this daratumumab and making this a quadruplet, patients were to have a better responses. And you can see in the Kaplan-Meier curve, there is a 53% reduction in the risk of progression or death for those patients that receive daratumumab with BTD compared to those that only receive BTD. The responses appear similar when you look just at the raw numbers, but you can see that the MRD negativity is actually better for the group that received the daratumumab up front. What is more interesting in this study is when you see patients that were exposed to daratumumab at any given time, and that's kind of the graph in the middle part at the bottom. Regardless of where the patient received daratumumab, the patients that receive daratumumab, whether it's an induction in the consolidation or the maintenance part, those are the patients that actually have the better outcomes in terms of progression-free survival, suggesting that perhaps the use of daratumumab regardless of what phase is used, could potentially be the reason why the cells get more sensitive and they acquire better responses with higher levels of MRD negativity, as you can see in the right-hand side of the slide. There is another study that tried to look at the use of daratumumab, but in addition to RBD, and this was recently published as of yesterday in the Lancet of Hematology with updated form of this study, suggesting that the progression-free survival is better for those people that receive daratumumab associated to RBD. But what you don't see is any benefit yet on overall survival when the median follow-up is around 4 years. So this is to suggest that yes, you can get a little bit of benefit of PFS, but not necessarily overall survival we'll see, and perhaps that has to do with the fact that we have novel drugs that patients can be exposed in different lines. So getting a good treatment is always our first suggestion, getting the best treatment available for the patient at the time of diagnosis, but as we progress and we receive new drugs, or we have novel drugs that might be accessible or novel technologies, patients actually can even get better. So this is the final analysis from the Griffin studies, and you essentially can see how the MRD negativity seems to be better for the group of patients that receive data RBD. And this doesn't happen necessarily right away. It can take up to 8.5 months to receive the MRD negativity at the 10 to the minus 5 level, and around 33 months to get it at the 10 to the minus 6. But it seems that the patients that achieve the best response, the deeper responses, they could relate with better survival. But as I said, there might be groups of patients that could potentially use MRD to get therapy, and there might be others where not necessarily giving more treatment and adding more toxicity might be ideal, and that perhaps can be the standard risk of patients where perhaps a clone that is more an MGAS clone can even present a monoclonal protein that is left over, but not necessarily that will translate into a resistant mechanism of the myeloma cells. So a stem cell transplant is the first question, whether we do the stem cell transplant or not, whether we can do the different inductions that we have. But the patients that are not transplant eligible, those are patients that we could potentially offer kind of the same combinations, but we're going to assess some of those in the setting of being patients that are 65 or older. As I said, that was an arbitrary age defined by different clinical trials to consider transplant eligibility. And this is a study that includes patients that were younger than 65, but they were not intended to receive autologous stem cell transplant up front. And you can see that the patients that receive treatment with RBD compared to RD had a 26% reduction in the risk of progression of death, with responses that were higher, 90 versus 78.8% when compared with the lenalidomide and dexamethasone alone. This study is also interesting, where they were trying to compare the use of carfilzomib versus bortezomib as the proteasome inhibitors based on studies that were done in relapsed refractory myeloma that suggested that carfilzomib perhaps might be a more potent proteasome inhibitor compared to bortezomib. But as you can see right here, the progression-free survival doesn't appear to be different between patients treated with KRD and RVD. This study applies only to patients that were not high risk. Patients that were low risk or intermediate risk were only included on this study, so this doesn't address the possibility effect of carfilzomib in patients that are at high risk defined by the cytogenetic abnormalities. What seems to be revolutionizing the treatment of myeloma, particularly in the non-transplant eligible group, is the addition of daratumumab to lenalidomide and dexamethasone. Nowadays, we have daratumumab given subcutaneously, so patients actually can be treated within 5 minutes in an injection that is subcutaneous that decreases the amount of time the patients spend in the cancer center. And lenalidomide and dexamethasone, for the most part, in non-transplant eligible patients can be very well tolerated. So you can see right here that the progression-free survival is around 61.9 months compared to 34.4 months for those patients that receive dara RD compared to the RD. And if you think of a patient that receives CyBorD followed by transplant and then lenalidomide maintenance, the median PFS that you see in a patient that are transplant eligible with that combination might be around the same, around 5 years, 4 to 5 years. This suggesting that Maya, this study with dara and Lendex, could potentially give us responses similar to what you might expect in patients that are transplant eligible with the combinations that we have. So this is a study that has revolutionized the use of treatment for non-transplant eligible patients with myeloma, provided that your country gets access to daratumumab. And there are so many places where daratumumab still don't become available. As you can see right here, DRD demonstrated a significant benefit of overall survival, 35% reduction in the risk of death when compared to lenalidomide and dexamethasone alone. So this is to suggest that this treatment that is less toxic could potentially give good responses. Not everyone gets MRD. Around 1/4 of patients get MRD and still they have a good response, perhaps suggesting that in some people, keeping a treatment more chronically without necessarily adding more toxicities can actually maintain the disease better control and increase survival. The MRD negativity, as you can see right here, seems to be better in a group of patients treated with DRD. And what really matters is not only getting to the deeper response, which is the MRD negativity, but sustaining this response for at least 12 months, and those are the patients that actually have the better outcomes. As you can see right here, the sustained MRD in the Kaplan-Meier curve in the middle, the one that offers the best PFS is the one that actually sustained MRD for more than 12 months. So this study is very important in this setting, and obviously the combinations that we have with RBD, DRD, and RD are still offered for people that are non-transplant eligible in Canada, and we also have combinations with VMP. Data can be combined with that, and we have an exception where daratumumab can actually be given with CyBorD for non-transplant eligible, but to be quite honest, most of our patients will be receiving data RD if they are deemed not to be transplant eligible. But also, there are variations of these treatments that could potentially have clinical significance, and that means that we decrease the toxicity of the medications that we use. And for instance, the studies by the Italian group have actually looked at using less dexamethasone and stop it after 9 months, or adequate the dosage based on age and based on the creatinine clearance, with the hope that patients will be able to receive the treatment for longer without necessarily sacrificing in terms of toxicity. And that is something that we have published even with bortezomib. Patients that are more tolerant, even with lower doses and sensitive from the myeloma perspective, can live longer and have better tolerability of the drugs, which translates into quality of life. And we have to remember that we individualize the treatment of patients with myeloma not only based on age and fitness and comorbidities, but also based on the biological aspects of the disease. So in someone that is a more aggressive myeloma, we try to give the best treatment that we have and the higher efficacy, but we have to also make sure that the patient might be able to tolerate that particular treatment. There are some studies that have been done with using oral treatment. Some patients might have the issue of not being able to come to the cancer center to receive injectables, and perhaps the addition of something that is oral might be adequate. There might be some changes that actually we have to make because of the pandemic, and we have to switch from Velcade to oral ixazomib, and many centers in Canada, that's what happened at the beginning of the pandemic. And this is a study that actually was negative. There was a benefit of ixazomib, lenalidomide, and dexamethasone compared to len and dex, but the most benefit was actually seen in the high-risk group, suggesting that perhaps the combination of dual treatment makes a difference, but this didn't actually fulfill the pre-specified goal that we have for the study, and is considered negative. And when you see the different combinations with daratumumab, you can see that the benefit of daratumumab remains regardless of whether patient is younger or older, and in this case based on 65. And you can see in Maya how this also translates into benefit, but the group of patients that are older, they might have a good benefit of the addition of daratumumab, but this decreases a little bit, which suggests that for our patients, we have to always identify the best treatment, but make it tolerable and decrease toxicity. It's also important. And as you can see, the responses are better for patients regardless of age when the addition of daratumumab, and you can see that MRD negativity also remains. And this is a meta-analysis just comparing the different backbones added daratumumab, and for the most part, daratumumab, in addition to the VMP, VTD, and RD, remains at the standard and the winner treatment. There is always a question whether we can actually use transplant later, and this is a slide when the data from the determination trial suggests that perhaps there is a group of patients where we can actually offer transplant for later, and that without sacrificing outcomes, and this might be something perhaps that we can consider more for the low standard risk patients with myeloma, where doing the transplant later perhaps might be still needed. But in the case of patients that are high risk, delaying the transplant could potentially be a little bit more dangerous, because the PFS, even when better with the new drugs, never gets to be similar to the standard risk group. So delaying the transplant in a small population of patients perhaps might be something to consider, especially with the addition of daratumumab to the treatments that we have presented. But obviously, in some places, the access of daratumumab might be an issue or more challenging, and in those patients, perhaps when the transplant might be better. So that is the first part of my presentation, and I guess we'll move to the second one, if we'll stop for some questions on this one.
I guess we'll just move on to the next presentation, which will be about bispecifics in myeloma, and then we'll leave the questions at the end.
Perfect. So the next part is actually very exciting because we're going to talk about bispecifics in myeloma, and that's a new avenue that has actually opened recently in the treatment of multiple myeloma. So far, we have now drugs that are part of these bispecifics that are approved in the US and also in Europe, and some of those also in Canada. I changed a little bit the name of the presentation just to call it T-cell directing therapies in multiple myeloma, because the BiTE expression is something that was used initially by Amgen, with these BiTEs were done against ALL. So this is more a T-cell directing therapy, and I'm going to present some variations of that, the same conflicts of interest as presented in the slide before. This is just the intro that we use for myeloma. The bispecifics are actually used in a population of myeloma patients that is an unmet need, and this is a group of patients that we call triple-class refractory patients. These are the patients where the median time to development of triple-class refractory is actually shorter, around 3 years from the diagnosis of multiple myeloma. And these days we can say that patients with myeloma live around 8 to 10 years, and in the low-risk group, perhaps more than 10 years. But the triple-class refractory, the median progression-free survival is very short, only 4 months, and the overall survival is in the range of 1 year from the time that they achieve this status of triple-class refractory. So the BCMA-targeted immunotherapies in multiple myeloma appear in different ways. It can be the antibody-drug conjugate, and the example of that is belantamab. Another one is the CAR-T-directed therapy, which I know that there might be a presentation tomorrow, virtual. And the other one is the use of these bispecifics. And one of those is teclistamab, but there are other antibodies. There are antibodies that are naked, and there are antibodies that have other markers that are not only BCMA, and there are actually treatments where we can actually combine the use of some of these multiple targets. So we're going to be discussing about these bispecifics, but when we talk about the antibodies, they can be antibodies that they have nothing attached. We call it naked antibodies. There are antibodies that can have either a toxin or a radioactive isotope that is attached to the protein conjugate. And there are antibodies that do have the properties of being engineered so that one of those ends binds into the myeloma cells, and we choose the target, whether it's BCMA or other targets that are presented, and the other ends binds to the T cells. And there is a part of these antibodies where they can be actually T cell stimulation with the hope of keeping the T cells active and preventing the myeloma cells from coming back for longer. There are patients that nowadays can be treated with CAR-T, especially in the US, it's available. There are some issues with regard to CAR-T, but we're going to defer the discussions about that for the presentation tomorrow. But it's just to say that patients with CAR-T still relapse, that the CAR-T doesn't seem to be curing myeloma. Obviously, this has been used in patients that are very refractory, whether it's triple-class refractory or penta-refractory, but you can see from the KarMMa-3 study where the patients still that relapse, even what is better than the standard of care. And the hope is that if we use it earlier, perhaps the benefit will be more meaningful, and that is actually manifested, for instance, in the CARTITUDE-4 study that you guys very likely will be discussing tomorrow. But because the CAR-Ts still don't keep the myeloma cure, then the myeloma will come back. And that's when the bispecifics might be still needed. Obviously, the bispecifics that we're going to talk about, there are some that are based on BCMA, so if patients receive a CAR-T first, then bispecifics might not necessarily be that active when the same, that is the theory, that it might not be perhaps that active when the BCMA is used, and there are some mixing data in that regard. But we're going to talk about these antibodies first from the beginning, and the first one that I want to mention is the teclistamab, which is a combination of a BCMA and a CD3 bispecific antibody. And this is one of the initial studies where the patients with relapsed and refractory multiple myeloma were included, and this is kind of the use of the IV teclistamab and the subcutaneous form of the teclistamab at different dosages. And this is on the part 1 based on the recommended phase 2 regimen dose with the idea of treating the myeloma. And this included patients that were treated, as you can see right here, with a median of 6 and 5 at the recommended dose prior lines of therapy, so patients that were very, very heavily pretreated, and around 20% of those patients actually manifested with extramedullary disease. So this is the report from the phase 1 first-in-human study of teclistamab, showing that hematological toxicities are suspected. Now with more use of these drugs, we expect to see more cytopenias, but the presence of CRS and ICANS was something that was seen in the CAR-Ts, and that's something that we also start seeing in patients with use of bispecifics. What is the benefit of using these bispecifics is they don't have to be manufactured, we don't have to use bridging therapies, patients actually get it off the shelf and they can get it right away. But something that started emerging with this is the presence of new infections. So around 20% of patients actually presented with grade 3 or 4 infections across all subcutaneous doses, and 23 had grade 3, 4 infections at the recommended phase 2 regimen dose. There was neurotoxicity in a very small group of patients, so that's not something that is necessarily that concerning, but we started seeing novel side effects that we were not used to see with the previous drugs that we have for myeloma. This is a report from the MajesTEC-1 study, which is a phase 1/2 study looking at teclistamab for relapsed refractory after 3 or more prior lines of therapy, and you can see something that is very unprecedented in this particular group of patients, seeing 63% of responses. If you think of daratumumab, when it was approved, the overall response rate at that time was 29% of the initial study. So having double type of response in patients that were even exposed to daratumumab suggests how these drugs are very beneficial and deep in getting responses. So when you look at the responses, you can see not only that the responses are 60%, but also you can even see MRD negativity in important group of patients. The median duration of the response is around 18 months, and the median PFS is 11.3 months, and overall survival of 18.3 months. And we were talking about patients that had a median PFS of 4 months and a median overall survival of no more than 1 year. So having these results is very promising. When we look at this study, the median follow-up was around 14 months, but responses seem to happen right away. Within the first month, you can see most of the responses, and around 1/4 of patients might get into the level of MRD negativity, and in particular, 46% of patients with complete responses might have actually MRD negativity. This is a study, a phase 1b study, looking at the subcutaneous teclistamab in combination with daratumumab, and you can see that this is a very heavily pretreated population, and some people were exposed to these triplet class refractory drugs and even antibodies without necessarily being refractory. Only 60% were refractory to anti-CD38s in the past. You can see the same. The toxicity, hematological speaking, is similar to what was presented in the phase 1. You start seeing CRS in around 65% of patients, but you start also looking at infections in a more prevalent way. This is a study where teclistamab is compared from the studies on the clinical trials with the standard of care. This is an historical comparison, and as I mentioned to you, with the standard treatments that we have available for this population, you get anywhere between 25 to 30% of responses. So having the double with this bispecific is very, very promising when we talk about new drugs in this unmet need population. And then it comes another antibody that targets the same BCMA, but it actually comes from Pfizer, and this is a bispecific antibody targeting BCMA and C3 called elranatamab. And you can see the same 64% responses. You see levels of MRD negativity similar to what you've seen in teclistamab, and you can see the 12-month event-free probability after response of 60% of patients. And even patients with exposure to BCMA seem to respond. So it seems that there are different factors that might preclude some predictability of response, and there is some interesting data from our group in Calgary that actually look at some analysis, mutation analysis, and the presence of different subcell populations that potentially can predict the responses to these bispecifics. This is a phase 2 study of elranatamab, and essentially patients were heavily pretreated. You can see that around 30% of patients had actually extramedullary disease. All those patients, or most of them, were triple class refractory, 96%, and pentadrug refractory, 42% of patients, with 96% of patients being refractory to the last line of therapy. And you can see the same, 61% of responses occurring during the first month. And you see also the same level of hematological toxicities, where very mild, just grade 1 and grade 2 CRS and ICANS, but the presence of infections was also important. There are other antibodies that are also based on BCMAs, and this is one from AbbVie called ABB383, and you can see the same depending on the dose that you see, the 40 and the 60 milligrams. So when you include all patients, between 56 to 61% of responses are seen in this group of patients in the 40 and the 60 milligram dose, and the median time to response is in less than 1 month, with a duration of response rate at 12 months of 79.9% in the 40 milligram dose and 68 on the 60 milligram dose. And the PFS expected at 12 months of 56 and 48% respectively. Same toxicities as presented from the other studies. There is another bispecific called linker MN1, and there is the data here from the phase 1, phase 2 study. This is by Regeneron and also targets a BCMA, and you can see that the responses, depending on the dose, go all the way down to 75%. So most of them are moving within the 60 to 70%, and that's very promising with this group of treatments, thinking of a population that is very refractory and a population that has no more than 1 year survival expected with the standard of care treatments available until now. This is data from another antibody called alnuctamab, or CC93269, where it combines also a BCMA and CD3 strategy. And you can see responses are similar. 63% of these patients, based on the dose, less than 30 or more than 30, is around 65, between 53 and 65%, which is really, really promising. But there are other markers that we can target with these bispecifics, and one approach is targeting this marker that is expressed in most plasma cells and seems to be really, really interesting, and something that we can actually combine even with other biomarkers. I'm going to present some slides in the next few moments, but this is GPRC5D. And this bispecific antibody is also developed by Janssen. It's called talquetamab, and the study that I'm going to present here in the phase 1 is the monumental one. And you can see overall responses on the level of 73, 74% at 0.04 and 0.08 milligrams per kilogram. The median follow-up is still short, but you can see that the responses occur during the first month, and these responses seem to be very durable. The patients that do have better responses, the ones that achieve complete response, are the ones that seem to maintain the responses for longer. And the toxicities are similar to what you have with the previous bispecifics in terms of the hematological changes, but there are some other features that are appearing in terms of side effects, affecting the nails, affecting sometimes the taste of different food. And those seems to be new side effects that are more commonly seen with these bispecifics that we didn't have in the past. And there are some infections that are infections that we were not used to have with the previous treatments, and we're going to mention a little bit more about that. But there is another antibody that has been tested in myeloma. This is called cevostamab, that targets the FCRH5 and the CD3. And this is another bispecific. As you can see right here, the overall responses can go all the way up to 56.7% with a higher dose, suggesting that you can actually target not only BCMA, but you can target other markers with responses that seem to be similar. This is a slide. As I said, I'm going to make available all these slides on my 2 presentations for any of you, so don't worry about remembering of this data, but it just to suggest that all these antibodies can be seen in the myeloma field, and now we have teclistamab, elranatamab, and talquetamab approved and hopefully available soon in countries like the US, Canada, and some European countries. And that's something that we might be facing, treating myeloma patients with these drugs and learning how to make them not only efficacious, as you can see that the efficacy is good, but to try to learn how to give and deliver these drugs in a way that is feasible. These patients get ramp up dose when they start on day 1, day 4, and day 7, and then they go home and they continue the treatment. But they have different infection patterns that we didn't have in the past, and we're going to talk about some recommendations. But this is an interesting study that was presented by Mariví Mateos in IHA this year, and it's actually called Redirect TT1 study, looking at the combination of 2 different markers that are targeted by these bispecifics. One is teclistamab that targets BCMA, the other one is talquetamab that targets the GRC5D. And the idea was to sequence these treatments every 2 weeks to see whether by combining bispecifics that target different markers could potentially make it even better. So this is a phase 1b study, and the design is done in dose expansions based on the different levels, based on side effects. And what you can see is a very heavily pretreated population with extramedullary disease in 1/3 of those patients. Most of people with a median number of 4 prior lines in the different levels of assessment of the escalation doses. And most of the patients actually refractory to the prior therapy, and 80% of those actually being triplet class refractory. Hematological toxicity seems to be similar to the other bispecifics, but you start seeing a little bit more on the non-hematological toxicities. The CRS, similar to what you see with other bispecifics, around 70%, 76%, but you start seeing dysgeusia, you start seeing some skin toxicity, nail disorders that seems to be particular to the off-targets with the talquetamab, and those are the new side effects that seem to be more particular to this level of this type of mechanism of action by these drugs. So the other thing that can be a little bit more concerning is these infections, and some of these clinical trials were actually doing in patients that were very heavily pretreated, that they have immunoparesis, which is the decrease of the immunoglobulins that are not affected by myeloma. And then the questions of what can we do to improve perhaps the immune response. And one of the things that we're going to talk about is the recommendations or the prophylaxis for different infections. But you can see that the CRS is not something that is different from the use of one bispecific by itself. The responses seem to occur very fast. There are different treatments that we can use for this CRS that seems to be similar to the others, but you can see that most of the patients actually have CRS on the first cycles, and after that the CRS symptoms are less. But you still see a lot of infections that people might say, you know, we're living in the pandemic and COVID is there regardless of whether we use these treatments or not. The reality is that some people still die of these infections, whether it's COVID new, but also they develop infections in the lungs, they develop viral infections that we didn't see in the past. There are patients that we have seen in our clinics with adenovirus and other viruses that we're actually more used to seeing people treated with allogeneic transplants and not necessarily with the lenalidomide or bortezomib for the treatments that we normally use as standard of care for treatment in myeloma. So we have to learn how to prevent this, and there are a consensus that I'm going to review with you guys today, but essentially those are the things that we have to evaluate, especially when we're trying to move these bispecifics to earlier phases of the treatment of myeloma. But you see with this combination, the responses are very impressive, 86.6 with all those levels. And when teclistamab is used at 3 milligrams per kilogram every 2 weeks and talquetamab 0.0 milligrams per kilogram every 2 weeks, the responses are seen in 96.3% of patients. So very, very effective combination. The median follow-up is still short, 13.4 at all levels, and with a more matured dose escalation of only 8 months. But these responses are very impressive in a population of very heavily pretreated patients with extramedullary disease. And you can see that the responses are seen even in those patients with extramedullary myeloma, which represented around 1/3 of the patients treated right here. And this is an example. These are the slides provided by Mariví Mateos. And you can see a patient with a PET-CT showing multiple areas of involvement by myeloma, and after treatment, this is from October of 2021, and after treatment for a few months, in January of 22, this PET-CT looks way better. So within a few months, you can see a real benefit with these treatments. And as I said, what we have to learn is how to use it. Now that we know that they're efficacious, is to use it and perhaps to prevent the possible complications, including these infections. And the conclusion from the study group is that the combination of different market-driven bispecifics is something that can be done, that the combination seems to be giving the same hematological side effects expected for the bispecifics. So the combination is efficacious, and so far the toxicity seems to be similar to what you expect with bispecific by itself. But the infection issue remains as an important one, and there is a consensus by this group of people that was just recently published in Lung Cancer Journal, where some recommendations were given. That is not really based on any clinical trials, on any randomized data. It's mainly a consensus based on the frequent toxicities that we have seen. and is recommended to use antiviral prophylaxis against HSV and varicella zoster in all patients. It's recommended to screen people with hepatitis B because of the risk of reactivation. IVIG is suggested to be given for patients with these treatments, and what we call immunoparesis, which is the decrease of the immunoglobulins that are not involved in myeloma, is something that we normally see in around 93% of people at the time of diagnosis. So the more treatments that they get, normally patients actually perpetuate this cycle. Sometimes it's really not mentioned as an important thing because most of the patients with myeloma do have an IgG kappa. So when you look at the immunoglobulin G, you will see that the immunoglobulin is always high. But if you do subtraction between the monoclonal protein and the total immunoglobulins, you will see that the immunoglobulin that is left out is always lower than what you might expect as normal. And that's why they suggest that even without clinical data and without targeting 0.4 or 0.5 at the level of immunoglobulins, patients that are going to be treated with bispecifics after the first month are to receive this. And there is also another factor that occur with these bispecifics that are made of IgG kappa protein. That's the marker that we're targeting from the BCMA perspective. So there is always recirculation of the immunoglobulin. So if you look at immunoglobulin G as a potential reflection of how low the immunoglobulins are, on the first month you will see that the immunoglobulin is recirculating and it might be actually higher than it is. It might be dysfunctional, it might be just the IgG that comes from the bispecific antibody as opposed to the normal IgG that might help you fight infections. And that's why the study, even without having all this consensus, even without having real data, suggests to give IVIG prophylaxis for everyone, because they are trying to protect as much as possible people. For grade 3 neutropenia, is recommended the use of GCSF. There is no prophylaxis that I recommend for aspergillus, but I recommend to use PJP prophylaxis for all patients. So there are other targets in myeloma that potentially have to do with genomic anomalies. This is the last one. And perhaps also with excess of protein production and immunosuppression to restore the anti-myeloma immunity. And that's things that we're hoping that will potentially help us to treat patients with bispecifics better. But the main thing is to learn how to deal with the toxicity. And with that, thank you for the invitation and the attention to these two presentations.
Thank you very much. Impressive talk, as usual. So we're going to open the floor for myeloma questions. Unfortunately, Dr. Carvella will not be here to join us for questions. So can you give the mic here? So until the mic arrives there, let me start with, so induction therapy, is becoming very challenging. It used to be VCD versus VRD and things are easy. But now, I guess everybody is moving toward quadruplet, especially in transplant eligible. So the question I think I have in mind is always, in those 20% who are, they've got a possibility of cardiac amyloidosis, what would be your favorite induction?
Patients with amyloidosis?
A patient with myeloma that you've got, you have a feeling that they've got a touch of cardiac amyloidosis, the 20% that we always worry about.
Yeah, so the amyloidosis group is a little bit different, obviously, because they have heart involvement and kidney involvement, so it's a little bit more prevalent. So in the clinics, when we talk about light chain amyloidosis, we always like to say that around 10% of people might have symptomatic myeloma, but actually the Mayo Clinic come up with a separation of these three groups of amyloid. The ones that do have light chain amyloid with less than 10%, the ones that do have amyloid with more than 10%, but no symptoms of myeloma, which might represent around 40% of patients. And then the real myeloma, where patients do have more than 10% and they have symptomatic myeloma, and that may be around 20% of that group. So those are the patients that we try to treat more aggressively because the median survival for that group of people is in the range of 1.5 to 2 years. But when you see patients with myeloma, it's really symptomatic, and you expect that you have to treat the myeloma more in a chronic way. There is always the balance between the potential treatments that you have available, but trying to present or to preserve the cardiac function. So it will be important to know how much the heart is affected. And sometimes what we do, we started doing in our clinic for all patients with monoclonal gammopathies, since 2018, we're doing NT-proBNPs for everyone, whether it's MGUS, whether it's multiple myeloma. And that makes sense to be just a marker of cardiac reserve. So regardless of whether you have amyloid or not, seems to be a factor that predicts for survival, even in people with myeloma without amyloid. It's just because obviously it's another factor of frailtiness. So if you have a patient with myeloma that needs complete treatment, but the patient has important heart involvement, what you try to do is to give the best treatment, but also try to limit the toxicity. Lenalidomide, for instance, might be a drug hard to give or hard to deliver for those patients because first, it interferes with the NT-proBNP. So you might see that the NT-proBNP is high, and you might think that perhaps the patient is having cardiac progression when it might not be the case. So you have to be know about that. If you have more than 3 grams of proteinuria and it's mainly albumin, you may think that it's more amyloid, and those are the patients that have potentially a higher risk to develop glomerular toxicity from the use of lenalidomide, so it might not be the greatest drug. So there are a few things that might be hints to try to choose the best drug. Obviously, Cyborg and daratumumab is approved for the patients with amyloidosis, and that's the first ever approved treatment for light chain amyloid. So that might be perhaps a good treatment to offer in that group of patients, provided that the myeloma part is not a high-risk myeloma. So that might be actually giving a good treatment with daratumumab. Right. It might take away the toxicity from len, but it still will preserve the bortezomib as the best PI, which is very sensitive to PIs, the light chain amyloid, right, and will give you the benefit of daratumumab and trying to avoid lenalidomide. But if you have to use an IMiD, pomalidomide might be perhaps best.
Okay. So I think we've got a study in our population that they did a cardiac MR on all myeloma patients, and up to 20% they've got actually late guide enhancement, and they've got some element of cardiac amyloid. So that's always the worry. How much steroid would you give? Would you avoid IMiDs and all these questions?
Nowadays for amyloids, we don't really have to do a lot of dexamethasone. With the sub-Q daratumumab, you might be concerned about potential allergy reactions of anaphylactic reactions on the first cycle, and then after that, the great group is actually trying to use only 4 milligrams of dexamethasone when patients don't have any reaction to the first, and that is not only for people with amyloid in general, but people that do have a very high level of involvement on the heart, where 4 milligrams of dexamethasone is still a lot.
Yes.
What we do sometimes is we switch actually the dexamethasone by solumetrol. Solumetrol has the benefit of having shorter half-life. It's only 24 to 36 hours compared to 4 to 5 days with dexamethasone. Right. So this is a try by the UK group that actually substituted the dexamethasone and started using solumetrol for the stage 3A and 3B group. And the responses are the same. They are no better, but the toxicity is a little bit less.
How much solumetrol?
So that is a good question, because you may think that 300 to 500 is a high dose. That's what the UK group were doing, and that's what we reproduced. Right. So far, the toxicity was better than even 10 milligrams of dexamethasone for at that time we were using IV data. So there are a few things that you can do in that sense. The other thing that is important is if you look for amyloid, 30% of people with myeloma might have a Congo red positive in the bone marrow without necessarily having systemic amyloidosis. Correct. And the problem is, if you do Congo red in those patients, they will be excluded from clinical trials just because there is amyloid in the bone marrow without necessarily having systemic amyloidosis. So there are sometimes things when you...
Without even, subtyping it, because 24% of amyloid, of MGS patients, they have TTR amyloid. So that even makes things more complicated.
Yeah, that is also complicated because amyloidosis is associated, light chain amyloidosis is not necessarily deemed to be presence of monoclonal protein with cardiac amyloid features. People with TTR, between 20 to 30% can have MGAS. Yes. And that's part of getting older. 10% of people over the age of 80, male in particular, might have MGAS, and they can still develop TTR. Also, it's more prevalent in male, and 20% of people over 80 might have TTR amyloidosis, especially the wild type. We used to call it senile. Yes. And if you look at the bone marrows that have been done, 15% of the bone marrows might show TTR amyloid. Not because it's seen in the bone marrow means that it's going to be light chain.
I agree. Okay. So, question from the audience?
Thank you very much, Doctor, for your awe-inspiring lectures. This is just to draw your attention onto something totally different, like treatment of Ayurveda. It has a 3,000-year history. And there are learned doctors, even in London, UK, Professor Hedge, I am quoting the name also, where side effects is totally zero. So what is your take on that? How will you address a medicinal thing called Ayurveda, which has 3,000-year history?
So, you know, the treatment of myeloma, the drugs that we use obviously come with side effects, and always my patients tell us about different things, whether it's Indian medicine, whether it's alternative medicine, or things that could potentially be used. And what I normally tell my patients is, as much as there is not really any big interaction with the drugs that we're using, I don't have any problem. Whether that is something that helps is really hard to know. There are different things that we use that we're never going to have clinical trials for. We used to have a green tea clinical trial for amyloidosis that was actually negative, but the clinical trial was not performed the best way. So that is just to give you an example. So there is not going to be any clinical trials when you use the standard treatment and you combine these alternative medicines, because nothing like that is attractive, and these clinical trials are expensive. So there is no any pharmaceutical company might be interested in doing any of these alternative treatments. There is, for instance, thought about curcumin and myeloma, and there are so many things that you can do in vitro that you can add in the lab to plasma cells, and that kills the plasma cells, but not because it works in vitro means that it's going to work in the clinical day, even when you do the clinical trials properly. But that is something that is there. As I said, if there is something that doesn't have side effects and no big interactions, so we don't worry about liver toxicity. So I tell my patients that that's fine. There are some centers where they have alternative medicine embedded on the cancer centers, and actually they facilitate some information to patients that may be interested in that, but that doesn't apply to all the centers.
Thank you, doctor.
Okay, so we've got a room for one last question. So I guess I'll take that chance. So the endurance did not actually include high-risk patients. And the question it always comes from the Stanford group is, carfilzomib is probably more potent in high-risk population. What's your take on that?
So that is a good question, and it is true that when you look at the KRD versus RVD, there is no differences. The data perhaps that we can use to make that try to answer that question perhaps is coming from the Forte study where they use the carfilzomib, and actually of the data from Dr. Jakubogian in the PAC when they look at the high-risk group, and that seems to be responding more to the carfilzomib. So before this study, we used to say, carfilzomib perhaps might be a good idea for the high-risk group. But regardless of what we use, the reality is that the high-risk group can potentially do better, whether you use a more potent KRD. But if you compare the high-risk group that are treated with KRD with a standard risk group that are treated with KRD, there is always better response for the standard risk. So that is a group that we also just bunch everything together. It's not the same to have a 17P deleted patient with a real mutation on TP53 that having someone that has the 17P but there is no mutation, or having someone that was considered high risk just because it's 414 that should be considered more an intermediate risk. But the real high risk group potentially be the ones that have two or more genetic abnormalities defined as high risk, and we actually term that now ultra high risk. So that perhaps may be the population that perhaps not even the KRD might have the best responses. But there is always bunch up in the clinical trials like high risk by all these abnormalities. There are some people that look even at 1P, 1Q abnormalities. There are some centers of some clinical trials that were done when there was not really those cytogenetic data. So using those data is really hard. There is one study presented from the UK, recently published, the Optimum study that actually look at the combination with kind of a penta treatment when you do everything and you just put everything on the kitchen, including daratumumab, seems to be better. But still, if you are to compare that same treatment with someone that is lower risk, it might be actually better on that group. The real unmet need is perhaps for the standard risk is how can we avoid to overtreat people that don't need very aggressive treatments. And that's something that we sometimes lose a little bit more sight of because we try to give the best treatment to everyone, regardless of the risk. And sometimes for some people that are frail in particular, they might not need more treatment, they might need less.
And is it a function of how strong is the medication or how longer is your therapy?
So we looked at, we were doing CyberD for the non-transplant eligible for quite some time. And we recently looked at what happens with the patients that actually get perhaps lower dose of the bortezomib, but they get it longer. And those are the patients that actually have the better outcomes. They have better PFS, they have better overall survival. And that's because you know that the patient is going to respond, and as long as he's sensitive or she's sensitive to the bortezomib, it doesn't really matter what dose we use as long as we continue with the treatment for longer. So it's more about the exposure to that drug that the patient is sensitive. By minimizing the dose, we actually make the treatment longer. And that actually seems to be more meaningful than trying to get a higher dose that is not going to be able to be delivered because the patient doesn't tolerate it.
Sounds good. Well, thank you very much for the presentation, and I'm so happy to see the Kage group is leading the bispecific realm with Nizar and Paulo Neri and yourself.
They're doing a lot of work, and Nizar and Paulo just reported recently Nature Medicine on this cell changes, and that's very impressive. Yeah, thank you so much for your invitation. And
we'll be back at 3:30 for the session number 4.
To our next session, which will be a Saturday Satellite Symposium, and we'll start with a session for biologics satellite talks, which will be updates in AML classification and disease management. This topic will be given by Dr. Christoph Rolk, consultant hematologist at the University Hospital of Dresden, Germany. It is a virtual presentation.
Dear ladies and gentlemen, dear colleagues, hello from Germany. My name is Christoph Röllich. I'm a consultant hematologist here at the University Hospital in Dresden, Germany. And I'm very honored to give you my view on the current treatment of newly diagnosed patients with acute myeloid leukemia who are eligible for intensive treatment. These are my disclosures. First, I'd like to start with a couple of words regarding the AML classification. As you may know, we have two parallel classifications since last year, an update of the WHO 2022 and a new international consensus classification also from 2022. Now, whereas WHO classification is mainly based on pathophysiological considerations, the International Consensus Conference paper puts more emphasis on the clinical management of patients. You may agree with me that the two classifications are a rather painful situation, but I can comfort you at least by saying that I do think that in the near future we will have one joint classification again. And I can maybe also for the time being comfort you by saying that these two classifications have a lot in common. They agree that recurrent genetic abnormalities, if they are present, should define the AML and not blast counts or something like that. They are almost identical in their definition of genetic abnormalities. Myelodysplasia-related genetic and cytogenetic abnormalities are also mentioned in both classifications. Treatment-related AML is mentioned as a so-called diagnostic qualifier in both classifications. The AML entity with multilineage dysplasia has been removed by both classifications as opposed to WHO 2022, WHO 2016. And there is an entity called myeloid neoplasms with germline predisposition existent in both these classifications. Differences between these two classifications affect the minimum blast count in recurring genetic abnormalities. Then the blast count between 10 and 19%, which is called MDS increased blast 2 by WHO and MDS/AML by ICC. In patients with recurring genetic abnormalities without recurring genetic abnormalities and more than 20% blasts, this is called AML defined by differentiation by WHO, where it is called not otherwise specified by ICC. We have a separate entity of TP53 mutation AML in ICC, but not on WHO. And we have almost identical, but only very slightly different genetic abnormalities defining myelodysplasia relatedness in these two classifications. And the term AML, myelodysplasia related changes from WHO 2016 is now called AML-MR by WHO 2022. And is no separate entity in ICC, but is kind of subdivided into entities called with myelodysplasia-related gene mutations, cytogenetic abnormalities, or in the diagnostic qualifier called progressing from MDS-MPN. Now, this is my conclusion on the two different 2022 classifications by WHO and ICC. They both put a stronger focus on the genetic predisposition than on morphology or the blast count. And the boundaries between MDS and AML are increasingly blurred. The classifications rather have biologic prognostic implications than therapeutic implications. And because of that, treatment decisions should not be based on these two classifications, but on blast count and blast kinetics, on the blood counts, the presence of cytopenia, the clinical performance of patients, therapeutic subgroups, as I will mention later on, targetable lesions, as I will also refer to later on, and the ELL risk stratification in order to judge the responsiveness to chemotherapy and the mode of post-remission treatment. At initial diagnosis, we first have to decide whether a patient is fit for intensive curative treatment or not. And you know that we have different treatment options for these two groups of patients. And within the next couple of minutes, in the interest of time, I will focus on fit patients who are eligible for intensive curative treatment. The main determinant for response and remission in AML is the individual genetic abnormality of patients. And for this, we also have a new classification by the European Leukemia Net. It was updated also in the last year, 2022. And you can see here that the main differences is how FLT3-ITD is treated. Every patient with FLT3-ITD is now intermediate risk. We have a specification for CBP alpha mutations in the way that only BZIP inframed mutated CBP alpha is now good risk. And we have an addition in adverse genetic lesions by two very rare translocations, but also by the addition of the so-called secondary type molecular changes, secondary type mutations. Secondary and treatment-related AML mainly have high-risk genetics, and that's why their prognosis is worse than the prognosis of de novo AML. So how do we treat newly diagnosed fit AML patients? The backbone of intensive treatment still is the induction with a 7+3 intensive chemotherapy regimen, followed by either post-remission treatment with chemoconsolidation, cytarabine-based, or allogeneic stem cell transplantation. Now, this is the subgroup-specific addition or specification of induction treatment. Patients with CBF or NPM1 mutated AML should have gemtuzumab ozogamicin in addition to 7+3. FLT3 mutated patients should have midostaurin in addition to intensive chemotherapy. Patients with AML with myelodysplasia relatedness or treatment-related AML should receive CPX351, liposomal formulation of chemotherapy, whereas patients with intermediate risk should receive 7+3, and then depending on the patient fitness and also CD33 expression plus minus gemtuzumab ozogamicin, whereas for the rest of patients with adverse cytogenetics or adverse features that do not fit into either of these categories here, we still only have 7+3 induction chemotherapy. Patients with secondary or treatment-related AML have a high unmet medical need, and for a large proportion of these patients, we now have a treatment option with liposomal formulation of cytarabine and daunorubicin that is called CPX351. It contains the two agents, cytarabine and daunorubicin, in a fixed molar ratio. Due to the lipophilic properties of this drug, it accumulates in the bone marrow, which causes longer cytopenias in patients, but also less side effects in the rest of the body. So patients quite frequently don't have hair loss, for instance, as a result of this chemotherapy. The CPX351 preparation contains a lot of copper, and that's why its color is purple, as you can see in this picture. The drug CPX351 was approved based on a randomized trial in elderly fit patients with secondary or treatment-related AML who were randomized to receive either CPX351 or 7+3 induction chemotherapy, followed by consolidation treatment. Patients with CPX, here in the purple line, had a significantly longer overall survival than patients who received induction chemotherapy with 7+3. And this overall survival benefit was most impressive when patients were transplanted in first CR. So if patients received allogeneic stem cell transplantation first CR and they were pre-treated with 7+3, they had a 5-year overall survival that was low, and as you can see here, just around 20 to 30% after 7+3, whereas in patients with CPX pre-treatment, the 5-year overall survival was around 52%, which is a remarkable number. Toxicity analyses showed no relevant differences between the two treatment options, CPX and chemotherapy. You can see here that whereas rash, headache, epistaxis, insomnia, and pruritus was more frequent in the CPX351 arm, nausea, diarrhea, peripheral edema, vomiting, hypotension, and edema was more frequent in the chemotherapy arm. CPX is not given over 7 days, but only on 3 alternating days, on days 1, 3, and 5, as a short infusion. CPX is approved for patients with treatment-related and AML-MRC by WHO definition 2016, at least by the FDA and by the EMA. Now, if we look at the new classification of AML, MRC, myelodysplasia-related, both according to WHO and ICC 2022, the multilineage dysplasia as a criterion was removed. And there are more genetic changes which define now myelodysplasia-relatedness according to WHO and ICC in 2022. These new genetic changes are called secondary type mutations and are shown here in green. Based on a German retrospective analysis, 44% of patients with AML myelodysplasia related, according to WHO 2022, are only defined by the new genetic changes called secondary type mutations, whereas based on the old WHO 2016 classification, they would have not been referred to as myelodysplasia related. Now the question is, does CPX351 also work in patients who only have those secondary type mutations? We don't have much evidence regarding this question yet. So far, there are only a couple of retrospective analyses. The first is from the NCRI AML-19 study, in which high-risk patients were randomized between CPX and FLAG-IDA. While CPX351 was not significantly better in all patients, there was a subgroup analysis in patients with secondary type mutations showing a significant survival benefit from CPX351. A retrospective analysis of the pivotal trial for CPX shows slightly higher CR rates in patients with secondary type mutations and CPX, and survival of these patients with CPX versus 7+3 also looked better. So CPX is a solid red line here, and 7+3 is a solid black line here in patients with secondary type mutations. Last but not least, this small retrospective analysis in CPX-treated patients from France shows that patients with secondary type mutations have a better overall survival than all the other patients. There is quite a high number of real-world retrospective case series now on CPX351. However, they contain mixed patients populations, younger and older patients with and without secondary type mutations. So it is difficult to make a general statement based on these real-world data. But what we can say is that CPX is also working in younger AML patients. However, we still don't know if it works better than intensive chemo in these younger patients. And we also cannot say for sure whether it works better or as well in secondary type mutations as it does in other myelodysplasia-related changes categories. Okay, now let's move on from the induction treatment to post-remission treatment once a patient is in CR after intensive induction. How will we go on here? We have two main choices for post-remission treatment with different characteristics regarding relapse risk and treatment-related mortality. Allogeneic stem cell transplantation with a lower relapse risk and a higher treatment-related mortality. Treatment-related mortality, vice versa. The main criterion for post-remission treatment modality is genetic risk, with the majority of intermediate and adverse risk patients going to allotransplant if they are eligible and have a matching donor. Apart from these two post-remission options, there is no one more option, maintenance treatment with tablets. And there are different maintenance options, and I will quickly go through them with you. In patients without allogeneic transplantation, oral azacitidine prolongs overall survival based on the results of this QUASAR trial in elderly fit patients who achieved a CR after intensive chemotherapy. You can see that maintenance here, the yellow line with oral azacitidine, prolongs overall survival by around 10 months as opposed to placebo. In FLT3 mutated patients who do not go to allogeneic stem cell transplantation, oral azacitidine is also working. It prolongs both relapse-free survival and overall survival based on the subgroup analysis of the QUASAR study. Or midostaurin maintenance is another option for FLT3 mutated patients. However, the evidence for the efficacy of midostaurin in maintenance is quite low based on the design of the RATIFY trial that did not randomize again by the start of maintenance treatment, and also based on the results of this post-hoc landmark analysis showing no survival benefit for midostaurin from the time of maintenance start. In FLT3 mutated patients who go to allotransplant, there is a good option with sorafenib as maintenance post-allo in FLT3 ITD mutated patients based on this German study showing a significant prolongation of relapse-free survival and also a significant prolongation of overall survival. And not only this German study has demonstrated this benefit, but also this Chinese study. It also showed a significant benefit in leukemia-free survival and overall survival. But since sorafenib only inhibits FLT3 ITD and tolerability can be difficult, we were all waiting impatiently for the readout of the so-called MORPHO trial using gilteritinib versus placebo post-transplant in FLT3 mutated patients. This trial is was not only looking at the efficacy of gilteritinib, but also on the clinical relevance of FLT3 MRD. Now, unfortunately, you can see here the results of the MORPHO study. The trial did not meet its primary endpoint, relapse-free survival prolongation. Although relapse-free survival was longer in the gilteritinib versus placebo arm, the difference did not reach statistical significance, and overall survival was almost identical in the two treatment arms with gilteritinib versus placebo. One main reason for that phenomenon was that only patients with FLT3 MRD by the time of transplant or by the time around transplant actually benefited from gilteritinib treatment, whereas gilteritinib maintenance made no difference in patients who were MRD negative by the time of transplant. Now, with this slide, I sum up. In AML, we observe a paradigm change in treatment compared to just a couple of years ago when we treated every AML patient with just 7+3. We now have specific treatment concepts for genetic subgroups. We have CPX351 for treatment-related and myelodysplasia-related AML, with slight differences in definitions between the classifications from 2016 and 2022. And we have real-world data suggesting efficacy also in younger AML and secondary type mutations. We have gemtuzumab ozogamicin for CBF and NPM1 mutated, and midostaurin for FLT3 mutated AML. Post-remission treatment should be based on the relapse risk and eligibility for allogeneic stem cell transplantation, and maintenance with oral azacitidine for intermediate or adverse risk patients without the option for allotransplant is also a valid option, the same as midostaurin maintenance potentially in FLT3 mutated patients without allotransplant. And with that, I'd like to thank you very much for your attention, and I'm looking forward to potential discussion and questions.
Thank you for the excellent talk. So we'll have the questions at the end of the session. So we'll move to the next presentation. It's my pleasure to introduce Dr. Ahmed Al-Ataibi as a moderator of the next session. Dr. Ataibi. Dr. Ataibi is a hematology consultant at King Faisal Specialist Hospital.
Assalamu alaikum jami'an. Thank you, Dr. Firas, and thank you for organization for this nice meeting. So this is a sponsored lecture, and thank you for Stemline for sponsoring this lecture and giving me the opportunity to moderate. We'll have a lecture about BPDCN management, and our guest will be Dr. Christina Papiamedis. She's a consultant hematology. She's a trained hematology oncology in University of Bologna in Italy. She also had a PhD in clinical and experimental hematology, also in Bolgo in Italy. Dr. Christina, she had a special interest and focus in PBDCN, AML, ALL, and she had multiple publications, more than 100, and she's part of multiple committees. And the lecture will be recorded. We'll listen to it, and then we'll have the questions. Thank you.
So, good afternoon, everybody. And first of all, I would like to thank the organizers for this very kind invitation to have a talk on BPDCN in this really exciting meeting. So just a brief introduction to set the stage. BPDCN is a highly aggressive malignancy derived from the precursors of plasmacytoid dendritic cells. And the exact incidence of this disease is difficult to estimate due to its rarity, evolving terminology, and likely underdiagnosis. However, we have some data coming from US and Europe telling us that an estimated 1,000 to 1,400 cases are annually reported. BPDCN typically involves patients of middle age, and the males are more affected than female. We have also reported cases of pediatric patients. In the last 20 years, the nomenclature and classification of BPDCN changed over time. At the beginning of the century, it was called blastic NK cell lymphoma. Then in 2008, it was considered a subset of AML, and it was defined as a unique myeloid neoplasm in the 2016 WHO classification. And we are quite sure that the frequent reclassification and renaming of this disease has contributed to under-recognition. Today, we have the last version of the WHO classification, 2022, and the plasmacytoid dendritic cell neoplasms is an entity, including two subsets, not only BPDCN, but also mature plasmacytoid dendritic cell associated why very for the time. About cutaneous lesions can be different from a patient to another one in terms of size, shape, color, and distribution, and can be confused with other malignant skin lesions or also with other non-malignant skin lesions. They can occur anywhere in every part of our body. What about the path to diagnosis? What happens to our patients? The most frequent scenario is represented in this cartoon. The patient notices an atypical skin lesion in his body. Then he refers to his general practitioner or to a dermatologist. And if the dermatologist is skilled and is aware of the disease, he usually should perform a biopsy of the skin in order to understand what's happening. But I mentioned the term expertise. Expertise is very, very important because if the dermatologist waits too much, the point is that the disease in the meantime can progress. And that's why we usually see that the diagnosis is made after at least 6 months in median from the beginning of the onset of the lesion. Often happens also that this kind of lesion is not diagnosed very well because it can be confused with other hematological malignancies such as involvement by lymphomas or acute leukemias or others. A significant percentage of patients initially present with involvement of the bone marrow and lymph nodes, and as I mentioned before, other sites may include the spleen, liver, and CNS, and only in few cases, BPDCN patients may present with bone marrow disease without skin involvement. These are data from a big cohort of patients, about 400 patients recently published. Another scenario may happen when the patient presents not only skin lesions, but also symptoms leukemia-like, so anemia, thrombocytopenia, neutropenia, fever not responsive to antibacterial therapy. And in these cases, usually the patient refers to an emergency unit or directly to an hematological center. And then blood counts are performed as well as bone marrow biopsy. And again, expertise is required, not only physician's expertise, hematologist expertise, but also and mainly pathologist expertise in order to recognize that is when begin to very important to follow the patient therapeutic path. different in the skin, but in terms and pathological cells, but also some variants like lymphoid-like, monoblast-like that are reported here. In terms of immunophenotyping and immunohistochemistry, there are at least 4 antigens which are the signature of this disease: CD123, CD4, CD56, and TCL1. This has been published in the last WHO classification, and you can see here that the immunophenotyping diagnostic criteria include the expression of CD123 and 1 other PDC marker, in addition to CD4 and or CD56. Or we can have the expression of any 3 PDC markers and absent expression of all expected negative markers. But there are open issues. It could seem an easy diagnosis, but it's not true. Why? Because most markers are not exclusive to BPDCN, but we can find out them also in other diseases. And the co-expression of the 5 most common markers of patients with BPDCN. And the other point is that antigens is limited. The recommendations which have been published this year by Dr. Livio Pagano mention that the collaboration, again, of clinicians and pathologists is essential in the diagnostic process. There is not always equivalence between the phenotypic profile on tissue sections and in peripheral blood, and that the WHO markers should be used at the beginning together with others to exclude the differential diagnosis. What about prognosis? We all know that unfortunately BPDCN patients have a dismal outcome with an overall survival of less than 1 year in most patients when treated with conventional therapies, so with standard chemotherapy. We have identified in retrospective studies some factors which can be linked to a bad outcome, such as elderly age, bad ECOG score, a disseminated disease, cytogenetic abnormalities, and some others which can be predictive for a better outcome, such as the expression of CD303 or an isolated skin involvement. However, multi-center studies are needed in order to better define prognostic predictive factors associated with outcome and therapy response. And talking about therapy, I would like to start with the pre-TAG era. Before the approval of tagraxofus, and we will see the data on this excellent drug later on, there were no approved therapies for these patients and no universally accepted standard of care due to the lack of prospective trials because it's a very rare disease. So patients were treated with high-dose chemotherapy, AML or ALL-like, followed by allogeneic stem cell transplantation for those patients who were fit and young to receive this kind of approach. And which were the results? In terms of achievement of complete remission, you can see here that with an AML and an ALL-like approach, many patients were able to achieve a CR, more than 70%, but unfortunately, the duration of the CR was very, very short, and the long-term overall survival was totally unsatisfactory. That's why new approaches are strongly required. Last years is that only allogeneic stem cell transplantation can add something in terms of long-term outcome. You can see here from these pictures that only the patients who receive an allogeneic stem cell transplant have a quite long, but again, unsatisfactory overall survival. So after chemotherapy, we were totally unsatisfactory and unsatisfied, and so and it was a great opportunity to have a new drug, which is now approved by FDA, by EMA, and also by our internal regulatory system in my country, and it's also available in many other countries for patients with BPDCN in first line. Thanks to the results obtained in a clinical trial that I'm going to show you now. This was the 4010114 phase 1/2 trial, a phase 1/2 trial of TAG monotherapy in untreated and in already treated patients with BPDCN. 47 patients were enrolled and received TAG on days 1 to 5 of each 21-day cycle. The primary endpoint was to assess the CR rate. Secondary endpoints were overall response rate, overall survival, and safety profile. These were the patients' characteristics. 32 patients with a naive BPDCN were enrolled with a median age of 68. Most of these patients had a skin involvement, 97%, and 47% had also bone marrow involvement. And you can see here the excellent results in the first-line setting with an overall response rate of 77% and a median time to CR of 57 days. And the most important point from my point of view is that about 0.5% of these patients were able to proceed to an allogeneic stem cell transplantation. The median overall survival was not reached with a median follow-up of 25 months, and the probability of survival at 2 years was 52%, something totally unexpected if we consider what we usually saw with the standard chemotherapy. What about toxicity? Which adverse events may occur when we use TAG and when? We can see here in this cartoon that the most important ones are represented by CLS, so capillary leak syndrome, hypoalbuminemia, and the liver toxicity. But if they happen at the beginning in the course 1. So we know that. We don't have to be afraid because we know also how to manage and to prevent, in particular, CLS. In the following courses, the drug is very, very well tolerated. And these are the guidelines that may help us in order to prevent and manage CLS. It's important and recommended to implement albumin during all the courses, in particular during course 1. And here there are all the suggestions regarding what we have to do in the case of CLS occur. What about long-term follow-up? It has been published last year by the group of Naveen Pemaraju. You can see here that, again, the median duration of CR and CRC was 24.9 months, and with a median follow-up of 34 months, the median overall survival was more than 1 year. The importance of allogeneic stem cell transplantation has been confirmed also with this drug. Those patients who achieve a CR with TAG and then are bridged to an allogeneic stem cell transplantation have the better outcome compared to those who don't. And you can see from this cartoon that the median overall survival was 38 months for those patients who, after CR, go to a non-allogenic transplant. But the efficacy of the drug has been demonstrated not only in the setting of first line, but also in relapsed refractory patients. This is a very bad patient population, of course. And again, from the same trial, you can see in this setting an overall response rate of 58% with a median time to response of 1 month, 29 days, and the median overall survival of 8.2 months with a median follow-up of about 3 years. So very, very promising data also in this setting. And I want to share with you also the experience of the expanded ASHC program, which has been performed in Europe in the setting of first line. Again, you can see the importance of transplant as consolidation after TAG. The overall response rate of these patients treated with TAG was excellent, 88% with a CR rate of 71%, and about 50% of the patients were able to be transplanted, with a median overall survival of about 17 months for those patients who received an allogeneic stem cell transplantation. In terms of toxicity, the majority of CLS events were mild, grade 2, grade 3, and no grade 5 events were reported. So it means that we are learning how to manage and how to prevent this kind of adverse event. And this is very important because we are now more confident in the use of the drug and in the treatment of our patients. So these are the last NCCN guidelines, and you can see here that for BPDCN, in terms of treatment induction, TAG is the preferred option. And we have to take in mind that we have to consider transplant for those patients who achieve a complete remission after tagraxofusp. However, there are other options like chemotherapy and low-dose chemotherapy, in particular for those patients who are not candidate for an allogeneic cell transplantation. In terms of recommendation, again, the paper by Vivo Pagano, which has been published this year, remarks again two mainstays, in particular that the role of transplant is mandatory for those patients who are young and fit in first CR, and that a CNS-directed therapy should be given to all patients. Regarding this topic, I want to show you this paper published again this year by Livio Pagano. This is a review showing that the incidence of CNS involvement in BPDCN may be quite high, not only at diagnosis, but also at relapse. That's why intrathecal prophylaxis and therapy is mandatory for all the patients we have to treat. What about future? We are very happy for the results we have achieved with the TAG, but of course there is room for improvement. That's why there are ongoing clinical trials combining TAG with other agents, doublets with hypomethylating agents, triplet combinations with the venetoclax and chemotherapy, and we will be happy to see these results in the near future. Regarding TAG immunotherapy, we should avoid it only in those cases in which we see that the patients has unmodifiable comorbidities such as low cardiac ejection fraction or others which totally contraindicate the use of the drug. But it's not so frequently observed a situation like this. In all the other cases, we have to follow the recommendations regarding the management and the preventions of CLS and going on using the compound. So take-home messages, an early and accurate diagnosis is essential. Any delays in the time before BPDCN is recognized can mean that disease progression may have already occurred, and this is a problem. Diagnosis requires a multidisciplinary team. It's important that pathologist is skilled in recognizing this disease and in using the right antigens to make the right diagnosis. At this time, we know that CD123 is highly expressed in most cases of BPDCN, and so this is the most appropriate target for therapy, and tagraxofusp is the most important drug in this moment. It's approved by many countries, and it's the best option to induce a complete remission. What's next? We have a lot of work to do, of course. We need to improve expertise in treating these patients. We need to create multidisciplinary teams in the field. We have to identify patients quickly in order not to waste time. And we should be able, I hope in the near future, to allow more and more patients to receive a target treatment such as TAG and to improve the outcome. Finally, I just want to share with you our experience in Bologna with TAG. So far, we have treated 6 patients. The other had already red box. You can TAG a great success with you. Clinical condition to the was detected the first time not and was from the stage and the bug the very supportive observed a mild legs fluid retention in terms of reduction of plasma. We were a little bit afraid because he is a very problems at all. The first because he is 91 or relapse.
Hello. So I would like to thank the organizing this lecture. So this is about inotuzumab in real world. Does it perform at the same level or better or less than what's reported in the clinical trials? So this is a disclaimer from Pfizer. And this is my agenda. We'll go over a little introduction, then go over some evidence from real-world data and a conclusion. So this is a slide that I usually share with our students. This is the development of therapeutic in ALL. As you see, in 1948 was the first successful result with ALL. This is a complete remission achieved by aminopterin. Aminopterin is methotrexate, basically. It's antifolate. And it was a New England Journal of Medicine publication, as you see over there, by Dr. Farber, the founder of Dana-Farber Institute. So that was the first success, and then later on, new drugs came over, like adrenocorticotropic hormone, so basically steroid, 6-mercaptopurine, and then people started to combine these and found out that combination is better than sequential. And then later on, vincristine, which was evaluated as a drug for diabetes, actually, by Eli Lilly, was found to have effect on the marrow and then used in combination with the other drugs. And then we started to see some long-term survivors. Then the VAMP protocol by the National Cancer Institute, vincristine, aminopterin, so basically pump regimen. The pump regimen led to 88% complete remission rates. And then when they used pump regimen for about a year, they observed some cures. Now, when long-term survivors survived, we started to see CNS relapse. So this is how we discovered that the CNS is a sanctuary site for ALL. We need to address the CNS, and this is how we started to use ITs in these patients. And then in the 1980s, the combination chemotherapy protocols, specifically pediatric protocols, extended protocols, and ITs were all fine-tuned to achieve a level of around 80% cure rate with the pediatric protocol. In the 2000s, we got the TKIs and immunotherapies, which is one of the biggest achievements in the treatment of ALL. So here on this slide, you see the immunotherapies in ALL and the registration studies that led to the approval of these drugs. First, you see the Tower trial, which led to the approval of Blina in relapsed refractory ALL. Then the Innovate, which led to the approval of inotuzumab in relapsed refractory ALL. Blast was a phase 2 trial that led to the approval of blinatumomab in MRD positive disease. And then, of course, you know now about the CAR T cell. We have two products. We have one for the young patients and one for the older patients available on the market. So now also these targeted therapy are being used in the front line, combined with different chemotherapy backbone. Here you see the Hypercivad Blina inotuzumab from MD Anderson. Very good results are achieved with these combinations, but still we don't have labels for these indications in the front line. This is also done for elderly patients who cannot tolerate chemo, cannot tolerate intensive chemotherapy. Also very good results have been reported by MD Anderson, but still this is not a labeled indication for the drugs. Now, with the use of these immunotherapies, we learned about their side effects. So we learned about the ICANS, neurotoxicity, and cytokine release syndrome with the pure immunotherapies like Blina and CAR T-cell. And then with the ADC antibody drug conjugate like ENO, we learned about the SOS. So here in this trial done by Dr. Kentarjian, you can see the SOS incidence was 11% with inotuzumab versus 1% in the standard of care patients. So this SOS was also exaggerated in elderly patients who are younger, elder than 55 regimen. So we learned about all of these, and the question is whether real-world evidence reflects these findings or different findings. So the real-world evidence utility actually is to see when people apply these drugs in a real-time setting rather than clinical trial controlled where you have inclusion-exclusion criteria. You have to stick to these. In real-world evidence, you decide to treat your patient depends on your judgment, what's best for your patient. So this is the first study reported from US. Basically, it's from 11 centers in the United States. 84 patients were collected. So these are patients treated with ENO for relapsed refractory adult ALL and treated with a regular dosing, 0.8, then 0.5, and then if NCR, 0.5, 0.5 for the next cycles. So this is the baseline characteristics. Here you can see the median age of 50, so kind of elderly population, good performance. And you can see that around a third had Philadelphia positive or translocation 411, so the higher risk. In terms patient 25 had prior transplant, and as you see, some people were treated with chemotherapy, so ENO plus chemo or TKI. And the median cycles of ENO received by these patients was 2, and you will see this number coming over and over in the next studies. So in general, this drug is given as a bridge for transplant, and in general, people would get around 2 to 3 cycles to bridge them. Now, some people are not candidate for transplant, they'll keep going, and that can go up to 6, 8 cycles, depends on the tolerance and the disease response. So here's the result, 63% CR/CRi. So that is close to what's reported by the INNOVATE. The INNOVATE, the CR rate was in the 73% range. And of these, 36 were MRD negativity. So 36 out of 51 is around 79%. The INNOVATE trial, the MRD negativity was 80%. So pretty much in terms of efficacy matching what's reported. You can see in different categories, like in Philadelphia positive, the CR is 73%. Patients who were refractory to chemo, so they got chemo, were refractory, 60% the CR rate, and so on. So a quarter of the patient proceeded to transplant, and all these patients received the prophylaxis for VOD. So they received ursodeoxycholic acid. 2 patients died at day 100 after transplant, but not both from VOD. So we will see here the results. The duration of response is 11.5 months. As you see here, for transplanted versus non-transplanted patients, the duration of response was higher for patients who were transplanted. And here, if you want to talk about statistical significance, so they did multiple risk factors and checked if these are related to the duration of response. And as you see, if you go over the p-value, none of them was significant. So the duration of response was similar among all these group of patients. whether they were allotransplanted or not, they received the prior allotransplant or not, they were refractory, Philadelphia positive or CNS positive disease. So they enjoyed the same duration of response regardless of the baseline characteristics. In terms of overall survival, the median OS was 11.6 months, and that's better than what's reported in the INNOVATE. The INNOVATE trial reported 7.7 months as median overall survival, which can be here because of the selection. So patients are better selected dependent on the results of the INNOVATE, and as such, they can withdraw more benefit from the drug. Now, the overall survival was better in Philadelphia positive patients, as you see here, as compared to the other population. And whether the disease was refractory or not, the overall survival was the same. So refractoriness did not affect the survival. And here you can see the multivariate analysis, and you can see that Philadelphia positive patients did better than the others, as you see with a pretty significant p-value. MLL gene rearranged patients, they did not do well, okay, so with ENO. So the other risk factors, they basically behaved the same. The overall survival was the same, whether the patient has the baseline factor or not, like allogeneic transplant before ENO or CR1, CR2, so they did have the same survival. But Philadelphia positive patient did better than the others. MLL did worse than the other, and MLL is very well known risk factor for worst outcome. In terms of toxicity, so the most frequent toxicity was liver toxicity, but not all VOD. Only 3 patients had VOD, so 4%. And this is in opposite to what's reported in bigger trial, prospective trial, and this is probably reflects the selectivity. So the selectivity of the patient, the better preparation of the patient. As you know, in INNOVATE, it showed that elderly patients, patient with baseline liver disease, patient who got transplanted with double alkylating had worst incidence of VOD. So probably in real world, people select their patients and avoid these risk factors and prepare their patient, and this is why the VOD was less. As you see, the fatality was only 1 case due to VOD. So only 1 patient died from VOD. Now, the limitation, of course, is retrospective. So selection bias is built into these retrospective studies. But it reflects that the drug performs, in terms of performance, the same, and safety may be better because of the better selection of these patients. What also was impressive in this is the fact that Philadelphia positive patients do better than others with ENO, though Philadelphia positive is a known risk factor or higher risk factor in ALL. Liver toxicities were the most common, but all were grade 1 to 2, except 1 patient, as we alluded previously. So this is the other trial. This is kind of economic trial. So this is comparing ENO to FLAG-IDA. As you know, FLAG-IDA is one of the salvage regimen in ALL. So this trial compared ENO to FLAG-IDA. What they did, they reviewed 40 consecutive cases who received ENO or FLAG-IDA, so relapsed refractory ALL, ENO or FLAG-IDA, and they compared the economic impact of the both approaches. As you see here, this is the baseline characteristics. Age was little higher in FLAG-IDA, 23 years old, the median age. Disease status, as you see, more refractory cases in the FLAG-IDA, but more cases received 3rd and 4th line therapy in the ENO arm. In the FLAG-IDA, the majority of patients received 1 or 2 therapies before FLAG-IDA. In terms of transplant, as you see, 5 patients were transplanted before ENO on the ENO arm and 0 patient for FLAG-IDA, and that was the only statistically significant variable that's different at baseline. Here you can see the number of cycles received. Again, on average, the patient received 1 to 2 cycles of ENO, and as you see the outcomes. So you see the infections much higher in the FLAG-IDA. The inpatient days much higher in FLAG-IDA and all statistically significant. In terms of bone marrow suppression and support for bone marrow suppression, all the variables were in favor of ENO. So basically, you need less inpatient admission, you need less support in terms of transfusion, you get less infections with inotuzumab as compared to FLAG-IDA. And this is very well known factor because FLAG-IDA is very immuno and myelosuppressive. So again, this is a retrospective study and the sample size is small, so this is why these are the limitation. But anyway, it does show that you need less days of admission and less use of supportive care measures with inotuzumab. This is a retrospective study from UK as well. So again, retrospective studies of patients treated in UK with inotuzumab from 4 centers in the UK. Here you can see the baseline factors like exclusion, inclusion of the patients. Here you can see the baseline characteristics of these patients. So limited number of patients, 28 patients. And as you see, 14% were Philadelphia positive. 3/4 were in first relapse, so kind of early use of inotuzumab rather than late use. And the other impressive characteristic is the number of transplanted patients prior to ENO. So 1/3 of these patients received a transplant, relapsed, and then received inotuzumab. Here you can see the overall survival, 11.7 months, so matching the prior retrospective study and little higher than the randomized INNOVATE trial, which was 7.7 months. And as you see, the CRI rate was 69%. So this is always the rate we're getting, around 70%. In terms of MRD negativity, 14 out of 18 patients had MRD checked. And of these, 11 were MRD negative, so 79%. So the same numbers are being repeated and repeated, you know, in terms of CR, around 70%. And of the CR cases, around 80% are MRD negative. Median overall survival, 11.7 months, as I said earlier. So here's the per patient who received or did not receive transplant. As you see, the overall survival was way much better with transplant, 22.8 months versus 6.6. And on the second graph, you see the overall survival by number of relapses. And you see a patient who relapsed early enjoyed a 12.3 overall survival benefit versus 4.9 in second and further relapse. So using the drug earlier in the relapse setting would be better. In terms of safety, again, we talk always about SOS with inotuzumab. And as you see here, 1 patient died from SOS complication after transplant, and another patient died actually from SOS, but did not receive transplant. So 1 was post-transplant, was 1 prior to transplant. And as you see, after inotuzumab, around 1/3 of patients were able to proceed to transplant, so they were in remission and went to transplant, and 7 patients received CAR T-cell therapy. So again, in this sample, the treatment with ENO matched what's reported in clinical trial. Safety-wise, it looks like less SOS than what's reported in trial, and that's probably because of the patient selection and prophylaxis and the fact that these decrease the SOS incidence. So this is specifically after transplant. So this is another retrospective study. We have 2 studies, and then we'll finish. So this is a patient who were treated with inotuzumab and then got transplant. As you see here,